of weaknesses, an area that will need to be improved, an area that are missing in the system. And thereafter, we had to develop the whole system again from the scratch based on that analysis. With that regard, we had to introduce the structure for managing and governing the CHF into CHF Boreshwa, a new structure. But we also put in place the IT infrastructure that have been used to enroll for identification, for claim submission, but again for the processing and payment of facilities claim after payment. But importantly, to have a system whereby we can keep information and data of members for different use in future, for example, actuarial analysis and other important analysis for the insurance.
Maboresho ya mfuko wa afya ya jamii CHF yamekuja kwa malengo ya kuboresha huduma kwa mwanachama. Wanachama wake ni wananchi walio katika sekta isiyo rasmi, wakulima, wafanya biashara ndogo ndogo, kina mama ntilie, wachimbaji wa madini wadogo wadogo, wafugaji, vikundi vidogo vidogo vya ujasiriamali. Hawa ndio walengwa mfuko huu. Na hata ukiangalia kiwango kile wanachochangia, unaona kabisa ni kiwango pekee, ni kiwango kinachomwezesha kabisa mwananchi wa kawaida aweze kufikia mfuko huu, kwa sababu hawa ndio wana changamoto na wenye uhitaji wa huduma za afya.
Hela ile unaona kana ni kubwa kwa sababu unaitoa, lakini hela ni ndogo pale unapopata shida, yani ya kiafya, aidha wewe au mtoto. Kiasi kwamba hii hela ukiweka ndani, kesho kutaifiki. Basi nikaona manufaa kutokana na yule mtoto wangu alikuwa kiuma, naenda kutibiwa mtoto wangu mdogo alikuwa.
Mama Adija Nasolo is among the beneficiaries of the CHF Boreshwa. Her and her family are covered with this social health insurance and are able to benefit from this extensive package, like the many other 4 million plus individuals that have enrolled so far in the CHF Boreshwa. The uniqueness of this social health scheme is that it provides different possibility for people in the Tanzania to access medical care. Whether you have high income, you are low income earner or mid income earner, this package provides a solution for you. You can see that they are able to get medical consultation from the very basic services at the dispensary up to the regional referral hospitals, where some specialized services are provided.
The policy of the government is to strengthen universal health coverage, enabling everyone to have good access to quality care. And with this system in place, we can offer something with a very broad benefit package to the rural population. And so we've worked very hard with the government to ensure that the capacities are there on different levels. That means human resources are operating the system at all levels. The IT system is strong enough and the IT experts can operate the system. For example, also we just try to strengthen the IT infrastructure, that even with more people being enrolled, the system can still manage that. The approach has always been to work hand in hand in an integrated way, not doing it on our own and then handing over something.
Mfuko unaendeshwa katika mikoa 26. Kitendo cha mfuko huu sasa kuweza kufungamanishwa na mifumo ya tehama. Unaona kwamba mwanachama anatoka kona hii, anaenda kutibiwa, anatoka Mtwara, anaweza kutibiwa Kagera, anaweza kutibiwa kokote kule ndani ya nchi. Tayari tunaona tumewaunganisha wanachama wa CHF, wamekuwa kitu kimoja, wakikutana wanaongea lugha moja.
The IT system allows the configuration at different level, meaning the enrollment is done at the place where people live. And every village should have a designated person for enrolling people. Every town quarter should have that as well. And the government is also working on improving that system, make it more responsive to people. While before, enrollment was done at health facilities and basically was a passive enrollment where people needed to come and register there.
Afya ni mtaji, na kila mwananchi ana haki ya kuwa na afya bora, na sambamba na hilo lazima ifahamike kwamba ugonjwa hauna muda maalum na ugonjwa huwa upigi hodi. Ndio maana serikali imekuwa ikitumia jitihada mbalimbali na ubunifu mbalimbali wa kuhakikisha kwamba wananchi wake wanabakia kuwa na afya njema. Na moja ya njia iliyofanya kuhakikisha kwamba tunakuwa na mfuko wa afya jamii ambao unalenga sana wananchi ambao wapo katika sekta rasmi. Na kwa kufanya hivyo ni kwamba wananchi hawa wanaepukana na changamoto ya kutumia fedha za mfukoni pindi wanapokuwa wameugua. Badala yake wanatumia kadi na kupata matibabu haraka na kurejea katika shughuli za uzalishaji ambazo saidia kaya zao pamoja na taifa kwa ujumla.
Anayefuata Nasoro. Kuwa na bima ya afya naona kama nina hela ndani ya akiba, kwa sababu hata mtoto akiumwa sasa hivi ninaweza kutembea mpaka Sabasaba kwa miguu, huko nimebeba mgongoni na akatibiwa. Kwa sababu zamani kama sina hela siwezi kwenda popote, lakini kwa sasa hivi najiona yani niko na amani yani yote.
Ile meza ya pale nyuma naomba registration leo imefanyikia ndani Pale nyuma naomba utulivu kidogo Wazee wa registration we shall have the missing officer that we missed yesterday, Ali, Kebi, Henry, any of them. Henry or Ali Kebi, please. Kiongozi gani ana? Yes. Wow. So we missed the Deputy Permanent Secretary from TAMISEMI yesterday, and we have been informed that he will be coming this morning to address us. We hope that he will make it on time. He said he would be here at 8:30, so that we don't have to stop when we have started our panel discussion when he arrives. But otherwise, yeah, so. But otherwise, we are going to start our day with the reflections of what transpired yesterday. To start with, I feel like the room is too much scattered and it really doesn't attract discussion. So if once again, with all the respect, I can ask people to move forward so that we can fill the tables in front of us, please. Can we do that in 2 minutes? Dada Ongara, sijui kwa nini leo umekimbilia nyuma. Hakuna maswali huko mbele. No exams, no test.
One, 1, 2. Okay. 1, 2.
Okay, 1 2 sauti. Okay, 1 2.
So the way we are going to conduct our reflection today is a bit different from what people are used to. Mic yangu naona kama sauti haitoki. Wao mnanisikia? Yes. Instead of the secretariat to read to you the summary of what happened yesterday, we wanted to generate this summary from you guys, and then we shall complement our minutes yesterday. So what we are going to do, on your table there was a notebook, a small notebook. Take one piece of paper and a pen, and then I'm going to give you some exercises, and we shall use that as the summary of the reflection of issues and events that happened yesterday. So what we're going to do, I'm going to demarcate and allocate different groups of people to reflect on something. For example, because you are representing your organizations or institutions, so tell us one key message that you are going to tell your colleagues at workplace that, oh, I attended this workshop and we had an honor to be addressed by the ambassador from Switzerland, and this is one key message he said. Can you do that for me? Okay. Yeah. And then here, these two tables from Professor Meshaki to my sister here, one key message from the Minister of Health representative who represented the permanent secretary. Do you remember that? Look at the program and you shall remember what was said. Okay? Yes. Very quick. That should be 2 minutes exercise. Amekuja. Okay. Yeah. And then this row, please tell us what do you remember as the key message that came from Dada Chaula. What did she say yesterday? One key message. Take a piece of paper and write for us. This row, join with this row. One key message from Sister Chaula. This row, do you remember what Professor Meshak said yesterday? Please tell us what you remember as his comments about everything on the project. This row, do you remember anything from as a key message from the panel discussion on CHF iliyoboreshwa? Here. Can you write down, you are just one key message, that anything that you remember as a key message from the panel discussion on CHF iliyoboreshwa. You can discuss or you can write it yourself and then discuss whatever the approach that you want to use. Yes, even this row, you can write about the CHF elaboration, the panel discussion. Let's do that very quickly. Okay. Sawa. Wakati zoezi hili linaendelea, The panel discussant wa medicine supply and management should prepare themselves. Can I? Kindly we plead for a good handwriting. Yeah, exactly. Yes. Yeah. Thank you. So please, once you are done with this, pass it to your left side, and then we shall collect it from that end. Yep. "30 minutes left." 30 seconds. Sorry. 30 seconds left. Please. Mbona nyie mwandiki hapa? Who is writing? Okay. Kwa hiyo ichane weka hapa. Tutaikusanya. Pass it to your left side. Oh, yeah, your left side, this one. Ileteni kwenye, watu wa huku leteni kushoto, watu wa huku walete kulia. Nione hapa, nikusanye. Please. Gazeti. Wewe mwandishi wa habari nini? Do you have viewers here, please? Do you have viewers? Did you write? No. You don't remember that? Oh, no problem. It's okay. It's okay. Mm-hmm. Okay. On which page? Okay. All right. Okay. Okay. It's good to reflect back, yeah? Kuliko kusimuliwa kila kitu kila wakati. Thank you. You have yours? Okay. You discussed as a group. Okay. Where's the piece of paper? It was the 2 rows. Great. Do you have yours ready? Okay. All right. Okay. That's good. That's good. Moderator wa medicine ni nani? Moderator wa medicine ni Karen. Yes. So can I call upon the medicine Kengia and your team, please? Can you come and occupy your seats? So please, hello, hello, fundi mitambo. Kama sauti haitoki vizuri huko au iko sawa? Hello? Okay. So this session where we are going to listen, learn, and discuss and learn about medicine supply and management, which was one of the component of the HPSS project, will be moderated by Dr. James Tumaini Kengia from Pure Raj. Dr. James Kengia works at the President Office, Regional Administration and Local Government as a coordinator of research and publications. He's an experienced public health specialist with a demonstrated history of working in the hospital and the healthcare industry in general. Dr. Kengia is a principal dental surgeon by training, with also a postgraduate diploma in hospital management that was part of international leadership training in hospital management supported by the government of Germany through by INWENT, which is Capacity International German. He has an MBA for medical doctors from University of Applied Science, New German, and a PhD in public health leadership, majored in healthcare economics from Tokyo Medical and Dental University, Japan, under the scholarship of the prestigious scholarship and the postgraduate diploma in leadership from University of Finland, etc. His CV is very long, but we just needed to appreciate that we have a right person for this session to lead us through this process. And we are very much even more benefited from him because he was part of the project. So I'm handing over the stick to him so that he can run the session. I call upon all the discussants to observe time. We need to close this session within 1 hour. So we are giving you 60 minutes and make sure that you utilize that effectively. Thank you very much. Karibu sana daktari.
Asante sana. Thank you very much and welcome all of you in this very important forum with regard to medicine, health commodity management. May I call upon my panelists. Number one is Karin Vidamaya. Karin Vidamaya, you are welcome and have a seat in front. And Karin Vidamaya is she's a senior pharmaceutical and public health specialist from Swiss TPH. She has a background in clinical pharmacy and extensive experience in the management of medicine and global health. She has consulted in a number of consultants internationally and also in Tanzania. And also she also teaches and has published a number of publications. And you can just go to the Google and Google her name, and then we'll see what it comes. She's also a visiting lecturer also at MUHAS, apart from Swiss TPH. Swiss TPH is a lecturer there. So let's clap hands for her. So the next speaker, I call upon Dennis Mbepera. Dennis Mbepera, you are welcome in front. Dennis Mbepera, he's working with the Ministry of Health as a senior pharmacist and over 14 years of experience working in the health sector in Tanzania. Holder of Bachelor of Pharmacy and master degrees in international master's degree in health economics and pharmacoeconomics from Pompeu Fabra University in Spain. He has a number of experience, but what is important as in our discussion here, he was a key person in the establishment of the prime vendor systems from pilot in Dodoma in 2018 to national rollout in 2018. Let's clap a hand for him. So the third panelist is Matthew Mganga. Matthew Mganga, can you come forward? Matthew Mganga is also a registered senior pharmacist working with the government of Tanzania, and in particular at PORAG, coordinating as a national coordinator for bottom-up quantification and overseas intervention related to electronic logistics management information systems, including the redesigned logistics system for about 6,000 health facilities under the President Office, Regional Mission and Local Government Authorities. So he's also a holder of Bachelor of Pharmacy from University of Dar es Salaam, and also both master degrees in corporate business administrations, and also is also a holder of Master of Science in Procurement and Supply Chain Management, both from Mzumbe University in Tanzania, and currently pursuing a doctoral degree at the University of Dodoma. Let's clap a hand for him. So the third panelist is Dosdedi James. Dosdedi James, can you come forward, please? Dosdedi James, he's a regional pharmacist working at Tanga regions. He's also a holder of both a bachelor degree in pharmacy and a master degree in public health from MUHAS, Muhimbili University. He has a number of experiences working from the level of the hospital pharmacist, and now he's a regional pharmacist, the same region in Tanga. So let's clap hand for him, please. So the other panelist is Dr. Ibenzi Ernest. Is he around? I think he's missing. I will introduce if he'll come. But the other panelist, the last one, but not the in terms of priority, is Dr. Ranjit Jha. Can you come forward, please? Dr. Ranjit Jha is coming from the private sector. He's a director in Astra Pharma Limited. He's also has a doctorate degree in business management with overall over 25 years in managing operation and management in the pharmaceutical sectors. He's working with Astra Pharmacy as a director and handling the following portfolios in commodity management, the engagement with the MSD, prime vendors, all NGOs, and institution business. So all these our panelists. Let's clap a hand for Dr. Ranjit. So for starting, let me call upon Dr. Karin for a presentation. Karib-san.
So, habari sasubui. It's a pleasure to be here, and I'm delighted to present to you the work that HPSS has done in the field of the pharmaceutical sector. Now I need oh, okay, sorry. Someone help me. Just to start with, the government of Tanzania, as we know, aims to improve the health for all Tanzanians, especially those at risk, and to increase life expectancy by providing health services to meet their needs. Now, medicines and other health commodities are critical building blocks of the health system, and they should always be available. Access to safe, effective, quality, and affordable essential medicines for all is a central component of primary health care, hence of universal health coverage. Now, there is no universal health coverage without primary health care. When HPS started in 2011, what did we find? Well, we found that there were a lot of shortages of health commodities in public health facilities due to low performance of the supply chain, of the national supply chain, and also medical stores department. In fact, out of all orders that were given to MSD, only about 60% of these orders were delivered, leading to a 40% gap of medicines delivered. In other words, there were stockouts. Sorry, this is okay. We also found some other weaknesses in the pharmaceutical sector. For instance, the pharmaceutical workforce was insufficient. Accountability was weak, leading to leakage of medicines from the public sector into the black market and private sector. Supply chain management capacity was not very strong, and there was a huge problem with pharmaceutical prescribing and use and adherence to standard treatment guidelines. Supportive supervision also was not very operational. And as I said, of course, there is a huge gap in health commodity supply. So what did we build on when we started the project, HPSS? Well, there's a lot of principles and policies that we built on, obviously coming from the funding from SDC, from Switzerland. We used strategies and built on strategies and policies, the SDGs, the Sustainable Development Goals. We also built our activities on the principles of primary health care, UHC 2030, and last but not least, of course, all the policies and guidelines of the government of Tanzania, which include the National Health Policy, National Pharmaceutical Policy, Human Resources for Health Strategic Plan, then the Tanzania Health Sector Strategic Plan, it has been mentioned before, the CCM Manifesto, and PPRA Act and others. So this was our foundation. And of course, the vision of HPSS included health system strengthening. And there we know this graph is quite famous. We know that we need health technology and medicines to make a health system work. And that's why HPSS also included work on health, on medicines and supply chain management. Now we know if one of these building blocks is weak or is not working, then the whole system will suffer. Similarly to the health system, the pharmaceutical sector is also a system. And we have to remember that it's not a vertical program. It depends on various components. So what was our strategy? When we sat together with all stakeholders, discussing how can we strengthen the pharmaceutical sector, we came up with a theory of change. I will not go into detail here, but a theory of change to strengthen the pharmaceutical sector in Tanzania. And we identified 5 pathways, which are supply chain management, human resources, performance and capacity, governance, and medicine use. And these 5 pathways should optimize performance of services in the pharmaceutical system, leading then, hopefully, to improved health outcomes, which is our main goal in the end. We're a health project. We collaborate with the government of Tanzania, and we want to improve the outcome of patient care. Now, where to start? We saw quite a few weaknesses, but the main complaint became our main focus, which is out of stock of medicines. And we sat together with our partners, had lengthy discussions and brainstorming, and we came up with the idea of a prime vendor system. It's actually, by the way, registered under the name of Jazia Prime Vendor System in Tanzania. So it's a registered name. We designed and developed this pilot first in Dodoma region. It is basically a classical public-private partnership, which is complementing MSD with supplies from contracted private vendors. And the approach entails regional pooled procurement. It also entails very stringent tendering and contracting procedures for these private vendors. So very simply said, Medical Stores Department is the main supplier for the public health sector in Tanzania. Now, when Medical Stores Department happens to be out of stock, that's when the prime vendor chips in and fills the gap. Now, as you know, the pilot in Dodoma was rolled out to Shinyanga and Morogoro region. And we got some results with this prime vendor system. First of all, delivery time was much shorter from the prime vendor than from MSD. The purchase value from prime vendors increased. The performance was very good in terms of services, communication, delivery time, and even order fulfillment from these private suppliers were very good. And of course, there was a much higher availability of health commodities. Plus, transparency and accountability improved significantly. And let me show you a graph. After having these 3 pilot regions, Dodoma, Morogoro, and Shinyanga, the average availability of tracer medicines, a basket of tracer medicines, increased by over 70%. We started with availability of 53% in 2011, and it increased to over 90% in 2018. That's when the government of Tanzania decided that we should roll out this prime vendor system to the whole country. It was rolled out in 26 regions, 185 councils, over 5,000 health facilities, and to a population of over 50 million population. I don't know whether the big screen is not working. Can maybe someone, yeah, thanks very much. By now, actually in 2023, we know we have over 6,000 health facilities and a population over 60 million. So a very high population growth. And so the results today, as of today, we have covered 26 regions in Tanzania with this prime vendor system. There are more than 14 private suppliers or vendors are engaged. The average availability of tracer medicines, as I said, has increased significantly. The procurement value for health commodities from private vendors between 2017 and 2022 are about 97 billion T shillings. It's a lot of money that is provided in terms of medicines from private vendors. And the average monthly procurement value from private vendors is about 2 billion Tanzanian shillings. An additional milestone and added value is, of course, the IT system for managing the prime vendor system. It was launched just recently this year, actually, by the former Minister of State. And it's a web-based system integrated in the GoTomis. It's a digital service for public health facilities to order, receive, pay, and report medical commodities from the prime vendors, and it's accessible, this system, for multiple users. So in a nutshell, what is the prime vendor system, or the JASIA prime vendor system as we call it? It's a public-private partnership benefiting both the public sector in Tanzania and private business in Tanzania. It complements Medical Stores Department. It does not replace Medical Stores Department. In fact, if Medical Stores Department will supply 100% of and fill their orders 100%, there is no need for a complementary supply chain, which, however, is rather unlikely considering the incredible population increase in Tanzania and the ever increasing demand for medicines. Prices are fixed and comparable. Health commodities are of assured quality, safety, and efficacy. Funds to procure from private vendors come from facility-owned services, responding to fiscal decentralization. This Josiah Prime Vendor system is a system, and I insist to say it's a system, it's not just a vendor. And as we have seen, it does increase transparency and accountability because we have monitoring and evaluation tools, we have SOPs and auditing. It's a sustainable system. It's not a parallel system, but it's a sustainable system because it's based on government policies and it's fully integrated in regional structures. So in other words, staff and infrastructure is there. It's not parallel. It's not a parallel system. We have, in addition, this web-based management information system. And I think what is important is also that this adoption growth over the years confirms that there's a need for complementary supply chain, such as the Josiah Prime Vendor system. And obviously, with increasing availability of medicines, there's also improved access for patients and hopefully improved health patient outcome. As I've said in the beginning, HPSS has a comprehensive vision of health systems, not just the health system, but also the pharmaceutical system. So we know that pharmaceutical staff or human resources for staff are the backbone of any system. And I have to go back to 2011 when we found that in 94% of health facilities, supply chain management was managed by non-pharmaceutically trained staff. In other words, it was done by nurses, by clinical officers, by assistants, and so on. So there was informal task shifting to clinical staff. In other words, taking away the time from clinical patient care for supply chain management. And obviously, pharmaceutical staff shortage translates into gaps of pharmaceutical services and causes risks to patients. That's when we decided, together with St. John's University, to come up with a basic pharmaceutical course called the Pharmacy Dispenser course. It's a one-year basic pharmaceutical science course. It is adapted to the pharmaceutical skills that are needed at primary healthcare facilities. It is accredited by NACTE and the Pharmacy Council, and we were also able to introduce into the curriculum ICT skills and competencies and supply chain competencies. In addition to that, obviously, over the 12 years of the project, there was a lot of training and capacity building and planning. And there was also a lot of knowledge sharing between partners and knowledge transfer. And in fact, we counted approximately that between 2012 and 2023, over 50,000 health staff were involved in training and in capacity building and in planning of these innovations. In addition to that, and I'm very happy also to say that we were able to really collaborate with brilliant colleagues in the pharmaceutical sector, pharmacists, and that they have been given a voice also in this project to contribute to development of our vision. And you see there was a lot of training and capacity building over 12 years, as you can imagine. Now, one aspect, and I'm coming to a close now, for me, we can have beautiful supply chains, very strong, solid supply chains. But if medicines available are not used responsibly and not used correctly or rationally, the whole supply chain functions, all the investments are futile. because in the end, we want to have patients to get better. And that's why we collaborated a lot with the Ministry of Health and colleagues at the Ministry of Health, and supported the revision of the National Essential Medicine list and the National Standard Treatment Guidelines. In fact, we also collaborated with IFAKARA and the TCCIH, the Tanzanian Training Center for International Health, and conducted some clinical training based on standard treatment guidelines. Because I have to say that we did a study in Dodoma and we found that adherence to standard treatment guidelines was in only about 30% of cases, of patient cases, adherence to standard treatment guidelines was there. 30% of these prescriptions were completely wrong. So there's a lot to be done in terms of rational and responsible prescribing and treatment of patients. We also developed so-called stratified standard treatment guidelines, because the National Standard Treatment Guideline is a pretty fat book, and it is made for medical doctors, and it includes just about any condition, medical condition that you can think of. However, at the level of dispensaries and health centers, you do not need these very extensive clinical descriptions and treatment advice. So we extracted manuals and guides from the National Treatment Guidelines for primary healthcare facilities. There's one little manual, it's for dispensaries and for health centers, and another one for district hospitals, based on their diagnostic capacity, what they have as diagnostics, and based on the medicines that they have there, and also obviously based on the conditions that they see there. Now, responsible use of medicines includes antibiotics, and this is a very important topic. I just quote WHO. AMR, resistance to antibiotics and antimicrobial, is one of the top global public health threats facing humanity. And so in 2017, I'm very happy to say that together with WHO and with the Ministry of Health, we organized and conducted the first AMR symposium for Tanzania. And then it was followed by the launch of the first National Action Plan for AMR. And we currently have a second revised National Action Plan, and HPSS also contributed to the revision of this National Action Plan on antibiotics. We also supported, HPSS supported the so-called rollback anti-malarial resistance initiative, which is a young, very young and very passionate NGO in Dodoma, actually based here in Dodoma. And what they're doing, they're developing school club projects in schools to talk with children as agents for change to contain AMR, and also to promote the idea of what is an antibiotic and what is resistance to antibiotics. We also supported the World Antibiotic Awareness Week campaigns with Bajajis here in Dodoma, and then events by TAPSA. TAPSA is the Tanzanian Association of Pharmacy Students. Now, obviously, during these 12 years, HPSS, together with our partners, we have learned a lot of questions. And I just want to summarize here. We tried to harness what we learned from operational research for visibility, but also for policy dialogue. In fact, we have presented over 70 presentations at various conferences, nationally and internationally. And we have so far in this component 17 peer-reviewed publications, and more are pending. And when we talk about, innovations and interventions, I think one of the key questions, particularly when you come to the closing of a project or a program, we need to talk about sustainability. And for the CHASIA prime vendor system, we know there's evidence. The CHASIA prime vendor system is based on government policies. It's anchored within existing structures. We have this management information system integrated also in the GoTomis. We have dedicated teams at WHO, at Ministry of Health and at PROLG at TAMISEMI. It shows a high acceptability by users and actors. And just as an example of the kind of handing over of this innovation is that in this year, actually, there was a rollout for the implementation manual for the CHASIA prime vendor, including the vendor guide, M&E manual, and SOPs. And this was quite an expensive endeavor. In fact, the total cost incurred was 6.8 billion Tanzanian shillings. Now, what is very nice to see is that the majority of this cost was actually burdened by health facilities, the district and regional local government authorities. And HPSS only contributed a mere 4.5%. So in other words, there's really a handing over to TAMISEMI, to the Ministry of Health, and to the local and district authorities. Now the way forward, that's my last comment. I started working in Tanzania in 1993 with the Dar es Salaam Urban Health Project. And the main complaint I heard, out of stock. A lot of happened afterwards, central medical stores became medical stores department. There were multiple efforts to improve the supply chain, from the push system to the indent system to EILMS and so on. When we got here in 2011, the main complaint, again, I heard was out of stock. Now today, in 2023, we can say confidently and proudly also that the availability of medicines has improved significantly. Now I just want to say this, please take this innovation and take care of this innovation. It's a great foundation to improve access to healthcare, but we also know that no achievement is forever. Work continues, it's not just that's it, it's done, it's finished, it continues the work. And corruption and poor governments continue to be poison for health. CHASIA prime vendor system will have to be resilient and weather storms, all kinds of storms and changes in the health sector, because we're in a dynamic health sector. And sustainability, of course, requires continued work and adaptation of any dynamic system. And very finally, I just want to give you a few personal remarks. I have worked with partners, with you colleagues, for over 12 years now, and I've seen such incredibly hard work. And I would like to say congratulations for the progress. Really, together, we have been able to really improve, to strengthen what we had in mind. For me also, the most important factor was the teamwork. The teamwork with colleagues, with partners at all levels. And I just want to thank those of you, all of you actually, who continue to fight for strengthening the health sector. And I'd like to say Asanteni. I've also seen that there's a new generation of Tanzanians coming, of young health professionals, of students and so on. And I'm very impressed by their skills and their competencies and their passion also to contribute to the health sector. So there's a great potential here. And yes, and I just can say to finish, I'm very proud of what we achieved as partners in strengthening the supply chain in Tanzania. Thank you very much.
Asante sana. Thank you very much, Dr. Karin Vitamaya, for a very detailed presentation, ranging from the evidence generations, implementation, and policy levels. Now is the time for our discussant. Number one is we'll touch base on the policy levels. I'll call upon some comment, reflection from Dennis, from the presentation of Dr. Karin. In your opinion, with the increasing life expectancy in Tanzania, and of course the government had a massive implementation of rehabilitation and the construction of some of the facilities that might increase the need for more supplies, and maybe we need some strategies to reorganize ourselves. What is your opinion on that? How can we really, in reflection to the presentation by Dr. Karin, how can we reorganize ourselves in terms of strategies and policies? Karibu.
Hello, asante. Thank you very much. In my opinion, at the ministry, we are earmarked towards achieving universal health coverage as our main strategy. Going toward achieving universal health coverage, the government has earmarked in capitalizing MSD, so that at the end of the day, the performance of MSD get improved, and also the government is earmarked in employing more pharmaceutical staff so that they can manage all the health commodities that are procured for the facility and minimizing expiry. Also, at the ministry level, we are focusing on improving quantification so that all the facilities identify their need through bottom-up quantification, and in that need, channel to MSD for procurement, and those that are missed at MSD, the prime vendor chip in. That brings the synergy and the essence of establishing a well-improved supply chain system. Also, the government is increasing its annual budget for the procurement of health commodities. That is one of the strategy. So at the end of the day, all the population that are in need of health services are able to get at an affordable and easy way. Also, another emphasis is on the issue of tracking the use of the medicine at the facility level, from the facility to the top, so that at the end of the day we optimize the use of the available scarce resource to enable the community benefit, the strategy that the government are embarking on. Thank you very much.
Thank you very much for very well elaborations. And now goes to the PORAC as implementers, to Matthew now. In reflection to the presentation of keynote address, in your opinion, with the role of PORAC, what will be like the role of prime vendor systems? You know that we have been implementing the prime vendor systems, and what have we attained so far when it comes in the role of prime vendor systems in availing commodity in our health facilities? And also, in a nutshell, can you also comment in general what have we attained, or rather the contribution of HPSS projects to the pharmaceutical system as a whole? Karibu.
Thank you very much, the moderator. Now, based on Dr. Karin's presentation, first, the role of prime vendor system is to bridge the supply chain gap observed at MSD. And primarily, the prime vendor system is a complementary system. It only works when there is out of stock at MSD. It will die when the MSD supplies 100%. So the prime vendor system is of very significant in bridging the supply chain gap. And we have noticed from the piloting time 2011 up to 2017 in 3 regions, Dodoma, Shinyanga, and Morogoro, until when the PURAJ took the mandate of launching it nationwide. So if you go to the electronic and logistic management information system, you will notice the commodities increment from 2018 up to now. So the observed increment of commodities availability at MSC is contributed first by the MSD itself as the major supplier for the health facilities, and also by the prime vendor system. So to my opinion, the prime vendor system has bridged what we saw in the holistic review supply chain gap of 2017. Now coming up to HPSS, everybody will agree with me that the prime vendor system is an innovation of HPSS. And it came as a project 2011 up to when the government adopted it as a government system on 2018. So this is purely an innovation that came up with the technical and financial support from the HPSS. And we have several publications that are worldwide recognized that the prime vendor system has worked and it has successfully bridged the supply chain gap. Now coming to the last question the moderator posed to me, to myself, I may align with what Dennis has said on the 3 interventions that the government now need to work it properly. The first one is bottom-up quantification. The second one is medicine audit. And the last one should be the supply chain data used for decision making. So if you go smoothly and implementing these 3 supply chain initiatives will actually strengthening the presence of the prime vendor system that has proven on bridging the observed supply chain gap. Thank you very much.
All from the level of the ministerials. Let's give them a big round of a clap. Matthew and Dennis. So now let's deep dive a bit. Let's go deep dive a bit to the level of the implementations, and we'll have a 3-tier implementation level. Number 1, we've been just joined by Dr. Ibenzi Ernest, is a director, hostel medical officer in charge of Dodoma Regional Referral Hostels. Karibu sana. So you have come to the right time. Now maybe you comment a bit. We know that the government have had a lot of investment in terms of diagnostics, human resource for health. We have a number of specialists at the level of regional referral hostels. Can you comment that with that, maybe there might be some increase in health commodities needs? What should we do on that in order to have a balance? Karibu sana.
Asante. Thank you very much. I would like to comment on what has been done with the government on the issue of investment. Actually, if we go in detail, the science and the medicine are so dynamic. Today, what we have, we can think that now maybe they are enough. The big deal now, if you want to match with what has been done with the government. However, yes, the government has done a lot. The HPS, the long term of health promotion and the strengthening system, also has done a lot. So in order to move it, the big deal is to move the science and technology. Yes, you have in the issue now of the medicine supply and the related health commodities. Actually, the availability countries it is good, but the problem now it's coming to the part of antibiotics.
the antibiotics now, there's a lot of emerging resistance. So the health system at large in Tanzania, maybe again it must deal much with the antimicrobial resistance. Also, we tell us what are actually required. Again, the database evidence. What are the diseases we have? What are we dealing with the community pattern of disease? Also, will tell us a lot what we need. Sometimes we procure a lot of the health commodities, but if you go in detail, maybe most of them, they are not needed for the treatment or such emerging disease and what are already existing in the community. So the database evidence, we do research, then what will tell us what to do, and we'll be operating in the line with the database evidence.
To the level of the regions, karibu sana Deus. Deus is the regional pharmacist from Tanga. In your opinion, we had a lot of discussion here about the private vendor system. Can you reflect in terms of what is happening in the level of the region and facility levels? Does PVC help a bit in terms of improving those commodities in your perspectives? But also comment a bit about in terms of the capacity being to our staff, the pharmaceutical staff. Karib.
Thank you, moderator. Allow me to extend my sincere gratitude to the HPSS team for their extensive and tireless efforts in strengthening the Tanzania health system. As we approach the universal health coverage, it's important to understand that every single intervention that increase or stabilize the availability of health commodity, it's of great value to us. Medicine audit and prime vendor systems are equally important in this case. And the two interventions are distinct from each other, and actually they have, I would say, different sets of implementation approaches, but they all contribute to the sustainable availability of health commodities at health facilities. The prime vendor system has contributed to the physical availability of health commodities by bridging the gap to the service delivery points, and the commodities are delivered timely, as it has been observed with the presentations that we saw yesterday and this morning. The commodities have been delivered timely, but also reliable quality, but also I would say of affordable price. Now, speaking of affordable price, I know there have been a debate on the affordability of the prime vendor prices, but we know those prices are fixed as compared to the actions that were happening before the introduction of the prime vendor system. But also the fact that the prime vendor system operates in a transparency mode has helped a lot to improve the operationalization of the supply chain system. Coming to the medicine audit, it reinforces the accountability to the supply chain system. It's important to understand that, speaking of medicine audit, of which we now call health commodity audit, to include even the auditing of the medical equipment and their functionalities, it does not merely look at the validation of consumptions of health commodities. We go further looking at the individual components of the supply chain system and their functionalities. For example, we look at the availability of guidelines, tools for documentation, as well as the documenting systems which are electronically made. With regards to the pharmaceutical capacity buildings, steps have been made. I'll give an example from my region in Tanga. I remember in 2013, we had only 8 pharmacists, in which one was at the regional level, 2 allocated to one of the districts, that was Tanga City Council, and the rest were distributed across 10 councils by then. So we had 5 councils with no pharmacist, completely no pharmacist. As we speak today, we are very happy that at least we have around 63 pharmaceutical personnel, 63 in a region, including across all levels. But also among the 63, 26 are pharmacists working in 9 of them being located at the regional hospital, and the rest distributed across the country. So there is much improvement, and this can be proved numerically. Thank you.
Asante sana. Thank you very much for that elaborations. Now, our last but not least person that will comment on the presentation of Dr. Karin is Dr. Ranjit, who is also coming in the private sector. In reflection to the presentation and all the discussions from the panelists, what is your opinion in terms of the role of private vendor systems in the context of the private sector? But I understand that there might be some unfinished business from your perspective. Can also you comment about them? Karim.
Thank you so much, sir. Hello. Hello. As we have discussed yesterday and today also, that this prime vendor system is in one of the excellent projects which was rolled out in 2011, and it is carrying on till now, which bridges the gap between the MSD and the facility, the goods where when the MSD is out of stock, the prime vendor comes into picture and stock in. As far as prime vendor is concerned, I have 2 suggestions for this project. One is that there has to be some policy where, since now the entire prime vendor system has been decentralized, so there has to be some policy where the policy should insist all the region to follow the same uniformity, which we are seeing that there is some gaps. Like in the earlier stage of the prime vendor selection process, some of the region has followed the different method of selecting the prime vendor. Secondly, we should have also the time to time some kind of review, revive and reform policy, which will also improve more on prime vendor system. Thank you.
Thank you very much for that short comment, but very, very important. Now it's time for us, the audience, in reflection to all the panelists. If there's any questions or comments, I would like to take 3 people because of the time. You can just raise up your hand, please. Anyone with a comment or question? I give you numbers. Number 1 there, Professor. Number 2, where? Here. And number 3, here, Doctor. Oh, we start with number 1, Professor Sen. Karibu. Please, mic to him, Professor Sen. In the left there. A mic to Professor Sen, please.
Thank you very much, Dr. Karin, for your nice presentation, but also the panelists. I just want to go straight to the point. It's well articulated that availability of medicine is a prerequisite, and it's like a surrogate marker to indicate the health services are, adequate. I just want to add 2 important things. Apart from the data that you have presented, like the availability of medicine has significantly increased, that's a very positive finding. But also the stock out have also significantly decreased when you compare like 2012 and 2020. So I just want to add 3 more things which are also pertinent when it comes to what HPSS has been doing for the past close to 12 years. So number 1, if you compare, for example, patient indicators, for example, the time spent between the, doctor and patient, the contact time, this has also significantly increased. For example, if you compare the baseline data in 2012, the contact time was approximately 4 minutes. And if you compare it now in 2020, it has actually doubled. So that means the doctors are spending more time with their patient. But also if you look on dispensing time, it has also significantly increased. And the last one, if you look also the time people spend from their place of domicile to the healthcare facility, this has also significantly decreased. And this is certainly due to, more construction of healthcare facilities across the countries. And, if you compare, for example, the 2012 data, people are spending like maybe hours maybe 2 hours to reach their district hospital, more than an hour to reach a dispensary. But you're talking of, if you compare, for example, the 2020 data, the time spent for people to move from their houses to the healthcare facility has significantly decreased. We're talking of less than 50 minutes. And at the level of dispensary, it's actually close to just less than 30 minutes, someone is already at the healthcare facility. So much as we are pressing to the medicine supplies, availability of medicine, but also we are seeing these other pertinent indicators which have also been shown to increase significantly. Let me finalize by saying we are also happy that the Health HPSS project has also significantly contributed to the implementation of our National Action Plan, both the first line from 2017 to 2022, and also the second version of our National Action Plan on the AMR from 2023 to 2028. And it has actually contributed in all 4 strategic objectives, from awareness, stewardship, IPC, as well as antimicrobial stewardship. So I think we are very, very grateful to your contribution. And we keep on looking forward to keep on working with you as we keep on supporting our government and the people of Tanzania. So thank you very much.
Asante sana. Thank you very much. Mic to number 2. Those were just comments. I think they've been taken by the Secretariat. Number 2, karibu. The number 2 mic.
Good morning, I'm Kai Schröder-Pohl of the GIZ. Thank you very much for the presentations, and congratulations to the great successes that you were able to show us today. I was particularly interested in the area with medicine or the health commodity audits, and whether you are integrating that with community oversight mechanisms, health facility boards and governing committees, if the communities have a role in that.
Thank you very much. That will be responded. Now to number 3, Mike, please. To Dr. Mboasi here, number 3, Mike. And then the ladies, get prepared. I have one chance for the ladies. Doctor,
Yeah,
thank you.
Great appreciation to Karin for the extensive presentation and the discussion panel. I have 2 issues. One of them is on prime vendor system. When the prime vendor system was established or piloted, a very strong bidding system was built, which took into account a high level of transparency in appointing the prime vendors. And that is the core of the prime vendor system. My current observation is that there has been some shortcuts in terms of comprehensive transparency in selection of prime vendors. And that has led to some of prime vendors being awarded and not being possible to supply. So the system is good, but if we try to avert the basic principles in selecting prime vendors, then the system will run up into a problem. And I think that is very critical. The due diligence should be done very thoroughly, because if you select a prime vendor who's not capable to provide the necessary supplies in time, then the whole purpose of supplementary supply fails. So that's very critical. The second, prime vendors, the supply from prime vendors with the current requirement of WHO and the government to have a quantification on consumption of antimicrobials requires now a precise data of movement of products of antibiotics from prime vendor to the public sector. because then that we will be able at the end to quantify the consumption at private sector. The data is not correct. If data is not correct, then we still have a problem of our data, WHO, because we might have a large consumption in the private sector, while at the same time some of the products are coming back into sector. Quantification of antimicrobial consumption, we use import data, central, but then it is imported, goes to the private, but comes back to the need of the suppliers. With the, we'll be able to extract this data at the end so that we can get the correct quantification for antimicrobial consumption. Thank you, sir.
Asante sana. Thank you very much. That one, Dr. Mbwasi. Now the last is Dr. Ongara, representing the ladies. The ladies are quiet. Let's have a comment or question from Dr. Ongara. Mic to Dr. Ongara there.
Thank you very much for the nice, good presentations and the panel discussion. Mine is, I know that we are having a PPP policy in the country, and I thought that Jazia is one of the examples of public-private engagement, public-private sector engagement. But I heard from the discussants that you are going to stop Jazia prime vendor system when MSD reaches to 100%. I would like to know what are the reasons. Instead of strengthening private sector engagement, you are going to stop Jazia prime vendor system. And Jazia prime vendor system is the one which made us have availability of commodities in the health facilities. Thank you.
Thank you very much for such a very nice questions. So now back to my panelists. Just half a minute, please. We are short of time. I think that one, the last question will be responded by Dennis, and the regional pharmacist should prepare to respond for the medicine audit issues. We are starting from here, from Karin, just a minute of saying something, and then we'll move from there. Then continue, Dennis. Yeah.
Okay. Thank you for the nice comments and the suggestions and questions for the for our session. I'll respond to Dr. Ongara's question regarding what my fellow just said, that when MSD reaches 100%, 100% availability of health commodities, the private system will stop. That he doesn't mean that it will stop. It will be there. MSD and prime vendor system works in synergy. When one is having less, especially MSD, then the prime vendor chips in. So when it comes, MSD has all the items the facility needs. Similarly, the prime vendor will not get order, but it doesn't mean that the system will not be there. It will be there waiting for the insufficient of commodities from MSD in order to fill it. Also, for comments raised by Seni and Dr. Mbwasi, they are so relevant to this session. And as you can see, the government has put in place so many health facilities in villages and some wards, just to make sure that the distance covered by the patients from their home to the facility is short. And my colleague will continue with the other responses.
So the regional pharmacist, maybe could you respond upon the issue of medicine audit raised by the GIZ? Oh, you start, okay, Matthew can respond. We are short of time, so please, Matthew, you could respond on that.
Very quickly, to Dr. Ongara. The prime vendor system, I want this everybody here to understand. The prime vendor system is a complementary system. It's only there to complement where there is a deficit at MSD. So if MSD has supplied 100%, the designing of the system allows prime vendor system not to work. We are not destroying the PPP, but better we understand the designing of the system. Now, coming to the question of audit from the GIZ representative. PureRaj has issued a circular on 2021 on commodities management should involve all sectors from the community, the council level, the regional, everybody has his role on commodities management, including the medicine audit. I know that the GIZ has done its work through Sikika on Mbeya and Tanga region. They have capacitated the health facility governing committee on managing various aspects in health, including medicine audit. We will also propagate it. We will also make sure that all regions also adopt what GIZ via Sikika has done on Mbeya and Tanga. Now coming to the question of Dr. Mbwas. Yes, antimicrobial quantification is part of the normal quantification which is done to our commodities. Now your advice is taken with respect to specifically antimicrobial commodities. And this should be taken by Dennis, because Dennis, the Minister of Health is the one with the ELMIS ownership. So whatever we are going to do, we need to get a permit from the Minister of Health. So let it be as an advice to the ministerial sector.
Thank you. Thank you very much. We've just almost to the end. The time is off. Thank you very much, my panelists, for all the comments and, of course, the keynote address from Dr. Karin Biedermeier. Just to summarize this forum, we had a chance to discuss about our journey with the HPSS, a 12 years journey. So we started with some gap in medicine availability, but here the evidence showed that through the PVS, prime vendor system, we managed to complement the MSD in terms of availability of medicine. Of course, Professor Sen mentioned about some other spillover effects in terms of some of the indicators. That is also noted. But what is critical, it was mentioned by Dr. Karin here, the teamwork approach, participating together with the government and our partner was critical to the success. Of course, the budget issues that also from the government was also important. But last thing, but not the least, the issue of rational use of medicine is also very important. And of course, that goes parallel with the data use for decision making and the issue of medicine audit. Thank you very much, Asanteni sana. Let's give a big round of applause to the panelists. Asante sana. Back to the moderator, Sulemani.
Thank you once again, Dr. James Tumaini Kengia, for moderating this session, one of very important component of the HPSS project. And I believe that the audience has benefited quite a lot to reflect on the various issues regarding the medicine component of the project. And we are hoping that the resolutions and the recommendations will be worked upon, particularly from the government side, so that the investment through this project is not wasted. I have a short announcement. Quickly, the following people are required to submit their IDs to the registration desk. Dennis Mbepera, Esther Nicodemus, Laurian Mtwale, Nebon Rumbeli, and Shadrach Stephen. Please make it a priority so that the registration desk can finish their work as required. We have been informed that the Deputy Permanent Secretary, Hethi, from PORAJ has arrived, and therefore we are going to provide time for him to address us very briefly. And once we finish with his address, we shall go for breakfast with him, and then we shall resume our program after tea break. Just remember that our tea break is strictly half an hour after that. Ali, karibu tumkaribishe mgeni wetu.
Dr. Charles Mahela, naibu katibu mkuu ofisi ya Rais TAMISEMI anayeshughulikia afya. Ndugu washiriki, wageni mbalimbali mliopo, habari ya asubuhi. Jamhuri ya Muungano wa Tanzania. Asante sana. Bila kupoteza muda, naomba kuchukua nafasi hii to invite our Deputy Permanent Secretary to address us today. Mkuu, karibu sana.
Good morning, ladies and gentlemen. I greet you in the name of the United Republic of Tanzania. Okay, I'm here I was supposed to be here yesterday, but due to inevitable circumstances, I was out of Dodoma, so I could not manage. Then I came around actually early this morning. Then I said it's better I come here before I go to the Parliament Committee. There we have some sessions. But we understand that you have been here discussing relevant issues on HPSS. So I have got a few things to say here. I hope protocols observed, because yesterday I think there were many people who were supposed to be addressed here. But on behalf of PORAJ and on my own behalf, as Deputy Permanent Secretary, PORAJ, responsible with the health, social welfare and nutrition, I'm profoundly delighted to be invited to participate in this very important health promotion and the systems strengthening project closing workshop. My thanks and congratulations go to all of you who have participated in one way or another in the conceptualization and execution of activities related to this project, and for the coordination of this particular workshop. My special thanks go to the Swiss government for ongoing support, to the people of the United Republic of Tanzania in different social and economic development initiatives geared toward attaining of sustainable development goals. You as Excellency Ambassador Didier Chisoti, please convey our heartfelt thanks to the Swiss government. Distinguished delegates, ladies and gentlemen, it has come to my attention that since 2011, the Swiss Development Corporation, through the HPSS project, has been a crucial partner in supporting Tanzania. The support has spanned various initiatives, including health systems strengthening, enhancing health commodities availability through innovations like the prime vendor system that we have been discussing even recently, health promotion, health technology management, and health financing, notably the establishment of institutionalization of the improved community health fund ICHF. In the informal sector, that has been significant milestone. I extend my deepest gratitude for your remarkable support, starting from the pilot phases in Morogoro, Shinyanga, and Dodoma, to the nationwide rollout. We commit ourselves to ensuring the success and the continuity of all activities supported by the HPSS project. Distinguished delegates, ladies and gentlemen, over the past 5 years, the Tanzania government, in collaboration with the partners, has made substantial efforts to enhance the primary health care systems in the area of, in the aspect of construction and renovation. The government has invested a lot. There are so many new dispensaries which have been built and also rehabilitated. So many health centers which have been constructed, and so many district hospitals. And not only construction, but have been equipped with sophisticated facilities. So this includes the construction, rehabilitation, equipment of healthcare facilities, as well as recruitment of diverse range of healthcare professionals. Nevertheless, there is much work need to be done to further improve health responsiveness, equity, resilience, overall services quality in the progress toward achieving universal health coverage. Still, much need to be done, because we have actually increased the number of health facilities, but that has also resulted into shortage of, for example, human resource, and a shortage of health facilities, shortage of medical equipments. But with your support of the prime vendor system, as you have seen out, it has helped to lessen the time for stock out of stock. But it has worked as a complementary between MSD, which has to some extent has been also a problem in providing timely provision of medical equipment and the medicine. But with the prime vendor systems, it has helped to improve, as you have seen. So we promise that it is important that we sustain it, for it to be there as a complement, especially when MSD is having out of stock, then this one comes in. But you have seen that primary vendor systems has also helped to reduce the time, because when it is out of the stock, then we quickly go to within 24 hours, we get those facilities from prime vendor systems. So it is a good achievement. So despite all the efforts that have been made together, the important work remains to be done to meet the challenges of our healthcare systems. Our health systems continue to be overwhelmed by increasing burden of diseases. Infectious and non-communicable diseases kept on rising, and the recent threats in emerging and re-emerging diseases. A call for action for strengthening promotive, preventive services, integration of services, intersectoral collaboration, health insurance schemes, and the centralization of screening services at the primary health care for early detection and the treatment is inevitable, while strengthening the evidence-informed policies that will make health systems responsive and resilient in the stride toward achieving universal health coverage. And with this note also, we are glad that the Tanzania Health Summit, which took place recently in Dar es Salaam, was very, very relevant. And it was at this time, it was on the theme was strengthening systems of UHC, focus on primary health care, and where PO largely is responsible for that. So, ladies and gentlemen, it is evident that all critical gaps, including health systems gaps, need joint effort through partnership. It is important that all stakeholders for the health, social welfare, and the nutrition services share a common vision of the challenge and the opportunities, so that we can together prioritize areas in which to intervene to accelerate the implementation of health social welfare, and the nutritional services related to sustainable development goals. As I'm coming to the end of this speech, I would like to express my heartfelt gratitude again to the Swiss Development Corporation through the HPSS project for their unwavering support, but you have also been supporting Health Sector Basket Fund. I also take the opportunity to request further support from the Swiss government to continue assisting the United Republic of Tanzania in achieving the Sustainable Development Goals. Moreover, I urge all regions and the councils to establish or to ensure the sustainability of the project activities through integration and collaboration with other implementing partners. Because for us, this support actually is in line with the strategic implementation plan of the PO Large, especially the Division of Health, Social Welfare and Nutrition. So we still request for support to continue supporting actually in the following areas. For example, ICHF is going to continue. The 2 days ago in Dar es Salaam meetings there were meeting going on, but I think ICHF is going to also to be part of the scheme that is going to come. So we want to support the process of redesigning the scheme to fit into the UHI framework. Specific areas that we request for support is establishment of the institutional structure, but also enhancing the ICT systems and the capacity development. Number 2, for the prime vendor system, as you can see now, a significant number of health facilities has increased. So we still need support, especially as you have heard also from some of the stakeholders, the challenges that are there in awarding prime vendor system, also in their functioning. They are not 100% perfect. So we still need the analysis of its performance to determine systematic areas for improvement. And when it comes to issues of medical equipment repair, so we have constructed and rehabilitated, we have done rehabilitation and the construction of new health facilities, but also equipping them with medical equipment, very expensive one, to the level of health, to the level of dispensaries and the level of health centers. And actually last month, the government disbursed the 27 billions to the lower level. And this month, September, 55 billions, implementation of the current financial year budget. And that money is for equipment, purchase of equipment to the dispensaries, health centers, and district hospitals, but also construction and rehabilitation. So those equipment are very expensive. The government has spent a lot of money to purchase them. The government has tried to has recruited the biomedical engineers, but the challenge that we have, these are newly, some of them graduated students from universities, and they need to be given in service training. So you find that when there is a breakdown of some of these facilities, they take longer to be repaired. So we think that we need, and these things, they stay longer, so the purpose for which they were purchased before, then they don't function. So it is important that they are repaired. So that, and those biomedical engineers have to be trained. So in this area of medical equipment repair, we still need capacity development of engineers and the technicians, establishment of workshops with the tools. We have some of the workshops that have been established with the regional referral hospitals because we work as a sector with the Ministry of Health, but still we need capacity building to that aspect. And the management of training of still, because now we need to build capacity to RHMT and the CHMT throughout the country in all councils, so as to be able to supervise and coordinate the implementation of various interventions in the region, in the country. But again, with the Ministry of Health, When it comes to UHC, the Ministry of Health and the PO Large, we are now working closely to come up with the systematic and the standardization of community health workers in the country. We think that is a way to go. And this actually was also a message there to the WHA 76, that UHC, the way to go is also to invest in community health workers. So we are working on that, we are working on the curriculum to come up with a system whereby we are going to recruit almost 153,000 385 community health workers for the coming 3 years. If at all we are going to get support from other stakeholders, and the government is really committed, we want to recruit in each year. For example, the year from 23 to 24, we want to recruit 51,291 community health workers. And the year after next year, 51,292 community health workers. And finally, 51,292 community health workers to be identified, nominated, recruited, trained. So we want to avoid the fragmented way of community health workers. So we want to, the curriculum is being designed and developed by the Ministry of Health. So the total amount of fund that is required is almost 1.1 Tanzanian trillion shillings to recruit those community health workers. And we think that will help also to strengthen the systems, especially when it comes to issues of health promotion and disease prevention. And that will help us a lot to the strengthening of the primary health care in Tanzania. So that is one area that we think also we will need support. Distinguished delegates, ladies and gentlemen, the government is excited about this collaboration, and they will remain committed to the supporting the efforts of the healthcare stakeholders. As you can see, especially the current sixth phase government led by Her Excellency Dr. Samia Suluhu Hassan has invested a lot in the health systems, financing the health sector, educational sector, and especially when it comes to health sector, the issue of nutrition. She's also supporting it a lot. So because we want to make sure that we fight the stunting rate, to reduce it down to below 22. So I'm certain that this meeting will deliberate on strategic and operational issues for the development, for developing further our partnership and the contribution to the betterment of health, nutrition, and the social welfare. And actually, we have one of our strategic objectives we want to enhance good leadership, strategic partnership. So this is one of the strategic partnerships. So that is our strategic objective. So the partners that are there, we want to continue working with them. But there is another strategic objective is to make sure that we enhance communication and information systems for health. And I've heard that within these 12 years of this project, you also helped us a lot in ICT, but much needs to be done. So I want to assure you that PO Large will carefully consider all the recommendations from this workshop and utilize them to sustain project activities. Thank you, and God bless you.
Dr. Maela, tunashukuru sana kwa a very good address, and also some information that you have shared with the meeting today regarding CHF, and other information that you have provided through your remarks. We take note of those, and we appreciate very much cooperation that have been rendered to us by PORAG throughout the period of the HPSS project. We shall continue to implement the remaining activity to do the handing over in the next 14 days. And we do hope that all the capitalization document will be forwarded to your office for referencing and for strategic continuation of the intervention that we have implemented together. We thank you very much. Having said so, I would like now to hand it over to our facilitator, Ndugu Selemani. Karibu.
Asante sana Dr. Mahera, mimi nimekuwa nikikusikia tu. I didn't know that you are such a wonderful speech deliverer. Kwa hiyo tunakushukuru sana. And the best part of your speech is not just showing what the government is doing, but also identifying areas where we can work together. And I think that is a strong point, because as we close this project, we really need to know where to strengthen. Asante sana. Sasa ili kuonyesha kwamba tunakushukuru vizuri, you were not scheduled for breakfast today, your share was yesterday, but we invite you for breakfast. Kwa hiyo tunaomba utuongoze, unyanyuke, utangulie, ili na wengine nao tukufuate nyuma twende kwenye chai. Asante. Half an hour breakfast, please. So kama wajana. All right. So jana tulifanyaje vile? Tulikuwa na grupu. Yes. So the embassy, please. Maybe we can combine the embassy and the project management. Yeah. Yeah. Can we do that quickly? Wakati tunajipanga kwa picha, I would also like to take this opportunity to recognize the presence of His Excellency Dr. Harun Machibia. Dr. Machibia, tafadhali simama tukuone na uwapungie wananchi, maana jana tulikumisi. You have a special history. Dr. Machibia was DMO for Morogoro Rural when I started working for the first time in 1998. Alinipokea nikiwa kijana mdogo, research assistant. Hata sijui system za afya zinaendaje. Today I lead him. Thank you for the knowledge. Some people have shortage of money. For us today, we have shortage of time. Tuharakishe. Okay. Fine. Usinyanyuke Ali. No. The high table people, you need to be seated. Another round. Waondoke tu waliosimama nyuma. Tunaomba viongozi wetu wa ngazi ya mkoa, kama bado tuna marasi, kama tuna RMOs, kama tuna naona pale Dr. Daniel Nkungu, please njooni tupige picha na mgeni wetu. Na Wizara ya Afya, viongozi wote wa serikali kuanzia ngazi ya wizara, mkoa, wilaya, please. Dr. Ongara njoo kwa sababu ya PPP. Njoo tafadhali. Pole. Haya, karibuni sana. Yeah. Wapiga picha, saidieni kuwapanga hawa wazee wetu ili zoezi liende haraka. Kuna watu wafupi kama dada Ongara anataka kukaa nyuma, hajui maana ya picha. Yes. Okay. It's a ceremonial closure of the project, so we need smiles. Great. Tayari? Okay, thank you very much. Let's rush to the breakfast.
na mimi sikuzoea, sitaweza kuliacha kwa sababu yako. Wanambia niliache nyumba, na mimi sikuzoea, sitaweza kuliacha kwa sababu yako.
Nakwambia uliwache nyumba, na wewe sikuzoea, ni lazima kuliwacha nyumba kwa sababu yako. Nakwambia uliwache nyumba, na wewe sikuzoea, ni lazima kuliwacha nyumba.
Wanipenda vile kwa baba,
nitoe mali uoe,
nipeleke kwa baba yangu akishakuona,
nitoe mali uoe.
wanambia niliache nyumba, na mimi sikuzoea, sikuweza kuliacha kwa sababu yako. Wanambia niliache nyumba, na mimi sikuzoea, sikuweza kuliacha kwa sababu yako.
Nakwambia uliwache nyumba, na wewe hukuzoea, ni lazima utaacha nyumba kwa sababu yangu. Nimesema uliwache nyumba, na wewe hujazoea, ni lazima utaacha nyumba kwa sababu yangu.
Kama wanipenda vile kwa baba akishakuona,
Nitoe mali uoe,
vile kwa baba yangu akishakuona,
nitoe mchuru nikuoe.
wanambia niliache nyumba, na mimi sikuzoea, sitaweza kuliacha nyumba kwa sababu yako. Wanambia niliache nyumba, na mimi sikuzoea, sitaweza kuliacha nyumba kwa sababu yako.
Nakwambia uliwache nyumba, na wewe hukuzoea, ni lazima utaacha nyumba kwa sababu yangu. Nakwambia uliwache nyumba, na wewe hukuzoea, ni lazima utaacha nyumba kwa sababu yangu.
Wanambia niliache nyumba, na mimi sikuzoea, sitaweza kuliacha nyumba kwa sababu yako. Niliache nyumba, na mimi sikuzoea, sitaweza kuliacha nyumba kwa sababu. Wanambia niliache nyumba, na mimi sikuzoea, sitaweza kuliacha nyumba kwa sababu yako. Wanambia niliache nyumba, na mimi sikuzoea, sitaweza kuliacha nyumba kwa sababu yako.
Usa Bashi Isanu Member Ufitina Na upelelezi ni sumu ya mapenzi fitina na upelelezi ni sumu ya mapenzi. Mimi kupendwa na yeye, nyinyi mwakerwa na nini? Tumependana wenyewe bila nyinyi kujua. Sasa mwaona mwanza kuleta matatizo. Mimi kupendwa na yeye, ninyi mwakerwa na nini? Yeye kanipenda, ninyi mwakerwa na nini? Ninyi mwakerwa na nini? Nipenda nami nampenda, ninyi mwakerwa na nini? Ninyi mwakerwa na nini? Nasi twazidi kuimarisha mapenzi yetu. Dunia tumekuja wawili wawili, kusaidiana ndiyo raha ya dunia. Ninyi mwakerwa na nini? 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 Chama muani na kutafono naenda kinani. Chama muani na kutafono naenda kinani. Chama mwani papatua nami nimebwaga zani. Sende kanisani tumwombe Mola tupe amani. Twende kanisani tumwombe Mola tupe amani. Tumwombe Mola tupe amani. Chama muani navuta fondo naenda kinani. Chama muani navuta fondo naenda kinani. Chama mwani papatua nami nimebwaga zani. Twende kanisani tumwombe Mola tupe amani. Tumwombe Mola tupe amani. Tumwombe Mola tupe amani. Tumwombe Mola tupe amani. Wanadamu sio wema, ndugu zangu nawaambia, ashindwaye kuyasema aje kwangu nitamwambia. Wanadamu sio wema, ndugu zangu nawaambia, ashindwaye kuyasema aje kwangu nitamwambia. Wanisema, wanisema, bure bure sio maana, haidhuru, haidhuru, Mola atupe salama. Wanisema, wanisema, bure bure sio maana, haidhuru, haidhuru, Mola atupe salama. Wanadamu sio wema, ndugu zangu nawaambia, ashindwaye kuyasema aje kwangu nitamwambia. Wanadamu sio wema, ndugu zangu nawaambia, ashindwaye kuyasema aje kwangu nitamwambia. Wanisema, wanisema, bure bure sio maana, haidhuru, haidhuru, Mola atupe salama. Wanisema, wanisema, bure bure sio maana, haidhuru, haidhuru, Mola atupe salama. Awambieni sasa basi, walimsheki ndugu watapata tabu. Ajidai hata kikanisa kwa Mola we, kesho kuna mambo. Kamwambieni sasa basi, walimsheki ndugu watapata tabu. Ajidai hata kikanisa kwa Mola kesho kuna mambo. Siku ya kurudi kwenu, mwalimu Sheki Nuhu utapata tabu. Wakidai hutaki kanisa kwa Mola kesho kuna mambo. Siku ya kurudi kwenu, mwalimu Sheki Nuhu utapata wajidai hutaki kanisa kwa Mola kesho kuna mambo. Sheki Nuhu utapata wajidai hutaki kanisa kwa Mola kesho kuna mambo. usikidu utapata tabu. Wajidai utaki kanisa kwa Mola we, kesho kuna nipeleke kwetu nipeleke kwetu nimelewa sana sina pa kulala, nipeleke kwetu nimelewa sana sina pa kulala, nipeleke kwetu nipeleke kwetu nipeleke kwetu nimelewa sana sina pa kulala, 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 nipeleke kwetu jumbe.
Ngoma iko Migombani Dancing Club leo na tunaendelea.
Tumba ngoma ya wazee. Mwani navuta fondo naenda kinani, chama na mwani navuta fondo naenda kinani, chama mwani papa kuwa nami nimebwaga zani, twende kanisani tumwombe Mola tupe amani, twende kanisani tumwombe Mola tupe amani, tumwombe Mola tupe amani, tumwombe Mola tupe amani, tumwombe Mola tupe amani, tumwombe Mola tupe amani.
Ngoma ndio hii.
Io nilipata na mshitiko usiosemeka. Niliposikia habari ilitokea ajali ya kutisha sana. Ni daraja la Sarika, magari mawili yamegongana. Yakatangazwa majina ya watu waliokuwa kwenye ajali hiyo. Mojawapo kati ya watu alikuwa mpenzi Zuena. Nikatoka bila kujitambua, mikono kichwani huku ninalia. Mbio kwenda hospitali, kwenda kumuona mpenzi Zuena. Sijui kama yuko hai au Zuena amekwisha kufa. Maringo na mikono yangu basi tulio kutibilikisha. Mami Zuena, oh mpenzi Zuena, oh mpenzi Zuena. Yakatangazwa majina ya watu waliokuwa kwenye ajali hiyo. Mojawapo kati ya watu hao alikuwa mpenzi Zuena. Nikatoka bila kujitambua, mikono kichwani huku ninalia. Mbio kwenda hospitali, kwenda kumuona mpenzi Zuena. Sijui kama yuko hai au Zuena amekwisha kufa. Maringo na mikono yangu basi tulio kutibilikisha. Mami Zuena, oh mpenzi Zuena, oh mpenzi Zuena. Zuena, nipata pie. Zuena, ninesa wangege. Zuena, nipata pie. Zuena, ninesa wangege. Uto wapie mpika, kabianza kupendeza. Zuena, Zuena, kweni na mpeka. Zuena, Kimpata pie, Zuena, Inesa, Yeye, Zuena, Kimpata pie, Zuena, Inesa, Yeye, Tutuadi, Tabiasa, Zuena, 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 Zuena. Moyo mia kutukia kutazuena alilima niona jera mena dunia kita zuena 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 mama zuena bibi zuena mama zuena pie zuena ini sawa yeye zuena Kimpata pie, Zuena, ini sawa yeye, tutoami mpika, tabiasa kutubeza, Zuena, 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 Zuena. Sijui mimi ningefanya nini kama Zuena angenituma. Nimeishi kwa mtaa wote wawili tumezoeana, Zuena, Zuena. Zuena mama, Zuena bibi, Zuena mama, Zuena kata pie, Zuena ini sawa yeye, Zuena kipata pie, Zuena ini sawa yeye, tujuane mpika, tabiasa kutubeza. Zuena, 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 Zuena.
Kama ujuavyo, magonjwa hakuna anayejua kama utaumwa usiku au mchana.
So shortage of medicines in health facilities. We found a shortage of health professionals or health workers, actually, pharmacists or pharmacy technicians and assistants, those who manage the supply chain. We found problems with distribution, with delayed deliveries of medicines and pharmaceuticals in the supply chain, and leakage of medicines out in the market. And we need a complementary supply to fill the gap that MSD cannot fill.
We designed an innovation which is called Prime Vendor System, and by then in 2014, the design was having one vendor who supplies the whole region. It's called a Prime Vendor System with a single vendor with pooling all orders.
This complementary supply chain has significantly improved the availability of health commodities at all levels of the health system.
If facilities had other funds, right, to procure medicine outside medical store department, and they could legally use them to buy it from the prime vendor, that led to an improvement in terms of drug availability and definitely quality of service.
Kupitia mfumo huu unatuwezesha hata sisi kujipanga vizuri katika kustock mali, ili inapotokea tu MSD kuna upungufu, wanaporudi kwetu basi tuna uwezo wa kujazia kwa haraka na kwa kiasi ambacho kinahitajika.
Jazia kama jazia, sio kwamba wana zile item tu ambazo sisi tunazo. Unakuta wao ni suppliers, wana vitu vingine zaidi, kwamba kuna kipimo hiki na hiki. Ina maana mimi kwangu utaniongezea ufanisi wa kufanya kile kipimo na kuongeza mapato kwenye kituo changu.
Jazia Prime Vendor System now covers all 26 regions and covers over 8,000 health facilities. In addition, the system has been digitized in PIVMIS and is fully integrated into the National GoTomis system.
Haya, nipende kutamka rasmi kwamba mfumo wetu huu wa mshikiri wa kielektroniki pamoja na mfumo wetu wa GoTomis nimeizindua rasmi. Hongereni sana.
Mfumo wa mshtusi kwa ajili ya kuratibu shughuli za Prime Vendor System. Kwa hiyo mfumo wetu utasaidia pia kupunguza muda wa kuchakata haya maombi, kwa sababu sisi zote tukafanyika kwa njia ya kielektroniki, na pia itarahisisha sisi kwenye ngazi ya taifa na kwenye ngazi ya mkoa pia kufuatilia maombi ambayo yanakuwa yameanzishwa na vituo na namna ambavyo wamepokea bidhaa za afya.
However, even a very well-designed supply chain model will not be successful if it's not embedded in a health system context. We have based our systemic approach on a theory of change with the ultimate goal to improve health outcomes. From the beginning, we therefore emphasized the need to support all the other building blocks of the pharmaceutical system, such as human resources for health, responsible use of health commodities, and accountability.
In collaboration with St. John's, the University of Tanzania in Dodoma, a one-year course for a new cadre of pharmaceutical staff and the pharmacy dispensers were started to manage medicines at the PHC facilities.
Quality of service for a client is not only the provision of clinical services, it's availability of medicine. If a patient goes to a hospital, is diagnosed, and then prescribed medicine, if he doesn't get the medicine at the hospital, already doesn't value the service.
HPSS therefore supported the revision of the National Standard Treatment Guideline and implemented the concept of stratified standard treatment guidelines for primary healthcare facilities, focusing on the most common conditions, the clinic available medicines for treatment in lower health facilities. This was followed by clinical training of health providers.
Hapo awali tulikuwa tuna ujuzi wala uzoefu wa kutoa dawa, tulikuwa tunatoa tu dawa tu bila kufuata utaratibu, lakini pia namna gani niweze kuangalia mahitaji yangu ya msingi wakati wa kuagiza dawa. Kwa baada ya kupata hii kozi imeweza kutusaidia kwa kiasi kikubwa sana. Kwa mpaka sasa hivi kwamba vituo vina uwezo wa kuagiza dawa kutokana na mahitaji ya kwao, na hivyo kupelekea upatikanaji wa dawa zote muhimu kituoni kwa muda wote.
Kwa sasa hivi kwa kweli huduma zimekuwa zimerahisishwa. Unaweza ukaenda zahanati ukapimwa ukapewa dawa. Umuhimu wa upatikanaji dawa kwa kweli katika jamii ni jambo la muhimu sana katika vitu vyote.
Antimicrobial resistance is a silent pandemic in Tanzania. Based on the initiative of HPSS and in collaboration with the Ministry of Health and WHO, a national AMR symposium was organized in 2017 where the Nation Action Plan AMR was launched.
In 2022, the Ministry of Health, in collaboration with stakeholders, developed the National Action Plan on Antimicrobial Resistance. 22nd AMR symposium was organized successful. Again, the HPSS has supported the Tanzania Young and the Successful Organization, the Rollback Antimicrobial Initiative that is working on community awareness and school children as a change agent to improve antimicrobial use.
Yes, we're truly delighted that this successful complementary supply chain, the Josiah Prime Vendor System, which by the way promotes good governance and accountability and all the related activities such as training and human resources for health and responsible use of medicines and health commodities have been taken up by the government, which assures, obviously, sustainability.
The system thinking approach in the pharmaceutical sector, backed by operational research, has strengthened the Tanzanian health system, contributing to a better access to healthcare.
Upatikanaji wa dawa katika zahanati zetu unatusaidia sisi kuokoa maisha yetu pamoja na muda.
Pure, TAMISEMI, and the Ministry of Health, they have taken it up and they will continue to monitor it, to manage it. So we as a project, we will soon be redundant. And that's exactly what we want to do. So Josiah, fill the gap of missing medicines, of stockouts, to fill the gap of shortage of medicines.
Tuko napata changamoto kubwa sana kipindi cha nyuma, kabla zahanati haija, kama ujuavyo, magonjwa hakuna anayejua kama utaumwa usiku au mchana. Inaweza katokea mtoto hasa kwa watoto, kuta usiku mtoto anachemka anaumwa, itakulazimu utoke uende hospitali ya mlenia, kama daktari akakuandikiwa dawa, alafu anakwambia dawa hapa hamna, unaandikiwa uende kanunue mtaani. Mtaani kwenyewe wapi?
When the HPSS project started in 2011, a situation analysis showed frequent stockouts of medicines and health commodities in health facilities.
We found a lot of weaknesses in the supply chain management in general. We found a lot of out of stocks of medicines, or shortage of medicines in health facilities. We found a shortage of health professionals or health workers, actually, pharmacists or pharmacy technicians and assistants, those who manage the supply chain. We found problems with distribution, with delayed deliveries of medicines and pharmaceuticals in the supply chain, and leakage of medicines out in the market. And we need a complementary supply to fill the gap that MSD cannot fill.
We designed an innovation which is called Prime Vendor System, and by then in 2014, the design was having one vendor who supplies the whole region.
And they could legally use them to buy it from the prime vendor. That led to an improvement in terms of drug availability and definitely quality of service.
Kupitia mfumo huu unatuwezesha hata sisi kujipanga vizuri katika kustock mali, ili inapotokea tu MSD kuna upungufu, wanaporudi kwetu, basi tuna uwezo wa kujazia kwa haraka na kwa kiasi ambacho kinahitajika.
Jazia kama jazia, sio kwamba wana zile item tu ambazo sisi tunazo, unakuta wao ni suppliers, wana vitu vingine zaidi, kwamba kuna kipimo hiki na hiki. Ina maana mimi kwangu itaniongezea ufanisi wa kufanya kile kipimo na kuongeza mapato kwenye kituo changu.
Jazia Prime Vendor System now covers all 26 regions and covers over 8,000 health facilities. In addition, the system has been digitized in PIVMIS and is fully integrated into the national GoTomis system.
Haya, nipende kutamka rasmi kwamba mfumo wetu huu wa mshitiri wa kielektroniki pamoja na mfumo wetu wa GoTomis nimeizindua rasmi.
Mfumo wa mshitiri umeundwa mahususi kwa ajili ya kuratibu shughuli za Prime Vendor System. Kwa hiyo mfumo utasaidia pia kupunguza muda wa kuchakata haya maombi, kwa sababu sisi zote tukafanyika kwa njia ya kielektroniki, na pia itarahisisha sisi kwenye ngazi ya taifa na kwenye ngazi ya mkoa pia kufuatilia maombi ambayo yanakuwa yameanzishwa na vituo na namna ambavyo wamepokea bidhaa za afya.
However, even a very well-designed supply chain model will not be successful if it's not embedded in a health system context. We have based our systemic approach on a theory of change with the ultimate goal to improve health outcomes. From the beginning, we therefore emphasized the need to support all the other building blocks of the pharmaceutical system, such as human resources for health, responsible use of health commodities, and accountability.
In collaboration with St. John's, the University of Tanzania in Dodoma, a one-year course for a new cadre of pharmaceutical staff and the pharmacy dispensers were started to manage medicines at the PHC facilities.
Quality of service for a client is not only the provision of clinical services, it's availability of medicine. If a patient goes to a hospital, is diagnosed, and then prescribed medicine, if he doesn't get the medicine at the hospital, already doesn't value the service.
HPSS therefore supported the revision of the National Standard Treatment Guideline and implemented the concept of stratified standard treatment guidelines for primary healthcare facilities, focusing on the most common conditions, the clinical skills of health staff, and available medicines for treatment in lower health facilities. This was followed by clinical training of health providers.
Hapo awali tulikuwa tuna ujuzi wala uzoefu wa kutoa dawa, tulikuwa tunatoa tu dawa tu bila kufuata utaratibu, lakini pia namna gani niweze kuangalia mahitaji yangu ya msingi wakati wa kuagiza dawa. Kwa baada ya kupata hii kozi imeweza kutusaidia kwa kiasi kikubwa sana. Kwa mpaka sasa hivi kwamba vituo vina uwezo wa kuagiza dawa kutokana na mahitaji ya kwao, na hivyo kupelekea upatikanaji wa dawa zote muhimu kituoni kwa muda wote.
Kwa sasa hivi kwa kweli huduma zimerahisishwa. Unaweza ukaenda zahanati, ukapimwa, ukapewa dawa. Umuhimu wa upatikanaji dawa kwa kweli katika jamii ni jambo la muhimu sana katika vitu vyote.
Antimicrobial resistance is a silent pandemic in Tanzania. Based on the initiative of HPSS and in collaboration with the Ministry of Health and WHO, a national AMR symposium was organized in 2017, where the Nation Action Plan AMR was launched.
In 2022, the Ministry of Health, in collaboration with stakeholders, developed the National Action Plan on Antimicrobial Resistance 2023 to 2028. And through the National Sector Coordinating Committee, a second AMR symposium was organized successful. Again, the HPSS has supported the Tanzania Young and Successful Organization, the Rollback Antimicrobial Initiative, that is working on community awareness and school children as a change agent to improve antimicrobial use.
Yes, we're truly delighted that this successful complementary supply chain, the Josiah Prime Vendor System, which, by the way, promotes good governance and accountability, and all the related activities such as training and human resources for health and responsible use of medicines and health commodities have been taken up by the government, which assures, obviously, sustainability.
The system thinking approach in the pharmaceutical sector, backed by operational research, has strengthened the Tanzanian health system, contributing to a better access to healthcare.
Upatikanaji wa dawa katika zahanati zetu unatusaidia sisi kuokoa maisha yetu pamoja na muda.
Pure TAMISEMI and the Ministry of Health, they have taken it up and they will continue to monitor it, to manage it. So we as a project, we will soon be redundant. And that's exactly what we want to do. So Josiah, fill the gap of missing medicines, of stockouts, to fill the gap of shortage of medicines.
Welcome back from your very nice breakfast, I hope. 10 years of demonstrated history of working in the health industry in Tanzania. He's serving as a national coordinator for health commodity tracking and the procurement of health commodities sourced outside MSD. He has gained extensive experience in supply chain management of health commodities while working as a hospital pharmacist at the Dodoma Regional Referral Hospital between the years of 2010 to 2014. And again, as a regional pharmacist between 2014 to 2019 in Dodoma region. Moreover, Dennis Mboera holds a bachelor's degree in pharmacy from Muhimbili University of Health and Allied Sciences, which he graduated in 2008. And he also he's a master's holder, which he gained this from the Pompeu Fabra University in Spain. I hope I've not misspelled the name of the university. And he graduated his master's in 2017. He has certificate basics in health economics from the World Bank Institute, gained in 2013, and the methodology and the practical application of health technology assessment and economics evaluation in health from Summer School in Public Health Policy, Economics and Management in Lugano, Switzerland. So this is, in short, his CV again is very long, but that is Dennis Mbopera. And we welcome you to the stage so that you can take lead of the session. Karibu sana, Dennis.
Habari za mchana. Good afternoon. I don't know if it's afternoon or morning. Good morning. Thank you very much for the introduction. I don't have much to say, rather to welcome my panelist, sorry, my keynote speaker, Mr. Ali Kebi. Before I let him in the stage, I'd like to say a few remarks on Ali Kebi. Ali Kebi has been serving in the HPSS project since its establishment, 2011. He's the advisor in the system strengthening on the area of HTM, has been advising councils, regions, and nation. Ali Kebi holds a bachelor degree as well as Master of Science degree with nearly 20 years of professional experience. Ali Kebi, may I call you to come in front so that the audience can see you, and they will proceed with the presentation. Also, I'd like to call my panelist, technician Twaibu, technician engineer Frida, and Suniva, engineer Mvanga, Suniva next to Ali Kebi, engineer Mvanga, technician Magige, and Dr. Ernest Ibenzi Njile. Dr. Ibenzi, please come in front. Dr. Ibenzi, as we all know, is serving as a medical officer in charge at Dodoma Regional Referral Hospital. He's a surgeon by profession, and in the morning we were together as panelists. Dr. Ibenzi was the first prime vendor coordinator for Dodoma region. So he's one of the pioneer of prime vendor system in Dodoma, and he was appointed by the regional administrative secretary, who is here with us, Mama Rehema Madenge. So Mama Rehema saw Dr. Ibenzi's potential and appointed him to serve as a prime vendor coordinator. Also, Engineer Suniva is an engineer by profession, biomedical engineer by profession, working at the Ministry of Health in the Directorate of Treatment and Services. And also, he has extensive experience on his career for over 17 years. He has been serving with the maintenance of medical equipment and its installation. Also, at the ministerial level, he's serving as a policy advisor on the issue of biomedical engineering, and is offering some technical expertise to other technicians on how to maintain and install the medical equipment. So let us clap for his success. Similarly, Frida is also a biomedical engineer working at Iringa RRH. She has experience over 7 years as a biomedical engineer. So far, she is skilled to the field and has extensive experience. Also, Engineer Mvanga, he has over 20 years of experience, both at the ministry level and now is serving at the Morogoro RRH as a biomedical engineer. Dr. Mvanga is skilled in the subject, and Dr. Mvanga is the mainstay for the medical equipment that are available in the entire country. He was the pioneer in advising the government what type of equipment to be installed in all parts of the country, in the public health facilities. So he's an expert to biomedical engineering career. Also, we have technician Magige. Magige is also a technician who has experience over 6 years at the Dodoma Regional Hospital. Magige is maintaining and installing equipment at Dodoma Regional Referral Hospital. He is also maintaining, instructing other technicians in the council to do the same. So he's an expert in this subject. Twalibu is also a technician working in the installation and maintaining medical equipment. He has also experience of over 3 years of experience, and he's doing the job as intended. Let us clap for all the panelists so that we can continue. Having introduced the panelists, may I take this opportunity to welcome the keynote speaker for HTM, Mr. Ali Kebi. Welcome.
Still morning. Good morning again. I'm delighted to stand here before you all to present our experiences in the health technology management. I'm very humbled to be sitting together with Engineer Valentino Mvanga as a panelist. To me, Engineer Mvanga has been a teacher and a guider in the area of health technology management. When we started, I being non-biomedical engineer, no technicians, I had to learn quite a lot from this gentleman. Similarly to my good friend Suniva Aule, who has been our long-term consultant in the project regarding these areas of biomedical engineering. So I'm very happy to sit together with this team and also to exchange in this area as well. The other colleagues on the panel, some of them are my students. So I also been training others after I've been trained. So it's very interesting day for me to stand here and share this experience. So basically, we, as for the other component that you have heard about, we had a mandate to support the government of Tanzania to come up with innovation in order to strengthen this work area in the healthcare system. Tafadhali slide utembe. So I will skip that slide. And that one as well. This one, you have seen it quite a lot. So we had a mandate, especially for this phase, to ensure that the technical facility that we established together with Ministry of Health and PORAG effectively support the national implementation of health technology. So the output were to have required structure, staff capacities, tools, and procedure for effective implementing the health technology management. So that has been the kind of ladder that guide us during these last 4 years, but we have done quite a lot of innovation and implementation in the previous phases, of which we are going to share their results. So when we started, basically we did some situation analysis to determine where are the experience in the government and where are the gaps. So several hii teknolojia inamletea shida nchini yako. Henry, umeziba hiyo. Hapo ulipokaa unaziba hii click. So what we found out during the situation analysis, there were very little manpower for maintenance of biomedical equipment. If I recall the number very well, we had only 14 personnel working on biomedical engineering in Tanzania. Majority were working in the private sector. There were no responsible person for maintenance, especially in the district and the regional level. So the regional were mainly depending on the services from the zonal maintenance workshops, which were distributed in the 4 zones of this country, which of course were overwhelmed by the workload on maintaining the facility, and they were focusing more on the big hospital where they were attached to. So in principle, there were no maintenance, which were done systematically. There was no planning and budgeting in all primary level of care for maintaining and repair medical equipment. There were no infrastructures for maintenance where the technician would work. They would need a workshop. Here in Dodoma, we had only one workshop in Mvumi Hospital, but the rest of the council had no workshop, and the similar situation were in many other regions of the country. There's no systematic documentation of activity of maintenance and repair of equipment. So you can tell when was this equipment received planned preventive maintenance, or when was it repaired? What costs were involved? What spare parts or consumables were changed? So there was no record in most cases. As I said earlier, no systematic approach for maintenance and repair, and the inventory mechanism for medical equipment were not in place in most of the area, except with some few facilities. So what we did as HPSS was to come up with an innovative way, but building on the international standard for maintaining medical equipment. So the biomedical engineering by itself is quite a complex intervention that need to be done in a systematic way, as we said. So it requires to conduct inventory, the technical inventory of the equipment, to understand what type of equipment it is, the manufacturer, the year of manufacturing, the year when it was installed, and the likes. You need also to have a plan for maintenance of the equipment, so for the buildings, and also procurement plan for the equipment. So the whole process of procuring involve a lot of processes. Our colleague might touch base on that. But also renovation plans, as well as training, development of standard operating procedures, and overall the management system from the health system managers down to the facility level. So that's what we try to introduce. In doing so, we were concentrating our efforts in order to strengthen capacity within the government structure so they could address around 80% of the problems. So we adopted the pyramid of the WHO that guide us or guide the health system that to ensure they've got in-house capacity which could address around 60 to 80% of the problem within the facility or at the district level where the workshop will be established. And it is expected that at regional level, it will address around 10 to 25% of the maintenance need, and 5 to 15% would be addressed by the specialized technical teams from the manufacturers or from the national level. So that pyramid, we try to build on that to make sure that within the government system, we try to build that capacity. So when we started it, we say there were no technical capacity. We even tried to implement a PPP plan. There was a private company we tried to engage in the process so it could provide the regional level and national level services. However, due to different reasons, that did not happen, and that necessitated us as a project to continue support the government to build its own capacities in order to solve those problems. So these were the approach that we adopted, and we hope it has worked. We shall hear from our colleagues today. The first intervention we did after the first training, we had to do the inventory. So we have developed quite a number of activity on inventory. We had a baseline inventory whereby the team of technicians from the region whom we trained had gone around the region to collect baseline information. And in doing so, we have also established a digital solution. We piloted the Open Medis solution to keep data, and so we can manage the information within that database to inform all the processes within the health system. And that system was used to inform the government planning processes, whereby they could understand what type of equipment they have, what type of maintenance plans are needed, and what type of corrective maintenance will be required, and also requirement for spare parts and consumables. So we did that. We are very lucky now. The inventory management system has been accepted, and we have now developed what we call the National Medical Equipment Information Management System, or MAMIS, with the Ministry of Health, which are currently being used around the country for management of inventory and other interventions. So I will skip this slide as well. So apart from that, we conducted a number of trainings to build capacity of the biomedical engineering personnel in the region. When we started, we had only one biomedical technician in this region. Thereafter, we had to identify available resources for technical personnel, either electronic technician, electrical technician, or electromechanical technicians who would be trained as on biomedical engineering so they could perform maintenance of equipment. We started with that approach. We implemented it for almost 2.5 years, which also worked very well. And later on, we received graduate technicians from the different training institutions. Some of them are sitting here with us. However, when they were deployed, we noticed that they were in need of building their capacity further in order to address the need in the field, because they had little exposure on a different technology while they were receiving the training. And without this kind of in-house training, their capacity would be limited. As you have heard today from the remark of our guest of honor this morning, DPS, that those graduates still need a training. So we did a number of training in the different types of equipment in order to build their capacity. Apart from that, we have conducted some user training for users, because when we started the implementation of the maintenance and repair interventions, we came to learn that most of the equipment, almost 60 to 70%, were breaking down due to user fault. Users were not properly using those equipments. They were not doing first line planned preventive maintenance. In that regard, there were a number of breakdown and the downtime of the equipment. So we embark on the training on how user could properly use the equipment and they could properly do the planned preventive maintenance. Not only that, during that time, we found out there are many technologies were not put into use because users were unable to use it. For example, this anesthesia machine where you see Engineer Magige there. It was for the first time it was turned on. It stayed in the store for almost 2 years, but no one were able to turn it on. And these were distributed across many facilities in the country. So that we did, and Engineer Mvanga also guided the team during that time on how to turn it on. There was no manual, nothing given by the supplier, so it was very difficult to use. So we had to do such training on that, but also concentrating our training in some targeted areas. For example, maternal and child health. There were many equipment provided by the government, but they were not put into use, and thereafter we had to do the training in that area as well, so to improve the use of that equipment, like those fetal heart Doppler, which we see one of the technician training clinicians and nurses. So in order to ensure there is sustainability of the intervention in terms of capacity building to address the gap, excuse me. Mashine imeharibika kituoni, natakiwa niende. Ndio kazi ya engineer. Natani. Nimepata taarifa Mheshimiwa Waziri TAMISEMI, the Minister for TAMISEMI will be here at 1:30 for a closing event. So we continue. So we supported establishment of a training course at Mvumi Institute of Health at biomedical engineering level, at artisan level, but now we are glad to mention the college and NACTE have agreed to upgrade that training to a level of a diploma from a certificate, because they've seen a need and to improve availability of biomedical technician in the country, as well as having the artisans. So we supported government also to establish maintenance workshop. It was required also for the government to contribute. So they've allocated some buildings which we were given to renovate. For example, that picture shows Mpwapwa building. This was an old mortuary. Later it was turned into a store. So we were given that to turn into a workshop, which we did. And we also installed working tools. So it's no longer a mortuary now. People are working there. The live people are working, not the dead people sleeping. In the Dodoma Municipal, they've gave us a room, a store that they are dumping everything they will correct in the offices or on the streets. On the other side down there, walikuwa wameweka nyanya, wamekamata wa machinga na nyanya wamezitupa huko. So we were given that room, and then we had to renovate it into a workshop. So that is existing, and this is the picture recently in Arusha region. We were given a very old building from the German colonial time. It was dilapidated, but we turned it into a meaningful building, a very good workshop at a regional level with all the very good equipment they would need. And I will not say much for Iringa because you know the behavior of people from Iringa. They might go and hang themselves afterwards. So, but this is where they are building. So we had to
expand it, so we had to build a new one. This was demolished, and we set up a new building with a very good work area, so where now engineers and technicians are working in that regard. So the lesson that we have learned on establishing the workshops, you don't need to build a new building where you have little resources. So you can also renovate some existing structure to make it meaningful structure for use of maintaining. This is the picture we took in Dodoma region when we started. This is the picture in Iringa. So to this time, we have set up 4 regional maintenance workshop and 5 district maintenance workshop. On top of that, we have supported the government to establish the National Calibration and Training Center, of which will be doing high-end intervention in terms of medical equipment, maintenance, and management in the area of calibration, but also training engineers and technicians in biomedical engineering. So this will help in terms of ensuring the equipment, when are maintained, are also calibrated to the standard set out by the manufacturer or according to the health guidelines, in order to avoid any harm on the use of that equipment. So in general, just to summarize what we see now after all the long-term implementation, we have seen the number of equipments in a functional status are increasing. For example, this chart here show the number of equipment which were maintained by the engineers and technicians. The requests were received, the engineers and technicians were able to address 81.1% of the maintenance, whereby around 1.9% did not complete. We call it a failed, because perhaps the equipment have reached beyond economic repair, so it has to be discarded, as there was no any escalation of a need to another level of maintenance, and 17% were not attended, meaning that they are still being addressed. So all in all, with this particular intervention, we have seen 97.7% of equipment reported in the MAMIS now are in a functional status. So the picture is very different if you compare with where we came from, and we see the engineers and technicians are really doing their work in maintaining the technology. Asanteni sana. We have no more to say about this. I don't know where these people are now. Maybe Manfred could tell us, because this picture was taken by Manfred in 2010. Perhaps these are already very grown up. Asanteni sana na nawashukuruni.
Asante Alikebi and the audience for listening. Let me take this opportunity to congratulate HPSS as we are celebrating the closure of their project. But at the same time, let me say a word of thanks to Mama Rehema Madenge for accepting the project to start in Dodoma, and her leadership. She trusted the young generation. Ben is among of them, and I was among of them, and the others. So the younger generation at that time pushed the agenda, and now we are celebrating the outcome. I would like to take this opportunity to welcome Engineer Suniva to address on the issue of how healthcare technical services as an integral part of the health system in Tanzania has taken a long journey to institutionalize it. And can you describe what has been the journey and how it has shaped now? Suniva?
Yeah, thank you, Mr. Moderator. Good afternoon, Ladies and gentlemen, as it has been introduced, my name is Engineer Suniva Haule, a biomedical engineer, now working in the Ministry of Health. Previously was working in a from private institution when HPSS started this project in the country. From that time, as it was spoken before, was very limited number of biomedical engineers, most working in the private institutions. So I was among of those working in the private institutions. Fortunately, I can say I was working in Christian Social Services Commission, CSSC. I think most of them knows about this. So when I used to work with CSSC, CSSC had a focal on how, focal or vision to see how to manage the health technology management in their health facilities. Most of the equipments were donated from the European countries through Christian health facilities. This equipment was expected to work for more than 10 years. Unfortunately, the equipment was working even with 1 month, then broke down, then they were just left aside, unknowing what was the cost of the equipment. So in the Tanzania Christian Medical Association, they had a quick survey to see how much they spent in medical equipments. Then they came to realize it was a lot of funds which could be used in another areas of the health system, like training of doctors, making construction of other infrastructure which were needed, and so on. So they came with an idea to start maintenance units. By then, one of them was in Bugando, then it was in Kilimanjaro, then it was in Peramio, and one was in Mbeya. Those was working as a zone hospitals, and I was among of those managers on those projects by then. So from there, government slowly started to see what Christian Social Services was doing in this, because the zonal workshops was working both in private, public, and religious organizations. So the impact was there. Then slowly, the government was looking on how to incorporate the working system from the Christian Social Services Commission to the public facilities. Also, to own the structure. So Engineer Mvanga came in the ministry, but I was still working there. Then we were working parallel, and then I was subjected to consult the HPSS from the Christian Social Services Commission. And from that time, Mvumi was providing short course for biomedical engineering technicians. But those guys who was there, was working in the health facilities from the religious organizations, was from mechanic side, was from electrical and electronics, but this word of biomedical engineering was not existing in the country. So from there, development went until now. We are sitting here. Also, this was the journey of opening the training institutions in Tanzania. As Ali was trying to explain, here we have some of the students who were trained in the country as the first finalist, then was adopted in the project. Now they are serving the government. So this is the milestone. And then the scheme of service was not existing in the government of Tanzania for biomedical engineering. Then advocacy to incorporate the scheme of service for biomedical engineering field was started, then slowly went until 2012. This was adopted in the system. Then when the first output from the training institutions came, where also Ministry of Health started to employ those biomedical engineering, by then was at technician levels. So this is the second stage. Then few of them were employed by the government working in the areas, but the workforce was not enough. We still depended from the experts or from the private institutions or equipment vendors to support during maintenance activities. The cost of the maintenance still was seen to be very high. Even the number of human resources, as I said, was very limited. It was not easy to cover all areas in the country as it was required. Then HPSS supported to implement this. Then the pilot, as I said, was started in Dodoma. We did, as Ali was explaining. Then noticed one point was not in consideration for the management side. Those guys was working, but if you go to the management side, it was not yet in the standard requirement. Also, the management of the hospitals was not aware. They was depending from the external service providers to maintain the equipment, although was not well intact. This was for the first side. For the second side, I think you know or you remember, it was one institution in the government, by then was called UGENS, was mandated to maintain the equipment. Unfortunately, in that UGENS, there were no experts for biomedical equipment engineering. So the priority of them to go to the institutions to maintain the equipment also was not as their priority, because they didn't knew the importance of priority what we have in the health institutions. In hospitals, we say everything is emergency. Hospitals could send the request for maintenance, then they stayed there even for 3 months. They come, look, go back, nothing was being conducted at the proper time. This made pile of unserviced equipments, and then the government was looking to invest in new technology or new equipments, then they forgot about the maintenance area. So when HPSS came, we made a quick survey of the equipments lying in the stores. We suddenly found some of the equipments needed 2,000 shillings to make it working. And the cost of the equipment was around 2 million, but it was lying there. The institution was thinking to purchase new equipment for 5 million. So a lot of equipment was revived, kept to work, and then now slowly the health workers from the medical side or clinicians, they came to start recognizing the importance of biomedical engineering field in the country. So this showed the milestone, and now I'm proud to say the government is advocating about these healthcare technical services in the health institutions owned by the government and the private institutions. Also, the government also insists on going to the second level for the specialization and supporting very well in our movements for advocacy of the health technology management in the country. Thank you.
Asante Suniva. May I ask Twaribu, as a district biomedical technician, how have the HPSS intervention empowered and facilitated the work of biomedical engineer services at the regional and district level, and for the engineers to carry out their work?
Thank you. Good afternoon. Good afternoon. Thank you. My name is Twari, biomedical technician from Dodoma. As a regional biomedical, HPSS help us a lot in improving us our work. First is they enable us to provide us with tools, and then enable us as a district biomedical to reach in the health centers to attend the repairs, maintenance. Also help us to provide a funds to procure the spare parts also and consumables. So at least now the demos have a understanding how the biomedical works. So appreciate the HPSS for doing this. Thank you.
As you have heard from the biomedical technician, actually their expertise is so vital in the healthcare system, because you can invest a lot in procuring medical equipment, but end up without maintenance, and it ends up in the storage facility without providing the intended need. So their presence makes longevity for medical equipment in our health facility. May I ask Engineer Winifrida, how have the HPSS intervention empowered and facilitated the work of biomedical engineering services at the regional level, and for the engineers to carry out their work? But Engineer Winifrida.
Thank you very much. On behalf of the entire community of regional referral hospitals, I'm so honored to thank you HPSS for what they did. Actually, the RRH management team knows you very well and appreciate what you have done. So HPSS has supported different areas in the regional level. One of them is the So one of the areas which they supported, it is building workshop at the regional level for the BMWs. Iringa Regional Referral Hospital is among of the hospitals which receive a massive support for the workshop improvement. Let me explain a little bit about the real situation which we had before the HPSS. Iringa Regional Referral Hospital, we had a simple and small and unsatisfactory building for the workshop for the BMWs to carry out their activities. A building had a single room which we use for all maintenance activities, and sometimes we use the same room at the office. During for tea time, we use also the same room. So as you can see, the contamination which we made at that time. So long as the room is small, so if one of the biomed is working in the workshop, and if it happens another work, so it supports the biomeds to go and work at the respective department where the problem has occurred. And if it happens, one sits on the chair, the other have to stand. So that was the reality. So as I speak right now, Iringa Regional Referral Hospital enjoys a good workshop with the office, store, working area. We have 2 working areas, toilets, and tea room together with the reception. So HPSS did not end there. They make sure that the department had the necessary equipment for BMWs to work together with the working tools and the skilled personnel to carry out the activities. So they after reconstruction, of the workshop, they purchase furnitures for the workshop, good furnitures. They also purchase laptop, and they also purchase a national working tools. When I say national working tools, I mean it. So thank you very much, HPSS, for your support. So condition, we can able to do our maintenance effectively. And with these tools, we can go to the district level to help them, because at first we did not manage to maintain our equipment because we don't have tools. You find that you have a machine is down there, you don't have a proper working tools to open that machine, so you have to live with. But for now, we can perform maintenance 100%. Thank you very much, HPSS.
Asante
Not
Frida.
only this.
Okay, 1 minute, please.
Okay, thank you. So the other area which HPSS helped us, it was the facilitation, training, and education. They facilitated a lot of training to BMWs. This helped in capacity building for maintenance. Not only that, it also increased the confidence for the biomeds and the relationship among the BMWs within the region and the district. So they also introduced the system, as Mr. Alkebi said, called MEMIS. That system is very helpful to our field because most of the information, if we want, we can find them over there. So it's helped us in budgeting plan, spare part, because if you want to know a kind of technology that the facility is having, you just go to the system and click it. You find all the system, all the technology which you have. So thank you very much for your support. Once again, let me wind up by saying that thank you very much, HPSS, for your beautiful and smart job which you did even 12 years. Thank you very much.
Asante Frida, thank you for that comment you have made. Engineer Valentino Mvanga, looking back, what is your reflection on the development of HTM intervention in Tanzania, and what has been the contribution of HPSS in the development?
Thank you. My name is Engineer Mvanga Valentino, as it has been introduced before. And I really appreciate everything which has been conducted by HPSS. At the first time I was at the ministry, one day I received guests from HPSS. It was Professor Meshak with the Alikebi. They came in and starting introducing what exactly they can support the ministry. I was really excited because it was the wish for the ministry to reach those kind of services and goals. And it was like an angel has visited your office. And I asked Mr. Alikebi and Professor Meshak if what they are introducing to me, it is a reality. Because we were at a very high need to receive that kind of support. And later, when we had that kind of meeting, the same day we started planning how to do the SAMO execution. And by that time, there were no funding in HTM at HPSS. But they promised that they are going to look for fund. And also, it is not easy sometimes when you are at the government office to go and introduce anything to the high levels, especially ministers and the permanent secretaries. But with them, they told me that if you have got anything, you can just tell us, and we will try to reach those decision makers so that we can implement these kind of good goals. From there, we started now doing the implementation, as it has been introduced, by training people and also doing some assessment on what exactly the project can support. And it was really difficult because the situation was not that much good. You visit the hospitals, you find a lot of equipment are just piled off somewhere. Then find some equipment, they are very expensive, and they just require a fuse of 500 shillings, very small amount of money. While visiting, doing assessment, we started also doing some repair, because it was like, hey, why this kind of equipment, very expensive and very useful in the hospital, but it is not functional, I mean, to support the services which were required to be provided using that equipment. And later, we find difficulties is on manpower to implement the activities at the facilities level. Then through HPSS, we trained some mechanical engineers and electrical technicians from the district, not district hospital, from the district commission or executive director. They are not used in the environment for hospital, but we were like at different hospitals, there are no people who has such capacity. Then we have to use somebody with that at least engineering knowledge so that they can support hospitals to have somebody to do the maintenance. But it was not easy because we couldn't get good products from them. By that time, we at the ministry, we had negotiating with the training institution to establish courses for biomedical engineering. Through HPSS, they supported us also to support the institution to bring people with that kind of professionalism to attend the kind of equipment and the technology which are available in the country. And in 3 years later, we had the output for the first time from Arusha Technical College and the Dar es Salaam Institute of Technology. And HPSS, because the government was not ready by that time to employ, HPSS employed, giving them full salary as a government employee, employed almost 7 people, biomedical technicians, to be working in the district, all districts in Dodoma regional facilities, and also to the regional hospital, referral hospital. By that time, workshops were not there. They constructed workshop or renovated workshops, purchased the tools, working tools for these biomedical who has been employed so that they can start working at that specific hospitals. And also, they renovated some buildings within the hospital so that these biomedical technicians, they can stay in those buildings which were renovated by that time. And it was like they are making us proud, and they are making us also to be popular, because it was an unpopular field. Then, till to date, there are a lot of things which has been said by my colleague here, a lot of developments, but one of the major development, it is to have a medical and infrastructure management information system, which is now showing us in a click of moment, showing us how much and what kind of technology are being invested at a facility. It was very difficult for the Ministry of Health, sometimes when, especially when our state leaders going out, trying to exchange the offices, we were supposed to give the report about the investment done at the Ministry of Health in concern to medical equipment. We were taking almost 3 weeks or 2 weeks to give the proper information that we have got this much X-ray, this much CT scan, this much ultrasound, and it was installed at which year, so that we know the outgoing leader, how much he has invested, and the coming leader should know that what is going on the health sector. But by today, I'm sure at the ministry, they can take 3 minutes to get all the information from the whole country's health facilities to know the installment base of medical devices. And the system, it is new in Africa. It is also new in the world, that a country to have one system which is going to be operated in the entire nation. It is almost, we are the first one. And in South Africa, they have tried, but they haven't reached the goal where we are by now. Then I thank you so much, HPSS, for this intervention, which is now, it is much easier also to allocate human resource, to allocate fund for maintenance, and also to think of procuring any other kind of technology required at a certain facility, because all the information can be gathered and discussed and decided at a very few time. Thank you so much.
Asante Engineer Mvanga for that experience and nice comments you have made. That shows that HPSS has contributed a lot to the biomedical engineering course, and also the impact of it you have heard from the panelists. Technician Magige, in your opinion, how has HPSS, in collaboration with the hospital you are working, have helped you to make your work go smoothly in maintaining and installing and maintaining medical equipment at your working place?
Okay, thanks. My name is Mage Kinanda. I'm biomedical engineering. I'm biomedical engineering from Dodoma Regional Referral Hospital. Firstly,
voice please.
Firstly, I want to congratulate HPSS project for huge work working during the 12 years at Dodoma regions. HPSS project help us engineers and technicians for building as capacities of trainings for various types of equipment which help us to perform equipment on various equipment. Also, HPSS help us working tools that you are used during the service of the equipment, which help us to simplify our works and make the equipment in good conditions, which include maintaining that equipment. Also,
thank you Magige. Dr. Ibenzi, in your opinion, In your opinion, what are the major impacts of health technology management in improving the quality of services and on the management of healthcare system? In your opinion, what are the major impacts of health technology management in improving the quality of services and on the management of healthcare system?
Okay, thank you. I remember during the time of once I came back from my Master of Medicine from Muhimbili, I was appointed to be the first prime vendor coordinator in the region. At the beginning, I knew the only medical equipment or medical device which can be serviced or can be maintained, I knew only it was just an X-ray machine and the ultrasound. I knew others. I knew, but once it is not functioning, it should be thrown away. They become a waste. But the coming of HPSS helped us. There is a lot on maintaining most of the equipment. Like the one was shown that the anesthesia machine and the other medical equipment was able to be serviced, and they came back to the original functioning. So with the major impact is the reduction on the budget of buying or procuring the new devices. Following the HPS training, by medical engineers who are able to repair this machine. So we thanks to the HPSS and the other people who really participated on facilitating this HPSS, which taught us a lot. So we thank the HPSS and the other stakeholder who really they worked with, especially in Dodoma, because we are the pilot region. We did a lot after HPSS, and if you come back to our hospital, I remember we had a lot of medical devices were just thrown away. We thought that they are no longer functioning, but we thanks to Mr. Arkebi, they journeyed together with the others biomedical engineering in the region. Then actually they taken back and they maintain those equipment, and now most of them they are working. And the budget for buying other equipment just was really reduced. Now we are buying medicine. We know buying one medical device, sometimes you can procure a lot of medicine, and we know once you come to the hospital, most of the people they equate the quality of the health facility and the health the quality of health service at the hospital they usually equate with the medicine availability. If the medicine availability is low, then most of the people they say that facility is not performing at the level which we do expect. If they come to the hospital, then they get a medicine, then they say, yes, that hospital is doing fine. Is what actually the impact it has been built through the HPSS. Thank you.
Thank you, Dr. Ibenzi. May I take this opportunity to welcome the members of the floor if they have any question to ask our panelists and keynote speaker so that they can respond. Mwenye maswali? Professor Seni? Karibu.
So thank you very much, all the panelists and the moderator. I think I don't know if it will be a comment or just a question. We understand currently the government has introduced a special, like a scholarship for some of the key postgraduate programs and even in undergraduate programs. And this actually came when we were faced with the pandemic of COVID. And you can see now there are clear sponsorship for scholarship for special program like radiology, anesthesia, emergency medicine. So can we maybe make also a deliberation that this new field of medical engineering to be also one of the priority in our government in terms of scholarship for both the diploma, bachelor, and also postgraduate level. I think if we come up with that, that will be also very, very important, because now we have actually rolled out so many machines, CT scan, MRI, ultrasound, digital x-rays. But then if you don't invest in human resources, equally like how we are investing in other medical and health related specialties, I think all this investment that we are pushing into the hospitals will just turn into vain. So I strongly recommend, like, we also come with a deliberation that we advise the government to also put scholarships from diploma to master level for in the field of medical engineering or biomedical engineering. Thank you.
Thank you.
Yeah,
Siana.
Yeah, I just want to add from Professor Seni, and I want to ask Engineer Mvanga if now the biomedical engineer are part of the government employment. If not, I think it's critical to have a deliberation so that they can be part of employment scheme in the government. Thank you.
One last question.
Thank you very much for your good presentation and experience sharing on this biomedical engineering issues. I have one question. On the CCHP budget allocation, that 5% is supposed to go for health commodity. But within that 5%, 5% is supposed to be allocated for PPM of medical and dental equipment. On your experience, are they the cancer? Are they usually allocate this 5%? And the second question is this 5% from the 35% of health commodities, is it enough to conduct PPM or biomedical engineering activities? Thank you.
Thank you very much for good comments and questions. Before I welcome the panelists, I would like to ask special question to Suniva. Then from there, other panelists will respond. Other questions from the members of the floor. Engineer Suniva, in your opinion, there has been heavy investment in the area of health technology in the country, from simple, advanced to sophisticated equipment and devices. What is the plan of the government on ensuring these equipment are properly used, well maintained, for continuity of services and sustainability? Also, how is the management of MEMIS facilitate in improvement of equipment management at the ministerial level to the facility level? Welcome, Suniva.
Yeah, thank you. Yeah, thank you, moderator. Thank you, Mr. Moderator. From your permission, also I would like to reply the first question, which aligns with your questions now. Regarding to the management of the heavy investment done by the government relating to the modern technology, the ministry has several plans to make sure sustainability of this investment. Simultaneously, this thought is going parallel to the training institutions. During procurement, in the procurement contract, there is a phrase insists the user and biomedical engineering training prior with the supply of the equipment. Then there is place to make sure availability of spare parts in the entire life of the equipment as per manufacturer's instructions. So these are well stated in the procurement contracts. And special training is being provided now based on the specific technology of the equipment. Also, we have already started to make the zonal maintenance workshops in the country. As said, we expect to have 6 zonal maintenance workshops with the high-tech knowledge for the maintenance of the equipment. This will bring the maintenance referral systems starting from the lower health facility to the national health facility with the lower or with the least technology of the investment to the high-tech technology invested in the country. I can insist that all of us knows that biomedical engineering is a new field in the country. Also, the training institutions were not existing. Parallel with my reply, the training institutions also is investing to train their trainers to the high level or to the specialized training to make sure those investments which is being done by the government also will be accompanied with their training institutions. Then there is a question about the budget for CCHP. It's true 5% is said or is spoken to be said for the maintenance activities that we call plant preventive maintenance. It's not enough, but there is a mother guideline which states percentage for the maintenance of the health infrastructures. When we talk about infrastructure like building, water, and others, you need to set 9 to 15% of your total yearly budget for the maintenance of infrastructures expected of medical equipment. This is the first point what you have to note. 9 to 15% for the infrastructures. This we can say water, electricity, renovation for the buildings, and so on. Then when you come now specific to the medical equipments, out of the investment cost value of your equipments in the health facility, you need to set between 4 to 6% of the total investment value of your equipments as a budget for year plant preventive maintenance. But when I say plant preventive maintenance, includes corrective, predictive, and so activities for the maintenance. That is stated in the policy for the health technology management. Then for the third question about the MEMIS. MEMIS is Medical Equipment and Infrastructure Management Information System, which was initiated by the HPSS. By then it was called Open Medis. This was an open software which we used to conduct the inventory as a pilot in Dodoma region. Then this had a transition, now it's called MEMIS from the Open Medis. In this MEMIS, there are several modules for management of the health infrastructures. First module in the MEMIS is the inventory of the medical equipments, inventory for the infrastructures, all are available in the MEMIS. Then we go to the maintenance module. In the maintenance module, you can find now the maintenance plans for the equipment in the health facility. Then in the maintenance module, there also is a sub-module for the preventive maintenance. The MEMIS can alert you when there is a need or when there is very close to a particular equipment for the preventive maintenance. Then we have the stock management module. For the stock management module, there is for consumables stock and spare parts stock. There you can see what is needed during the maintenance activities. Then I have a very limited time, so I will not go very far. As before, we have a lifespan for the equipments. MEMIS also can predict the depreciation of your technology, then also can advise you when close to the disposal of your technology.
Thank you very much, Suniva. May I welcome Mvanga to make the last comment before I hand over the session to the main facilitator.
Oh, thank you so much. And
1 minute, please. 1 minute.
okay. Yeah, concerning the scheme of service, the biomedical engineering cadre is in the scheme of service since 2009. That's why the employment are ongoing. And also maybe I could say that the bottleneck of maintenance and also healthy technology management in the country, as it was been said that the availability of spare parts, it is very crucial because the suppliers, most of them, they just bring new equipment and sell to us, but they don't consider facilitating the availability of spare parts. And also working tools for the employment which is undergoing to a different facilities. Really, we need the government also to support working tools to those facilities so that biomedical engineers, they cannot be bored at the facilities. They have to work because they have got working tools. And also standardizing the infrastructure for workshop. And my last thank to HPSS, as they have trained us, and we are now ready to move forward to implement the HTM in the country. And they have given us, built us a center of excellence for calibration and maintenance in Tanzania. And in East Africa, we are almost the third. The first one was in Kenya and Uganda, the second. We are the third one, but we have got a very beautiful building. And also it is equipped already.
Thank you very much.
We need to utilize
Thank you
that
very much, Engineer Mvanga.
Thank you.
May I take this opportunity to appreciate all the panelists and the keynote speaker for their wonderful comments. And also, may I take this opportunity to thank HPSS for having utilized the experience of the retired personnel like Mr. Mpuya, Dr. Mpuya, Dr. Machibia, Professor Meshak, and the like. They have contributed a lot to the performance of the project, and today we are celebrating their experience. The younger generation have learned a lot from them. Thank you very much for your contribution. We still need your support. Whenever we ask for, please be ready to offer your support. Thank you very much.
Thank you very much, Dennis, for leading this session. Like the previous ones, I believe that this session has been very productive. It has contributed to our learning and gathering the history, the background, and notifying the future and what could be done to make use of the achievements that have been registered by the project. Now we are struggling with time, as has been announced by Ali Kebi earlier, that, sorry, did you say something? Professor umeniambia kitu? Okay. As has been announced by Ali Kebi previously, that the guest of honor for closing ceremonies, the Minister for PRH, will be here at 1:30. So we are left with only 30 minutes before that time. We shall try to run the health promotion panel discussion. We hope that within the 40 minutes to come, if he arrives on time, then we shall hold him for 10 minutes. But let's make sure that we spend 40 minutes to run the health promotion panel discussion. I call upon the moderator as well as the panelists to be very brief and concise. If some of the things that have been previously discussed, we can skip that and bring on only the content that we haven't discussed so far. So I would like to take this opportunity to welcome the moderator for the health promotion. It's very unfortunate I didn't get your bio earlier. So please introduce yourself briefly and then talk over. Thank you.
Good afternoon. My name is Stephen Kibusi. I'm from the University of Dodoma. I'm a senior lecturer there in public health. And somehow I think I've done some work, mainly my work in health system research. So I happened to work with the likes of Alikebi and other people who did their PhDs under HPSS. So somehow I'm aware and I know a lot of things that have been implemented within this through this project. So this is a privilege to be here, and I think we've been warned about the time. So I'll go straight by inviting the keynote speaker, Mr. Alikebi, so that once we finish, then we will see if time allows to invite the members of the panel for the discussion. Maybe I can just invite them straight. Should I invite them directly? Yeah, so the member of the panel, Dr. Tumaini Haonga, Mr. Selemani Yondu, Ms. Lona Mzirai, Mr. Nelson, Mr. Carl Limo, Mr. Saidi Muya. It's not allowed, okay. So Dr. Karume, I'm informed that Mr. Muya is not around. And then do we have Dr. Eva? How about and Fatima? Okay. Okay. Yeah. Maybe before we invite the member of the panel, I'll just give everybody very briefly, maybe half a minute, to just introduce yourself, and then we can proceed with the presentation. Yeah.
My name is Dr. Karume. Currently, I'm serving as the Mbeya Regional Dental Officer. I'm also working with HPSS back then in Dodoma at Kondoa District Hospitals. I'm holder of a degree from the University of Dar es Salaam, also a master degree from Bugando Health Institute. Thank you.
Okay, my name is Carl Limo, working as a regional health officer of Morogoro region for past 15 years, and transferred to Dodoma also as a regional health officer. Health promotion will be one of my priority during my work.
Good morning. I think it's still morning, eh? Chana. Oh. Okay, good afternoon, everyone. My name is Selemani Yondu. I'm working with PRH, and I started working with HPSS when I was working at Bai District Council in Dodoma region. So I have experience with this project for 10 years. My bachelor degree is in environmental health sciences and a master's in health economics. Thank you.
My name is Aisha Abubakar from Wihuma Dispensary. Is one of among of the health facility. HPSS work with them. Thank you.
I would like you to invite Beatrice Tito. You also be one of them. I mean, one of the members of the panel. there are a few changes. Some of the members are not present, are absent. So we made some late replacements, and we thank the people who accepted the invitation. So Beatrice, may you introduce yourself a little?
Thank you very much. My name is Beatrice Tito from the Ministry of Health, and I am the Afya Call Center Supervisor currently. The Afya Call Center is greatly supported by the HPSS project during 2020. Thank you very much.
Yeah, thank you very much. And now with, we should not waste more time. So I'll just invite the keynote speaker, Mr. Kebi, to make the presentation.
Asante sana. Naomba presentation tafadhali. Well, basically, we are going to share with you some highlights on what we have done in terms of supporting the reforms and strengthening of health promotion practices in Tanzania. We have done a number of activities from phase 1. At the moment, we are sharing the information. We shall refer the last outcome as we did for the previous presentation. Similarly, in this particular work area, we wanted to achieve a state whereby the government has required structure, staff capacity, tools, and procedures for effectively implementing and managing community and school participatory health promotion interventions. So we did this activity as a facilitating agents with the government to make sure that they do it. At this particular phase, it was a small intervention, just aiming at institutionalizing the intervention in the system of the government. So I'm pleased to have some of the colleagues here whom we work together in this area, Mr. Limo, who have been very instrumental in the implementation of the pilot here in Dodoma as a former RHO. We have also Dr. Kalume, who we worked together. He was still working back then in Kondoa District Council, among the very area adapter of the approach. And also we have Mr. Suleiman Yondu. Well, Suleiman was working in Bahi District in our first and second phase. So he worked very well with the community engagement in total-led sanitation and the school-led sanitation in that particular area. And very fortunately, he was appointed and elevated to the office of PORAG, where we continue working with him in order to institutionalize these lessons we have drawn from the pilot initiative in Dodoma. So when we started, as in many other places in Africa or in the world, we noted that the health promotion, the way it was implemented, was not following the Ottawa Charter principle, but was rather a top-down approach. And the main approach which was used was health education. And it was expert-led, whereby we have people from the central level who would go to a community and educate them. And after the session, they will go back to their district town or to their regional town and leave nothing very comprehensive to the community of which they could do on their own in order to improve their health and well-being. It was mainly concentrating on supervision, whereby you find a team from a council or a region, they are going down to supervise, and also the inspection of business styles, looking into whether people have got aprons, whether they've got their hair shaved, they have cut their nails, and something like that. So it was not really engaging community in terms of improving their health. And as I said, it was a district-led health promotion, and the population was left as a passive receiver of the intervention, which was contrary to what the WHO principles were guiding us through the Ottawa Charter. So this chart just summarizes what happened. So in order to reverse the situation and improve it, we adopted the Ottawa Charter 5 work areas of actions. So one is to build the public policy. We started looking into what policies are existing in terms of guiding the health promotion intervention. We also looking to what creative environments were existing and what are the gaps in order to bridge that gap. And then we look into the strengthening of community action. What already are community doing in order to improve their health and well-being? So we can build on that in order they can own, for them to own the intervention further. And also we look into how best the personal skills were developed for people to develop self-efficacy, but also to understand how to address the challenges. If they need to develop any mechanism, how to do it, and what kind of skill set will be required for such to happen. And of course, we were looking into the area of how we can reorient the health services which are currently or still back then were offered by the primary and secondary level of care. So our intervention mainly were concentrated in these 5 main areas of action in order to reach where the WHO was aiming at through the Ottawa Charter and through the definition of the health promotion. As is stated, it's a process of enabling people and groups to increase control over and to improve their health and quality of life. So it's not for the government to do that, but rather for the government officials to facilitate that procedures or process to happen for individual to take responsive actions and the likes. So what we did, we strengthened capacity of key staff with up-to-date health promotion activity. The stakeholder in Dodoma normally refer that as Milembe training. So we had a massive training of community development officers, health officers, and social welfare officers. Around 168, they received that training in order to introduce these approaches and techniques of health promotion and to guide them on how they could facilitate the community to identify their own health concerns and needs, and so to develop their own plans of actions, and for identifying local available resources in the facility, mainly human resource, for example, village health workers or community health workers, and the resources available at the district level, the different personnels, the different resources like educational materials and financial resources through CCHP. We engage the health system at all levels in the health promotion and participatory approach for health. Not only that, we went further to integrate different other sectors into the health promotion, because health promotion is not an approach or an intervention that could only be implemented by the health sector. It is multi-sectoral approach. If you look at the determinant of health and well-being, you can find many other aspects that need to be addressed, such as environment, food and nutrition, housing, and many others. So for that to happen, we had to engage as a department in the system to collaborate together in order to deliver what was intended in that area. So the focus has also been on school and health facility, whereby we facilitated the process of development of a joint action plans. Because for school to be able to implement the health intervention, they will need an expertise. And the expertise are available in the facilities or from the health officers. So nearby schools and the facilities, they were joined up together to develop the school health plans, of which they identify intervention which they will do and activity. For example, screening of students, vaccination, prophylaxis provision, and health promotion activity. These were drawn and were implemented together by the schools and the health facilities. We engaged the community development officers and health officers, as well as ward education officers, in supervising and supporting the community engagement and empowerment. We have very few health officers around, not only in Dodoma, across all the regions, but we have many development officers. And we look into their job description, but we also went further looking into the policy guideline and the policy of the community, community development. In those documents, you will see health promotion is listed there. but they were not implementing it. They left it to the health department. So we have to engage by, first and foremost, lobbying the department heads to refer them back to their own document that guiding their day-to-day activity. And we agreed to wherever that they even changed the work job description for the community development officer, and they were assigned to implement these interventions for health promotion in the different areas, including hygiene and sanitation, nutrition, and school health activities. We engaged ward education officer as a pilot here in Dodoma, and later on we were able to succeed to integrate that in the national WASH guideline, whereby they were given task to support school WASH activities, because they've got a lot of resources, but we are not optimally used for the impact of the school population and the community at large. So that we achieved, and they were engaged. We are very happy until today. That continues. Sorry. So apart from that, we went on to support the health promotion supervision, because what we found, CHMTs, RHMTs, they were doing a general supportive supervision. In their assessment tool, there are only 2 issues on health promotion. One, we are looking on the inspection of business stars. The other one was on the vaccination. Mainly, they were looking at those elements. And in some region, they were including some few elements of health promotion activity, but focusing only on the vaccination. But the health promotion remained weak in terms of its visibility, even at the RHMTs and the CHMTs. So it was not possible to have any intervention to be approved and supported by the management. So we designed this intervention, we piloted it in Dodoma, and we engaged the team which went around the district to supervise health promotion, looking at all key intervention areas as set out in the CCHP and other government tools in order to ensure the activity for health promotion are implemented, reported, and the results are also noted. That was done as a pilot, and we are very happy by 2017, the assessment by the Ministry of Health and PRAG was done on the tool, and the decision were made. It was then rolled out across the country and is being used to date. So we support also establishment of the training center at UDOM, where they are running short courses, but some of the modules that we have introduced there, they've been integrated to their core courses as they call it elective courses, huh? Elective courses for public health. So they are doing also intervention in that area. So people who are graduating at master's level and first degree, they've come out already with a good understanding of what health promotion is all about, different from the perspective we had before. I recall when we were introducing the health promotion supervision to the RHMTs from across the country, and we introduced these principles of health promotion, they were looking at us like, where are you from? From which planet are you coming from? All along, we have been told health education is health promotion, but why are you changing it? They say it's not us, it's the principle we have from the WHO, but also from the National Health Policy. So the problem was the training, not for you guys. Wazee wananiangalia fikiri nitakutaja, sikutaja. Dr. Wachibia. So Limo could attest to that. So we had to change the mindset of those learning the business of preventive health and public health. It was not easy, but we achieved that, and we are very happy. We shall hear more stories from our colleagues here. We went on to facilitate training of the school health coordinator and the community health promotion coordinators across the country. So we have organized a training together with UDOM. They were trained and in these approaches and techniques, and now they are implementing it, but the implementation level varies across in one region and the other. So I'll skip this slide because it will come back again. So all in all, from the pilot level where we did and what has informed the national intervention, we had a total of 254 student screening session conducted in the primary and secondary schools of Dodoma. We shall hear whether this exercise is ongoing or has been stopped, of which we have 90,000 students, children were screened on the different areas, including oral health, eye, earworm, and schistosomiasis. Out of those, 2,532 children were referred to specialist service after they were detected with more complicated cases. We had some children have a very complicated eye problems, which were not, could only be addressed from the RRH. Over 1,000 health promotion sessions were conducted in 402 schools. 100 schools installed over 195 hand washing stations for promotion of hand hygiene, which is very crucial for preventing of avoidable and preventable diseases. 760 school clubs were established in the Dodoma region, and that also informed the school wash guideline on how best they can do it to quickly replicate establishment of these school clubs. And then we have 93 plus students participated in those awareness sessions, and we shall hear from our colleagues here what has happened and what is currently ongoing. This technology is not very friendly. So we have done quite a number of interventions in those areas, but the good thing that we agreed with the government is to anchor all the interventions in the government policy for sustainability. So we have a number of guidelines which have included the experience from HPSS. So that, I think, marked the end of my presentation, and we shall stop here because the guest of honor has just arrived. I've got a signal. Perhaps suggest the panel to move a bit, and then we shall reconvene. Naomba tukakae, tupange vizuri hapa. Secretariat, naomba kuja hapa tusaidiane kuarrange mbele hapa. Samahani, nafasi yangu imebadilika tena kutoka kwenye mwasilishaji kwenye shughuli nyingine. Secretariat, naomba tusaidiane kuweka meza vizuri haraka haraka. Nicholas. So we have to adapt our program now, as we have to allow for the guest of honor to come. Naomba meza zile kule pale nyuma. Naomba usinyama.
Mgeni wetu anaingia. Naomba tusimame. Kaa mwishoni kabisa. Vivian, next too. Habari za saizi tena ndugu zangu. Mheshimiwa Naibu Waziri, Ofisi ya Rais TAMISEMI, tunakukaribisha katika kikao chetu hiki. Tupo hapa tangu jana. Leo ni siku yetu ya pili na tunashukuru sana kwa kutenga muda kidogo kuja kushiriki nasi na hasa katika kuhitimisha. Wenzangu najua wamekuhabarisha kwa muktasari kidogo ulipofika madhumuni ya kuwepo kwetu hapa, lakini nilipenda nitumie muda huu kukujulisha ni akina nani hasa ambao wako hapa kwenye meza yako kuu. Kama ambavyo nadhani umeshagundua, tuna mwakilishi wa balozi wa nchi ya Switzerland nchini Tanzania. Balozi mwenyewe tulikuwa naye jana wakati wa ufunguzi. Hali kadhalika kushoto kwako ni mkurugenzi wa mradi ambao ndio tuko hapa katika kusherehekea kufungua kwake, ndugu Manfred. Tunaye pia mwakilishi wa permanent secretary Wizara ya Afya, ndugu yetu anaitwa Dennis. Bahati mbaya PS mwenyewe ameshindwa kufika. Na vile vile tuna mwakilishi wa permanent secretary kutoka ofisi yako, Wizara ya Ofisi ya Rais TAMISEMI, na tunaye pia mwakilishi wa Maras. Tunaye dada yetu hapa Rehema anawakilisha Maras. Tulikuwa na idadi nzuri tu ya RAS ambao ni beneficiaries wakubwa na watekelezaji wa mradi huu. Kwa hiyo bila kupoteza muda, tuko hapa katika kumalizia ngwe yetu ya mwisho. Jana tulianza kwa kupata historia ya mradi, mikakati, kwa nini mradi ulikuwa umeanzishwa, mikakati gani ilitengenezwa, utekelezaji wake ulikuwaje, mafanikio yaliyopatikana ni nini, tunajifunza nini katika miradi hiyo. Leo tulikuwa katika kufanya what we call critical reflection katika hizo achievement na kuangalia ni mambo gani ambayo wenzetu wanatuachia kama vitu vya kusustain, lakini ni maeneo gani ambayo ni kama vile ni unfinished agenda, unfinished business ambayo tunahitaji sisi kwa umoja wetu kujihakikisha kwamba tuko sawa kuyaendeleza. Tumepata vile vile fursa ya kuangalia changamoto na maeneo ambayo yana mapungufu ili tuweze kuendelea kuyafanyia kazi. Mjumuiko huu usingeweza kuwa kamili iwapo wadau wengine ambao wako mbele yako wasingekuwepo. Kwa hiyo tunao wawakilishi kutoka mikoani, wenzetu waganga wakuu wa mikoa na ngazi zote zinazofuata chini. Tuna wenzetu ambao wamekuwa wanatusaidia katika kufadhili shughuli mbalimbali za maendeleo, yani development partners. Tuna wadau wengine ambao wametusaidiana na serikali katika kutekeleza miradi mbalimbali including mradi huu, na kwa namna moja ama nyingine walishiriki, yani kundi tunalopenda kuita implementing partners. Na tuna wadau wengine kutoka ofisi za umma na taasisi zisizo za kiserikali, waandishi wa habari na kadhalika. Kwa hiyo kwa heshima na taadhima, ningependa kutumia fursa hii kwanza kabisa kumkaribisha ndugu Manfred ili aseme neno kidogo wakati huu tunapohitimisha shughuli hizi, ili atoe muktasari kwako na alafu tutaendelea na ratiba. Karibu Manfred. Yes. If you want I can bring the mic.
Asante sana. So I have to switch to English. My Kiswahili is not so fluent. I just want to make it brief. I want to thank the PIORALC and also the Ministry of Health and all the partners for their cooperation, and the guest of honor today for coming here and officiating the closing of our project after 12 years of support rendered to the government of Tanzania in the health sector. We worked together in a lot of areas. We worked on the reform of the community health funds, creating the CHF Ilioboreshwa as a stronger and more powerful health insurance for the general population, especially in the rural areas. We worked on reforming the supply chain management and had some improvements here in the availability of medicine. We worked on health technology management and also on health promotion. So all this has been a very fruitful and exciting journey, and we thank our partners for this great collaboration. So thank you very much. Asante.
Thank you very much, Manfred, for this very brief and concise address. Next, I would like also to invite the representative of the Permanent Secretary from PRAJ to just say a word. We have the opportunity to hear quite a lot from your office, mgeni wetu rasmi, lakini for the sake of this audience, then tunamkaribisha dada yangu Subie ili aseme kitu chochote kwa niaba ya Permanent Secretary of PRAJ.
Jamhuri ya Muungano wa Tanzania, habari za mchana. Ndugu mgeni rasmi, naibu waziri toka ofisi ya Rais TAMISEMI, mwakilishi wa balozi wa Swiss, ndugu katibu tawala mkoa wa Dar es Salaam ambaye amewakilisha makatibu tawala wote, ndugu mwakilishi toka Wizara ya Afya, ndugu washiriki wote. Ofisi ya Rais TAMISEMI tunapenda kupongeza kazi nzuri ambayo wenzetu wameweza kuifanya kuhakikisha kwamba huduma ya afya inatolewa kwa wananchi wetu, lakini pia tunashukuru kwa huduma zote ambazo zimeweza kutolewa kutokana na huu mradi ambao ofisi ya ubalozi Swiss imeweza kusapoti nchi yetu, lakini pia tunashukuru ofisi yenu pia kwa kushirikiana na wizara zote, Wizara ya Afya pamoja na ofisi ya Rais TAMISEMI, kwamba sasa tunafunga huu mradi, na kufunga kwetu kwa mradi tunasema ni mwanzo wa utekelezaji tena wa mradi mwingine, kwa sababu kama tunavyojua matatizo bado kwenye jamii yetu yapo, na kama alivyosema asubuhi mgeni wetu naibu katibu mkuu, ni kwamba bado tutaendelea kuomba ushirikiano kutoka kwenye ofisi yenu kuhakikisha kwamba hizi huduma ambazo tulikuwa tumezianzisha kuhakikisha kwamba tunaziendeleza ili wananchi wetu wakawe na afya njema, lakini pia ili kuboresha uchumi wa nchi yetu. Ndugu mgeni rasmi, kazi yangu ni ndogo tu ambayo nimepewa kwamba niweze kushukuru. Kama jana tulianza kikao na tumejadili mambo mengi, mambo mazuri ambayo program imeweza kusapoti, lakini pia na changamoto mbalimbali ambazo zilitokeza wakati wa utekelezaji. Nadhani yale ambayo kama watekelezaji ofisi ya Rais TAMISEMI kama watekelezaji tutachukua na kuweza kuboresha maeneo mbalimbali ambayo yataleta manufaa kwa wananchi wetu, lakini na yale mazuri pia tutayaendeleza kuhakikisha kwamba yanakuwa incorporated kwenye mipango yetu ya wizara ili kuhakikisha huduma zote zinatekelezwa katika mamlaka za serikali za mitaa. Baada ya kusema hayo, nashukuru sana.
Asante sana dada Subie kwa niaba ya Permanent Secretary kutoka ofisi ya Rais TAMISEMI. Tunafahamu kwamba kazi yenu ilikuwa ni nzito sana katika mradi huu, ingawa umekuwa unarifaa kwamba project imewasaidia, lakini we understand that everything has been implemented through you. The project brought ideas, technical support plus financial support, but you were really the doers of everything. Thank you very much for your remarks. Naomba nichukue fursa hii pia kumkaribisha mwakilishi wa Permanent Secretary kutoka Wizara ya Afya, naye aseme neno kwa ufupi kuhusiana na mradi huu kama viongozi wetu katika miongozo na sera. Karibu Bwana Dennis.
Asante. Mheshimiwa Naibu Waziri, Ofisi ya Rais TAMISEMI, Mheshimiwa mwakilishi wa balozi wa Swiss nchini Tanzania, Mheshimiwa mwakilishi wa makatibu tawala mkoa, katibu tawala mkoa wa Dar es Salaam ambaye ni bosi wangu, ale ni mentor tokea nikiwa ndo naanza kazi, Mheshimiwa mwakilishi wa katibu mkuu Ofisi ya Rais TAMISEMI, Mheshimiwa washiriki wenzangu, kwa niaba ya PS Idara ya Afya, napenda kutoa shukrani zetu za dhati kwa Wizara ya Afya kwa project ya HPSS kwa kuwezesha kuleta innovation ambazo zimesaidia katika kuboresha huduma za afya nchini. Bila mchango wao, pengine tungekuwa na changamoto ambazo tusingeweza kuzitatua. Lakini mchango wao kwa kufanya kazi kwa pamoja, wafanyakazi wa Wizara ya Afya na Ofisi ya Rais TAMISEMI, tumeweza kufanikisha innovation mbalimbali ambazo zimewezesha kuboresha huduma za afya nchini. Hivyo basi, nihitimishe kwa kusema kama mwenzangu wa Ofisi ya Rais TAMISEMI alivyosema, kufungwa kwa mradi huu ni mwanzo wa mradi mpya. Kwa hiyo tunaikaribisha ofisi ya Swiss, balozi wa Swiss, mje kuwekeza kwenye afya kwa ajili ya Watanzania ili mwisho wa siku tuweze kuachieve one health, one goal. Asanteni.
Asante sana Dennis kwa a very brief remarks. Ninaomba niseme kwamba tunatambua uwepo wa wawakilishi wetu, wawakilishi wa wananchi bungeni, kwa maana nyingine wabunge. Tunatambua kuna wabunge wengine wamekuja lakini hatujawapatia mahali pa kukaa. Naomba kama wapo wasimame tuwaone. Tuna mmoja hapa mbele, Mheshimiwa Lusinde, ambaye tutampa nafasi ya kuzungumza kwa niaba yao. Lakini wale wabunge wengine kama wapo hapa ndani, tafadhali simameni tuwaone na tuwashangilie kwa kutenga muda kuja kushiriki na sisi. Kama hamjaingia ndani, it's very unfortunate, lakini tunafahamu kwamba mlikuwa na commitment ya kuja. Kwa hiyo basi nitumie dakika chache kumkaribisha Mheshimiwa Lusinde. Hatukukuandaa kutoa hotuba, lakini mimi ni mpenzi wako na kuaminia hushindi kupata neno la kusema. Karibu sana.
Mheshimiwa Naibu Waziri, Ofisi ya Rais TAMISEMI, Mheshimiwa Lasi wa Mkoa wa Dar es Salaam, dada yangu Lema Madenge na shemeji yangu kwa kweli, mwakilishi mkazi wa balozi, pamoja na washiriki wote. Awali ya yote nimshukuru Mungu kupata nafasi hii adhimu ya kuja hapa. Ni kweli mawasiliano hayakuwa mazuri, lakini tunashukuru kwamba tumefika. Jambo kubwa hapa ambalo nimeweza kulisikia kwa kufika kwangu hapa ni kwamba kwa niaba ya bunge, na sisi tunashukuru sana hawa wahisani wetu ambao wamekuwa tukisaidiana na serikali kwa ajili ya kuboresha afya za Watanzania, na hasa kipindi hichi ambacho kwa kweli changamoto zimekuwa nyingi. Kwa hiyo kwa niaba ya wabunge wenzangu tunashukuru sana kwa semina hii ya siku mbili. Tunahakika kwamba tumekosa kusikiza sauti zenu, lakini tutapata walau vikonyo vya kwenda kuvisoma na kuvifanyia kazi siku za usoni. Asanteni sana.
Asante. All right, so I would now take this opportunity to invite the representative of the Honorable Ambassador of Switzerland in Tanzania to address the audience and enlighten the guest of honor for our closing ceremony on what have you gathered from the 2 days of discussion here and what are the prospects. We have put ahead a lot of requests. If you are able to, please provide us with some commitments as well. Karibu sana.
Honorable Minister, Deputy Minister of President's Office, Regional Administration and Local Government Authorities, Dr. Frédéric Lugangwe. Distinguished representative of the Ministry of Health, Ministry of Community Development, Gender, Women and Special Groups, Ministry of Parage and Ministry of Finance, dear guest, dear participant, dear partner, all protocol observed. Ladies and gentlemen, mabibi na Mambwana, sorry, habari za mchana. It's a privilege and a great pleasure for me to be here today and to make some closing remark on behalf of my ambassador Didier Chassot, who unfortunately couldn't stay for the 2 days. Yesterday and today, during this closing workshop, we heard a lot of impressive achievement, the challenges that were faced, and how we addressed them to reach the overall goal of the HPSS project. It was, and it is, an excellent, well-organized 2 days workshop. We are, Switzerland, very happy to see the great participation and fruitful discussion and exchanges. Switzerland is also very much motivated and encouraged by all these positive results and feedbacks and achievement reached together thanks to this fruitful collaboration and work of all of you here. Of course, a lot remains and needs to be continued. On behalf of Switzerland, I would like also to recognize again all the numerous partners who have been engaged in this joint endeavor over the past 12 years. In particular, I would like to acknowledge the strong leadership of the Tanzanian government counterparts, the Ministry of Health, the President's Office, regional administration and local government authorities, the Ministry of Finance and the Ministry of Community Development, Gender, Women and Special Groups. Without whose commitment, dedication and ownership to the project, idea and implementation, we would not be here today. Of course, I also acknowledge the presence of the civil society organization, NGO, research and academic institution, all the health personnel across the country that worked closely with the HPSS project. Last but not least, let me also extend my special thanks to the entire HPSS project team under the great management of Ali Kebi, as well as the Swiss Tropical and Public Health Institute under the leadership of Manfred Stormer, for their essential key role in building trust and achieving remarkable successes. Allow me also to take this opportunity to thank all the experts, the retired experts who are here today. Thank you very much for coming today. Also for the expert who came from Switzerland and far away, and here Mr. Giry, I heard you put a lot of brain into the CHF EMIS. Thank you very much for your engagement. Honorable Deputy Minister, dear all, the Embassy of Switzerland is very proud of this fruitful cooperation in strengthening Tanzania's health system. We are confident that the government of Tanzania will sustain this joint legacy and further build on it, especially in view of the envisioned universal health insurance. With the handing over of the HPSS business processes going on, we wish the government of Tanzania all the successes, and I can here today confirm and assure that Switzerland will continue its commitment to support the Tanzania health sector, especially on UHI and primary healthcare support. I wish you all a good continuation of the workshop. Asante sana kwa kunisikiliza.
All right. So just to run quickly with the program and observing the time that the Honorable Deputy Minister has, ningeomba nitumie fursa hii kumkaribisha dada Rehema Madenge kwa niaba ya marasi wote Tanzania. Kama tunavyofahamu, mradi huu ulikuwa unaimarisha mifumo, na when you are strengthening systems, it means that the beneficiaries is across the whole country. Tukirekebisha mfumo wa taarifa, then the whole country is benefiting. Tukirekebisha mfumo wa kwa mfano wa human resource, nchi nzima inanufaika. Na wanufaika wa kwanza kabisa ambao mambo yakienda safi ni ndugu zetu marasi ambao ndio watendaji wakubwa. Kwa hiyo naomba nimkaribishe dada Rehema kwa niaba ya marasi wote Tanzania ashukuru, lakini pia ninakupa kazi ya kumkaribisha mgeni rasmi ili atufungie workshop yetu. Karibu sana.
Nashukuru sana kwa fursa hii, Mheshimiwa mgeni rasmi, Naibu Waziri Ofisi ya Rais TAMISEMI, mwakilishi wa Mheshimiwa Balozi, meza kuu, wageni wote walikuwa, mabibi na mabwana, habari ya mchana. Jamhuri ya Muungano wa Tanzania. Nashukuru kwa fursa hii Mheshimiwa mgeni rasmi, pamoja na kwamba ni mwakilishi wa marasi, lakini pia ndio mwenyekiti wao. Kwa hiyo ni nafasi sahihi kabisa kuzungumza juu yao. Lakini pia nichukue fursa hii kwa dhati kabisa kushukuru kwa mradi huu, na niseme kwamba nilikuwa miongoni mwa wale waliotekeleza mwanzo kabisa kama waanzilishi wa mradi, kwa sababu umeanza kutekelezwa hapa Dodoma na mimi nikiwa katibu tawala mkoa wa Dodoma. Lakini nikahamishwa kutoka Dodoma kwenda Lindi. Na nilipofika Lindi nikakuta kuna component ya mradi inatekelezwa Lindi, kwa maana ile ya mshitiri prime vendor nilikuta Lindi inatekelezwa. Lakini nimekwenda Dar es Salaam pia nimekuta mradi huu unatekelezwa. Kwa maana hiyo mradi unatekelezwa katika nchi nzima na tumeona mafanikio yake. Mheshimiwa mgeni rasmi, niseme kwangu mimi naona kama mradi huu unafungamana katika utoaji wa huduma kwa wananchi. Kwa maana gani? Kwa upande mmoja serikali inaendelea kuboresha miundombinu ya utoaji wa huduma katika maeneo yote, kwa zahanati, vituo vya afya, hospitali, mpaka hospitali za rufaa. Lakini sasa tunakuja na sehemu ya pili ya mradi, kuna ICHF ambao tunajitahidi kupata wateja wakuja kwenye vituo vile vya kupata huduma. Lakini hapo hapo tunajitahidi kwamba kwenye hivyo vituo vya kutolea huduma vifaa vyake tiba vinaendelea kutengenezwa pale ambapo vinapata zile hitilafu ndogo ndogo ambazo pengine wakati ule zilikuwa ikipatikana hitilafu ndogo kama hiyo, kifaa hicho kinawekwa pembeni. Sasa tuna uwezo wa kukitengeneza. Kwa hiyo huduma zinaendelea kupatikana wakati wote. Lakini tunahakikisha kwamba kuna huyo mshitiri ambaye kama dawa hazikupatikana MSD, yupo msitiri ambaye anatusaidia katika kuhakikisha hizo dawa zinapatikana kwa wakati. Kwa hiyo ninaona kabisa kuna huo mfungamano mkubwa kati ya huduma zinazotolewa na mradi, lakini kuhakikisha kwamba wananchi wetu wote wanapata huduma kwa wakati na huduma stahili. Kwa hiyo niseme kwamba ni asante sana. Tunashukuru sana kwamba hili limeweza kufanikiwa na kwamba wananchi wetu wanaendelea kupata huduma kule walipo, lakini huduma stahili kwa wakati na zote zinazohitajika kwa wakati huu. Baada ya kusema hayo, niseme sasa naomba nikukaribishe ili utufungie rasmi. Karibu sana.
Jamani, habari za mchana. Hongereni kwa kikao kizuri cha siku mbili. I would like to take this opportunity, first of all, to recognize the high table, the representative of the ambassador of Switzerland and the team from Switzerland, the representative of the permanent secretary, Minister of Health, the representative of permanent secretary, President's Office, Regional Administration, Local Government, And I would like to recognize the presence of the regional medical officers. I can see the RMO from Dar es Salaam and Katavi, and the others who are available in this hall today. Would like to recognize the presence of the gurus of health. I'm so happy to see Dr. Machibia. He's my mentor. When the representative of the permanent Secretary of Health was talking about the RAS Dar es Salaam as a mentor, I saw my great mentors, two great mentors here, Dr. Zenabu Chaula and Dr. Machibia. And I do appreciate the good work they've been doing throughout in the health sector improvement. And Dr. Chaula has been a permanent secretary, first of all, deputy permanent secretary, health, the president's office, meaning regional administration, local government. She went in the Tehama area, Mawasiliano communication. She was a permanent secretary, Minister of Health. Then community development, gender, children, the elderly. So she's a guru in the health sector and the community development at all. So I'm so happy to see you, Dr. Chaula. And Dr. Machibia is my first RMO when I was first appointed as a DMO in Ikela, Mbeya region. So he mentored me so very well. I'm so happy to see him, very young looking to date. I know he retired almost 10 years now, but he's still working with the government to make sure that we improve the quality of services. And actually, I recognize all the participants in this very important workshop. And the very, very important message here is we are all working as a team, regardless wherever you are. You are retired, you are working, you are in a different sector, but health sector, at the end of the day, is a sector of which we need to have a cooperation to every stakeholder so that we can make the achievement we want. Ndugu washiriki, ninawasalimu kwa jina la Jamhuri ya Muungano wa Tanzania. I'm here today representing the Minister President's Office, Regional Administration, Local Government, Honorable Mohamed Omar Mchengerwa, and I would like to present his speech on his behalf. And on behalf of the Minister of State, President of the Regional Administration, Local Government, Honorable Mohamed Omar Mchengerwa, and on my own behalf, I'm profoundly delighted to be invited to participate in the delivering of these closing remarks in the very important health promotion and the system strengthening project. Closing workshop that intended to disseminate HPSS project achievements and deliberate on way forward for sustainability. My thanks and congratulations go to all of you for your tireless effort in the strategic and operational implementation of the project activities and the coordination of this particular workshop. My special thanks goes to the Swiss government for ongoing support to the people of the United Republic of Tanzania in different social and economic development initiatives geared towards attainment of the Sustainable Development Goals. We thank you so much, the government of Switzerland, for that. Your Excellency, the representative, the ambassador of Switzerland, please convey our heartfelt thanks to the Swiss government. Distinguished guests, delegates, ladies and gentlemen, it has come to my attention that since 2011, for nearly 11 years, the Swiss Development Corporation, through the HPSS project, has been a crucial partner in supporting Tanzania. The support has spanned various initiatives, including health system strengthening, enhancing health commodities availability through innovations like the prime vendor system, health promotion, health technology management, and health financing. And as I speak of the prime vendor system, always I see the image of Dr. Chaula, Mshitiri, Mama Mshitiri. She actually pioneered it, and she was very well committed to make sure that we achieve in the prime vendor system in our regions when she was the deputy permanent secretary in president's office. So she did a very, very remarkable work in the PVS system in our country. The support has spanned various initiatives, as I said, and notably the establishment and institutionalization of the improvement of a community health fund in the informal sector that have been significant milestones. We have seen a lot of improvement in the improved community health fund enrollment. If you compare the number of the households before launching the improved community health fund system, actually we had a very gradual and very low number of Tanzanians who were enrolled in the CHF, the original CHF. But after improving the CHF system, we saw a remarkable improvement. The number of households and even individuals who enrolled in CHF improved remarkably, and we saw actually it was a very good step towards achievement of what we need as health insurance. So I extend my deepest gratitude for your remarkable support, starting from the pilot phase in Morogoro, Shinyanga, and Dodoma, and to the nationwide rollout. We commit ourselves to ensuring the success and the continuity of all activities supported by the HPSS project. Distinguished delegates, ladies and gentlemen, over the past 5 years, the Tanzania government, in collaboration with its partners, has made substantial efforts to improve the primary health care system. This includes the construction, rehabilitation, and equipping of healthcare facilities, as well as the recruitment of a diverse range of healthcare professions. And in this area, I would like to say, in the past, like 3 years, we have made a lot of efforts in improving health infrastructures, construction of dispensaries in villages, construction of health centers in strategic wards, construction of cancer hospitals, and actually now we have cancer hospitals almost in all cancers in our country. So a very huge work has been done in construction, rehabilitation of health facilities in order to improve the access of health services to the community. And what we need now is the improvement of the quality of healthcare services. And this discussion in 2 days, you can see most of the areas we have been discussing actually aims at improving the quality of healthcare services, which is very, very important agenda at the current in our government. Distinguished delegates, ladies and gentlemen, in the past 3 financial years, from 2020 to 2021, under the leadership of Her Excellency Dr. Samia Suluhu Hassan, the President of the United Republic of Tanzania, we have registered a massive success with the construction of 955 dispensaries for shillings 77.41 billion, 466 health centers for shillings 718.18 billion, construction of 136 district or council hospitals, and renovation of 19 district hospitals for shillings 195.53 billion. So you can see the number of facilities constructed within 3 years. Moreover, within the same period, we were able to construct 28 intensive care units, 80 emergency medical departments, and 150 staff houses for shillings 45 billion. Also employment of 18,418 staff of different cadres, and the procurement of medical equipment for a total of Tanzanian shillings 148.73 billion. Distinguished delegates, ladies and gentlemen, despite registered success, there is much work to be done to further improve health system responsiveness, equity, resilience, and overall service quality in the progress towards achieving universal health coverage. Our President, Her Excellency Dr. Samia Suluhu Hassan, has emphasized the need to improve the quality of health services in her speech during signing ceremony of new nutrition compact agreements with the regional commissioners on September 30, 2023. The HPSS project, which has generously supported us, has played a vital role in strengthening our health system towards improving the quality of healthcare by enhancing the availability of health commodities and financial resources through ICHF as crucial element within the supply side of the health system. This aligns perfectly with the strategic vision of our President, and we are immensely grateful for your cooperation. Thank you so much, the Swiss government and all the partners. Distinguished delegates, ladies and gentlemen, the Ministry of Health, in collaboration with the President's Office, Regional Administration and Local Government, is spearheading the implementation of the Improved Community Health Fund, ICHF. In a relatively short period, this reform has significantly improved the efficiency by increasing enrollment in the scheme. As of the end of September 2023, over 4,570,217 Tanzanians are registered in CHF, contributing a total amount of 33,266,521,400 as membership premiums, with 24.97 billion disbursed to facilities for membership treatments. The CHF card holders can access medical care at dispensary, health centers, cancer hospitals, and regional referral hospitals across the country. So you can see the difference between the original CHF and the improved CHF. In the original CHF, the members were entitled to have the treatment within the facility that they registered. If it is a dispensary A, they have to be treated in dispensary A. There was no crossing to other healthcare service levels. For example, from one dispensary to the other dispensary, from one dispensary to health center to cancer hospital. But by having the improved community health fund, we actually bridged the gap. Now a member can benefit at any primary healthcare level facility, from the dispensary, health center, cancer hospital, and actually we are looking forward to improve the referral system to the regional referral hospitals and even to the levels of the consultant hospitals. So we've made a lot of achievement, and we are looking forward to make sure that we continue improving the ICHF so that most of the Tanzanians will benefit through this type of insurance. Now, building upon the success of ICHF, I would like to recommend to the technical team involved in the discussion of the upcoming Universal Health Insurance Bill to explore ways to incorporate the key achievement of the ICHF model. Distinguished delegates, ladies and gentlemen, we are well aware that there is still much work to be done to address the challenges in providing quality health care. Our health systems face growing burdens from various diseases, including infectious and non-communicable diseases. And recent threats, such as the COVID-19 pandemic, have further highlighted the importance of a robust and a resilient healthcare system. Let us continue to collaborate, lead, and take responsibility to ensure core elements of high-impact interventions that enhance the quality of care are realized. Distinguished delegates, ladies and gentlemen, as I'm coming to the end of this speech, I would like to express my heartfelt gratitude to the Swiss Development Corporation through the HPSS project for their unwavering support. I also take this opportunity to request for further support from the Swiss government to continue assisting the United Republic of Tanzania in achieving the Sustainable Development Goals. Moreover, I urge all regions and the councils to ensure the sustainability of the project activities through integration of project activities within the available planning and the budget process and the collaboration with other implementing partners. So I would like to insist on this area that we've been cooperating with the Swiss government in these interventions areas for the past 12 years. As we are coming to an end of this project, it is very important to make sure that now we are going to incorporate in our budgets the implementation of these areas so that we have the sustainability of the project, we sustain the achievement, and we keep improving the achievement. That means we should not turn back again, regress from what we have achieved to date. We must make sure that we advance and improve through making sure that we incorporate in our budgets so that the interventions continue. Distinguished delegates, ladies and gentlemen, the government is excited about this collaboration, and we remain committed to supporting the efforts of all healthcare stakeholders in the country. Together we can achieve so much and learn from one another to improve healthcare for all. Distinguished delegates, ladies and gentlemen, I want to assure you that the President's Office, Regional Administration and Local Government will carefully consider all the recommendations from this workshop and utilize them to sustain the project activities. And before I conclude my speech, may I just a little bit say it in Swahili, kwamba ndugu washiriki wote, kwanza nitumie fursa hii kuwashukuru sana na kuwapongeza kwa shughuli hii ya siku hizi mbili ambayo tumejadiliana mambo mengi ya msingi ambayo kimsingi sote tunafahamu ajenda ya serikali yetu katika sekta ya afya baada ya kuendelea na ujenzi wa miundombinu ambayo Mheshimiwa Rais Dr. Samia Suluhu Hassan amefanya kazi kubwa sana ya ujenzi wa zahanati katika vijiji vyetu, ujenzi wa vituo vya afya katika kata za kimkakati, ujenzi wa hospitali za halmashauri za mikoa na hospitali zile za rufaa na za kanda. Sasa moja ya ajenda pamoja na kuendelea kuboresha miundombinu kwa maana ujenzi wa vituo, ajenda mojawapo ni kuhakikisha kwamba tunakwenda kuweka nguvu ya kutosha katika kuboresha ubora wa huduma za afya. Kwa sababu kama serikali tumeona tumefanikiwa sana kwenye miundombinu, ajira kwa watumishi, kazi nzuri sana imefanyika, ununuzi wa vifaa tiba, kazi nzuri sana imefanyika. Lakini tunaona bado tuna pengo kwenye ubora wa huduma. Na ubora wa huduma tutapima kwa upatikanaji wa dawa, vitendanishi, lakini pia level ya kuridhishwa kwa wateja wetu, wanaridhika kwa kiasi gani kwa huduma ambazo tunazitoa. Kwa nitumie forum hii kusisitiza kwa viongozi wote katika mamlaka serikali za mitaa, kwa wataalamu wote wa sekta ya afya, kuhakikisha kwanza tunatumia kikao hiki ambacho tumefanya kwa siku 2 kuona maeneo ambayo tumefanikiwa. Tumeongelea swala la mshitiri, tumeongelea swala la teknolojia ya vifaa tiba, teknolojia katika utoaji wa huduma za afya. Twende tukatathmini vituo vyetu na nchi yetu tuko katika hatua gani katika maeneo hayo. Je, washitiri wameweza kufanikiwa kwa kiasi gani kupunguza upungufu wa dawa katika vituo vyetu? Na kama hatujafanikiwa kwa kiasi ambacho tunakitarajia, nini tatizo? Changamoto iko wapi? Na hatua gani tuzichukue kama watendaji na kama serikali ili tuweze kufikia malengo ya kuhakikisha kwamba wananchi wetu wanapofika katika vituo vya huduma wana uhakika wa kupata dawa zote. Sasa lengo la mshitiri ni kuhakikisha kwamba ile gap ya MSD, ikitokea MSD hawana dawa, basi mshitiri ana supply zile dawa ili kuhakikisha dawa zote muhimu zinapatikana kwenye vituo vyetu. Sasa hilo ni jambo la msingi. Lazima tujiulize, wananchi wetu wanaridhishwa kwa kiasi gani na upatikanaji wa dawa na vipimo katika vituo vyetu. Lakini wananchi wetu na sisi kama watu wa huduma tunaona maeneo gani yana changamoto ambayo lazima tuyafanyie kazi katika upatikanaji wa huduma bora. Lakini tumeongelea swala la maintenance ya vifaa tiba, matengenezo ya mara kwa mara ya vifaa tiba. Katibu tawala wa mkoa wa Dar es Salaam dadangu Rema Madenge amesema vizuri hapa kwamba mara nyingi tumekuwa na vifaa tiba ambavyo vinatumika kwa muda mfupi, vinaharibika kitu kidogo sana, vinapelekwa store vinapotea. Kwa hiyo tunatumia fedha nyingi sana kununua vifaa tiba mara kwa mara ambavyo vinatumika kwa muda mfupi na baadaye tunashindwa kuvimaintain. Lakini workshop hii imetuwezesha kuona namna nzuri zaidi ya kuweka mifumo imara ya matengenezo ya mara kwa mara ya vifaa tiba, lakini ya miundombinu mingine ya huduma za afya kama majengo na kadhalika, ili tuweze kutoa huduma vizuri. Kwa hiyo nitumie fursa hii kuwapongeza sana sana washiriki wote, na niwashukuru sana wadau wa serikali ya Switzerland kwa kuwezesha maandalizi, lakini pia kikao hiki. Na niwashukuru sana wadau wote, Mheshimiwa Mbunge Lusinde kwa niaba ya Mheshimiwa wabunge wote, lakini wawakilishi ofisi ya Rais TAMISEMI na Wizara ya Afya na wadau wote wa serikali na taasisi ambazo sio za kiserikali. Sisi sote tunafanya kazi moja. Kazi yetu ni kuona namna gani tunaboresha huduma za afya, na lengo la Mheshimiwa Dr. Samia Suluhu Hassan rais wetu ni kuhakikisha Watanzania wanapata huduma bora za afya. Na sisi ndo tumepewa wajibu huo. Ndo tuko kwenye usukani. Sasa resources zinaletwa, sisi tupo, lazima tuone tunatoka hatua moja kwenda hatua nyingine katika kuondoa changamoto. Baada ya kusema haya, nirudie tena kuwashukuru na niseme rasmi tumefunga kikao chetu hiki, na niwatakie kila laheri katika shughuli nyingine ambazo zitaendelea. Asanteni sana kwa kunisikiliza.
Tunakuomba mgeni rasmi urudi kwenye kiti chako, na meza kuu msinyanyuke kwanza. Tunataka tupate kumbukumbu ya picha. Tunaomba wenzetu kutoka ubalozi wa Switzerland mje mbele, muungane na delegation iliyoko hapo pamoja na project staff na management yote iliyoko hapa. Njooni tupate picha ya pamoja. The embassy and the HPSS project members, please. Picha ya kwanza hiyo. Tunaomba okay. Ali is reminding me that we have non-Swahili speakers. So we are inviting members from the Embassy of Switzerland together with the HPSS project to come forward and have a photo with our guest of honor, with the high table members. While this first group photo is taken, the second round of the group photo will involve regional leaders. Barasi waliobakia pamoja na RMOs mjiandae kwa ajili ya picha ya grupu ya pili. It's a ceremonial closure of the project, so we need smiles. Dental formulas needed to be counted. Great. Thank you. Asante sana. Tunawaomba dada Zainab, please, RMOs, Dr. Nkungu na viongozi wa wizara mbili za afya pamoja na ofisi ya Rais TAMISEMI tujumuike pamoja katika picha namba 2. Minister of Health, Minister for President Office, Pioraj. Kama kuna wenzetu kutoka Wizara ya Maendeleo ya Jamii na makundi maalum pia. Wafupi wakae mbele, warefu wakae nyuma. Simsemi mgeni rasmi. Mgeni rasmi kimo chake ni moderate. Okay? Yeah. Great. Tunawakaribisha sasa, asanteni sana. Tunawakaribisha development partners na implementing partners. Tafadhali tuje tupige picha na mgeni rasmi. Taasisi zingine zote, CSOs, DPs, IPs, tafadhali. Wadau wa maendeleo. Government agencies, MSD, njooni hapo. Please. Hey, hakuna members wa group. Dada njoo hata kama uko peke yako, njoo. Njoo. Implementing partners, development partners, CSOs, FBOs, all that. Government agencies. Mstue huyo. Okay. Mngekaa kati sasa kwa sababu mko wachache, sogeeni mkae kati. Yes. Yeah. Kuki vipi bwana? Mbona unataka kuniangusha? Great. Asante sana. So to mark the end, kwa sababu hii business ni kama imefungwa, lakini sisi wenyeji hapa ndani tunajua siri yetu na aibu zetu, si ndio? Hatutaisema kwa mgeni rasmi. So we declare that this workshop has been closed kwa sababu mgeni rasmi ametamka, lakini sisi ni Waafrika na utamaduni wetu wa Kiafrika ni ukarimu, na ukarimu wa Mwafrika ni chakula, au sio? Kwa hiyo tutakuomba mgeni rasmi ufuatane na sisi, twende tukale chakula cha pamoja, halafu ndio utapewa ruhusa kuondoka, na ukikataa unatuvunjia heshima. Kwa hiyo tutairudia. Kwa hiyo ninaomba tufuatane, utuongoze Dr. Festus. Watakuonyesha njia vijana wetu kuelekea mahali ambapo tumetengeneza utaratibu wa kupata chakula. Wenzangu na mie wote tukimaliza kula chakula ni 1 hour, tunarudi hapa ukumbini kuja kufungasha virago vyetu. Tuna mambo ya kumaliza, au sio? Okay. Twendeni.
Baba mzazi, prof.
Na mama nilimpa salamu zako, amefurahi sana. Asante.
Upelelezi ni sumu ya mapenzi. Ufitina na upelelezi ni sumu ya mapenzi. Mimi kupendwa na yeye, nyinyi mwakerwa na nini? Tumependana wenyewe bila nyinyi kujua. Sasa mwajua mwanza kuleta matatizo. Mimi kupendwa na yeye, nyinyi mwakerwa na nini? Yeye kanipenda, ninampenda, nyinyi mwakerwa na nini? Nyinyi mwakerwa na nini? Yeye kanipenda, ninampenda, nyinyi mwakerwa na nini? Nyinyi mwakerwa na nini? Nafsi twazidi kuimarisha mapenzi yetu. Dunia tumekuja wawili wawili kusaidiana, ndiyo raha ya dunia. Nyinyi mwakerwa na nini? Yeye kanipenda, nami nampenda, nyinyi mwakerwa na nini? Nyinyi mwakerwa na nini? Yeye kanipenda, nami nampenda, nyinyi mwakerwa na nini? Nyinyi mwakerwa na nini? Acha fitina.
Sumu ya mapenzi.
Chico Banda, vous avez que beaucoup moule par la Jana. Uta, uta,
Ndugu wapenzi wa habari niliyopata leo, wanasema sultani ni mwanamke. Ni pasi ya wapi umeona bibi sultani? Hata kwa mababu haikuwa namna ile. Hivi Safina, kwa mapendo nilikupenda, hiyo vile unataka kuwa sultani wangu. Hivi Safina, kwa mapendo nilikupenda, hiyo vile unataka kuwa sultani wangu. Akili ya bibi haiwezi kushinda ya bwana. Akili ya bibi la 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 la. Akili ya bibi haiwezi kushinda ya bwana. Akili ya bibi sawa sawa. Wandugu wapenzi wa habari niliyopata leo, wanasema sultani ni mwanamke. Ni pasi ya wapi umeona bibi sultani? Hata kwa mababu haikuwa namna ile. Bibi Safina, kwa mapendo nilikupenda, hiyo vile unataka kuwa sultani wangu. Bibi Safina, kwa mapendo nilikupenda, hiyo vile unataka kuwa sultani wangu. Akili ya bibi haiwezi kushinda ya bwana. Akili ya bibi la 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 la. Akili ya bibi haiwezi kushinda ya bwana. Akili ya bibi sawa sawa. Nilikuelezea yao mama, patu wangu mama. Nilikuelezea yao mama, patu wangu mama. Mapenzi ya kwetu we haitaka uyaga mama. Mapenzi ya kwetu we haitaka uyaga mama. Tabia yako na yangu haisikilizane. Tabia yako na yangu haisikilizane. Unaona unaona sasa we mama, unaona sasa we mama. Unapenda kuvaa, mimi sina pesa upati. Unapenda kuvaa, mimi sina pesa upati. Unapenda kula vizuri, mimi sina pesa upati. Unapenda kula vizuri, mimi sina pesa upati.
Nipe mali
sisoe,
niwe mtu nipate dawa ya pesa.
Nipe mali wacha nifunga, niwe mtu dhambi kwa Mungu Baba. Kama unipendi weye, wenelose mama. Kama unipendi weye, wenelose mama. Shauri yako, shauri yako, shauri yako, shauri yako, shauri yako, wenelose tena wangu. Siwezi kuwa mtu baba, dhambi kwa Mungu Baba. Siwezi kuwa mtu baba, dhambi kwa Mungu Baba. Wende lote tena wangu Chukuruka, 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 serebuka, 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 chukuruka, 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 chukuruka. Nipe mali, watanifunga jela mie. Niwe mtu dhambi kwa Mungu Baba. Nipe mali, watanifunga jela mie. Niwe mtu dhambi kwa Mungu Baba. Kama unipendi weye, wendelose mama. Kama unipendi weye, wendelose mama. Shauri yako, shauri yako, shauri yako, shauri yako, shauri yako, wendelote tena wangu. Siwezi kuwa mtu baba, dhambi kwa Mungu Baba. Siwezi kuwa mtu baba, dhambi kwa Mungu Baba. Yo, wendelote mama. 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 Yo.
Japo umeondoka, daima utasikika, milele utasifika kwa yako kazi. Sifa yako kuifika si rahisi kwa hakika, umetuachia mashaka, hili ni wazi. Mwenyezi Mungu akurehemu, mzee wetu marehemu, akuepushe na hukumu, akupe amani ya kudumu. Bila wewe basi mzee unikone, bila wewe rubasio mzee unikone, bila wewe rubasio mzee unikone, bila wewe rubasio mzee unikone. Kama ninga ulisikika mashariki mwa Afrika, wengineko tuna hakika twakupongeza. Wakati wa Mola umefika, wito wake umeuitika, tuacha twasikitika, twaomboleza. Mwenyezi Mungu akurehemu, mzee wetu marehemu, akuepushe na hukumu, akupe amani ya kudumu. Bila wewe rubasio mzee unikone, bila wewe rubasio mzee unikone, bila wewe rubasio mzee unikone, wewe rubasio mzee unikone. Wewe rubasio mzee unikone, wewe rubasio mzee unikone, wewe rubasio mzee unikone, wewe rubasio. Mama Colola, 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 Mama Colola, Colola, Emedodo, Emedodo, Changani, Emedodo, Emedodo, Changani, Wabuba, Masoe, uwe wangu Wabuba, Masoe, uwe wangu Colo, Colola, Mama Colola, Colola, Colo, Colola, Mama Colola, Colola, Emedodo, Emedodo, Imelala Changani, Emedodo, Emedodo, Imelala Changani, Wabuba, Masoe, uwe wangu wa milele. Wabuba, Masoe, uwe wangu wa milele. Wabuba,
mazoea, uwe wangu wa milele. Wahuba na mazoea, uwe wangu wa milele. Kweli ajali haikimiki, hasa ilipo Mola mwenyewe. Kweli ajali haikimiki, hasa ilipo Mola mwenyewe. Ni chombo imara chenye thamani kilichopasishwa Uingerezani, ilinguruma ligoni likatiririka, wale pasenja wakapelea bahari. Dereva kombo, ngama zako zimekwisha, kwetu Mombasa jirani wasikuachirika. Tuliona hivyo, kwaheri. Tuliona hivyo, kwaheri. Tuliona hivyo, tuliona hivyo, kwaheri. Nilitoka kwako juzi nikitaka kukusamehe, amio alinijibu mwenzio hayuko katoka. Kamuuliza kenda wapi, akasema hajui pema. Nilipita vichochoroni nakukuta ukinywa changa, umekwisha potea, umekwisha potea. Wapotea mtoto mzuri kwa kunywa changa, umekwisha potea, umekwisha potea. Wapotea mtoto mzuri kwa kunywa changa. Nilitoka kwako juzi nikitaka kukusamehe, mamio alinijibu mwenzio hayuko katoka. Kamuuliza nenda wapi, akasema hajui pema. Nikipita vichochoroni na kukuta ukinywa changa, umekwisha potea, umekwisha potea. Wapotea mtoto mzuri kwa kunywa changa, umekwisha potea, umekwisha potea. Wapotea mtoto mzuri kwa kunywa changa, umekwisha potea, umekwisha potea. Wapotea mtoto mzuri kwa kunywa changa, umekwisha potea, umekwisha potea. Wapotea mtoto mzuri kwa kunywa changa. Chini kukuna machozi, hadi kule kokotoni, moyo kufanya majezi, ni kukosa fortuni. Siku za pita, sina usingizi, sina furaha moyoni, kwa nilivyokuzoea, kwa nilivyokuzoea, kwa nilivyokuzoea. Chirikuwa yako rangi ilivyonijia moyoni, nikenda mbali sishindi kukuacha pweke tunduni. Siku za pita sina usingizi, sina furaha moyoni, nakumbuka mazoea, nakumbuka mazoea, nakumbuka mazoea, nakumbuka mazoea, nakumbuka mazoea, nakumbuka mazoea. Kolola, mama kolola, kolola, mama kolola, kolola. Embedodo, 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 chambani, uba, zoea, uwe wangu wa milele. Waruba, amazoea, uwe wangu wa milele. Waruba, amazoea.
Sasa nimeshatubu ewe wangu, nimeabudiwa na wazee wetu, yaisha nitokigundua siku zile nimeshaamua mimi nikiache vidogo nisije. Sasa nimeshatubu ewe wangu, nimeamuliwa na wazee wetu, kisha nilichokigundua siku zile ili nikiache vidogo nisije. Sasa nimeshatubu ewe wangu, sitaweza tena. Tumeamuliwa na wazee wetu, yamekwisha. Nilichokigundua siku zile mwenyewe nimeshaamua, ili niache ulimwenguni nisije nikajuta. Sawa, usikiliza thamani ya mapenzi nikusikiliza. Na mimi leo ndio mwisho wangu, niliyotenda kwako kweli yanatosha. Yote hayo niliyoyafanya hayakukuzi wewe, samahani sana mpenzi wangu. Sawa, usikiliza thamani ya mapenzi nikusikiliza. Na mimi leo ndio mwisho wako, niliyotenda kwako kweli yanatosha. Yote hayo niliyoyafanya hayakukuzi wewe, samahani sana mpenzi wangu. Sawa, usikiliza thamani ya mapenzi nikusikiliza. Na mimi leo ndio mwisho wako, niliyotenda kwako kweli yanatosha. Yote hayo niliyoyafanya hayakukuzi wewe, samahani sana mpenzi wangu. In the house. Kusikiliza thamani ya mapenzi, kusikiliza mimi leo ndio mshoto niliyotenda kwako Eliana. Yote hayo niliyoyafanya na kukuona wewe, samahani sana mpenzi wako. 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 Samahani sana mpenzi wako.
Thank you.
Hebu kipenzi nisikize.
Kutokana na teknolojia inavyokuwa, ninaiona picha mbele kwamba tunakoelekea sasa tunaenda kuzuri zaidi, kwa sababu wa upatikanaji wa wataalamu wa vifaa tiba umesaidia kwa asilimia kubwa sana kutatua hizi changamoto nyingi ambazo zilikuwa zinajitokeza kwenye hospitali na mpaka kuonekana kama hospitali za serikali hazifanyi kazi. Kwa majina naitwa Dennis Faustini Musiba, ni mtaalamu wa vifaa tiba. Kabla ya ujio wa biomedical engineer na technician katika kada ya afya, walikuwa hospitali nyingi zilikuwa zinatumia mafundi wa mtaani, local fundi, katika kufanya matengenezo ya vifaa tiba. Na challenge kubwa ambayo ilikuwa inatokea kwa hao mafundi, kwa sababu hawakuwa na ujuzi wa vifaa tiba, vifaa vingi vilikuwa vinafikia mahali vinatoa majibu ambayo sio sahihi, na ikapelekea tatizo la wagonjwa wengi kupewa ugonjwa ambao walikuwa hawana.
Kabla ya hapo unakuta kifaa kinatupwa kwa sababu tu switch imekataa kuwaka. Yaani imeingia tu vumbi, unawasha ile switch imegoma, inatupwa pembeni, wananunua kingine. Hadi pale wameshapunguza nini? Wameshaongeza budget kwa sababu kilikuwa tu ni kusafisha ile switch na kuiwasha ikiendelea kufanya kazi.
HTM, or what we call it health technology management, is an important aspect of the health system building block. So that's deal with the technology and also biomedical engineering field as a whole. Basically, through the mandate that we were given, that we were able to do a pilot to strengthening this area. In terms of what are the gaps existing in the management of technology. So after that realization, therefore we came to devise these interventions.
Serikali ilikuwa inatumia gharama nyingi kuwekeza katika vifaa vya kutolea huduma za matibabu kuliko
We learned that there was also a huge gap in terms of the manning level or the staff available for maintenance and repair. But also very importantly, there were no working settings where the technician and engineer could do their work. For example, there were very few workshops around, but again, the workshops were not well equipped to be able to perform the expected activities and the output.
Hapa kwanza kulikuwa hakuna workshop. HPSS pia waliwezesha kutoa mchango kwenye hilo jengo hapo tunaloliona la karakana. Hili lilikuwa jiko, walituwezesha tukatengeneza kama unavyoliona na vitu vingine vilivyopo ndani humo na samani zile. Tukawa na karakana.
Na kuanzia hapo unaona kuna angalau kuna maendeleo ya vifaa tiba, kidogo tunapata vifaa tiba ambavyo viko vizuri.
Mvumi Institute is the only institution who provide this biomedical engineer, technician. Also, HPSS project has done a lot to our institution by renovating the infrastructure, including classroom and workshop, and also equipped the workshop with learning and teaching material in the workshop.
Tulipokuwa kule Mvumi, tulijifunza vifaa tiba aina mbalimbali. Tunapotaka kutengeneza kifaa fulani, tunapata mafunzo kwa ajili ya kutengeneza na kukijua zaidi kifaa kinafanya kazi gani.
HPSS in this intervention involve government at all levels to plan and devise interventions that will help to strengthening the health technology management. Through that approach, we were able to develop systems which were owned by the health system. This is a digital format system that capture all information of the biomedical equipment in their location, where they are available or installed, their function status, whether they are due to do for plant preventive and maintenance. So we piloted that together for almost 8 years. And thereafter it has informed
the process in the government to develop what we call it MAMIS. In a long form, we call it Medical Equipment and Infrastructure Management Information System.
Mfumo huu umetusaidia sisi wataalamu wa vifaa tiba kwa maana ya kwamba katika mfumo kwanza kuna sehemu ya kuweka lifespan ya kifaa, lakini pia mfumo unatunza rekodi ya kila kitu ambacho umekifanya kwenye kile kifaa. Kwa hiyo kama umekifanyia matengenezo kwa mara ya kwanza, umefanya mara ya pili, mara ya tatu, na ukaona kabisa hii kifaa sasa hivi kimefikia hatua za mwisho, maana yake ni beyond repair. Kwa hiyo una uwezo wa kukitolea maelezo kwamba hii kifaa sasa hivi hakifai, kimechoka, kiweze kununuliwa kifaa kingine.
MAMIS ni mfumo wa kielektroniki ambao inaweza kusaidia katika hatua mbalimbali za management, ngazi ya mtumiaji, ngazi ya utawala katika kufanya maamuzi. Kwanza ni unatusaidia kuelekeza vituo mbalimbali vya kutoa huduma za afya nchini kufanya budget katika mahitaji halisi ya huduma za matengenezo. Hapo nyuma hakukuwa na budget kabisa katika huduma za matengenezo, na haikuwepo kwa sababu hakukuwa na wataalamu. Pili, hakukuwa na taarifa zozote kujua nini kiko wapi, kinahitaji nini katika mzunguko mzima wa mwaka wa matumizi.
Indeed, there are quite a number of issues that still need to be looked into. At the moment, we are building new, more workshops in the region of Arusha, Iringa, and Shinyanga. So again, to expand this kind of services to reach many more regions. Furthermore, everyone at management level need to get a good understanding. Why should we invest in technology management?
Kutokana na teknolojia inavyokuwa kwa sasa, ninaiona picha ya mbele kwamba tunakoelekea sasa tunaenda kuzuri zaidi, kwa sababu wa upatikanaji wa wataalamu wa vifaa tiba umesaidia kwa asilimia kubwa sana kutatua hizi changamoto nyingi ambazo zilikuwa zinajitokeza kwenye hospitali na mpaka kuonekana kama hospitali za serikali hazifanyi kazi. Kwa majina naitwa Dennis Faustini Musiba, ni mtaalamu wa vifaa tiba. Kabla ya ujio wa biomedical engineer na technician katika kada ya afya,
naomba tuwahimize watu chini wapande juu.
Zilikuwa zinatumia mafundi wa mtaani
Tusaidiane kuwahimiza watu kurudi huko.
Matengenezo ya vifaa.
Secretariat, naomba tuhimizane watu warudi juu. Henry, kaka Henry, naomba nisaidie kuikumbusha secretariat kuwahimiza watu kupanda huku juu. Wakubwa, wazee, turudi tena katika ukumbi. Naona ukumbi umepwaya sana. Tafadhali wale ambao wako nyuma sana wasogee mbele kidogo, ili sisi wachache tukikaa pamoja tutaonekana wengi tu. Kama moyo haudanganyiki, acha tuyadanganye macho. Okay, so we postponed the was it health promotion? Yeah, we postponed the health promotion discussion. We just had the keynote speaker concluded his presentation, and then it was the time for the panelists to start discussion. So we resume with that quickly. I call upon everybody to really observe time, otherwise hatutaweza kufanikiwa. Kila mtu aongee kwa si zaidi ya dakika 2, mko watano. Kwa hiyo nadhani mnaweza mkatumia dakika 10, alafu tukapata maswali matatu, tukitumia dakika 10 zingine in the next 20 minutes tukimaliza hii kitu.
So welcome back to our session. I hope everybody enjoyed. We enjoyed our lunch, and now we are back into business. The presentation given by Mr. Eric Kebi covered explaining how HPSS project has facilitated the PRH roles. We know PRH is mainly concerned with the supervision and the coordination. So to what extent has HPSS project facilitated or helped PRH in fulfilling its role with regard to health promotion activities?
Okay, thank you very much. Good afternoon again, everyone. Okay, health promotion within the Tanzanian health sector is well addressed within the health policies and the different policy documents, including the guidelines. It's part and the parcel of different programs which are implemented within the country. And to mention a few, for example, when you talk about for example, strategic national health strategic plan, it has the component which is responsible for health promotion. And also in terms, for example, in sanitation and hygiene, there is a component also for health promotion. So what actually was HPSS doing is to shift from the beginning the way of delivering these health promotion initiatives. As previously it was like we are designing more about the health education to the people. So it's all like top-down interventions. So after actually working on our, those consideration and our tower chapter, that now what was required is to engage the community so as they can identify their needs on the particular, what are the particular problems, and actually what are the solution which are existing within the communities. So the HPSS through the training actually which was done through collaboration with the UDOM. So it was just introduced different approaches for health promotion. So by doing that, we capacitated the regions and the LGAs in terms of conducting health promotion by involving the communities, identifying their needs. As we know, in the community there are different people have different needs, and also there are different vulnerabilities. So as you can have people like having access to particular health services, you need to address them. So the easiest way is to see how you are engaging those communities. And for example, in this era where different countries are experiencing pandemics and epidemics, so those pandemics, when they go now to the community, you try to design the intervention from top to down. Some of the intervention become very difficult to be consumed by the communities. But through this community engagement, that like through approach like PRI, that participatory approach, then you can be able to know what are actually the needs, what the community solution are available for these problems. Then you can go and design with collaboration with them those interventions that they fit different social cultural issues which are existing within the communities and the different actually needs. So this is actually what health promotion in a nutshell have been helped. In terms of PRH, how it has been helped in its role of supervision and the coordination. So as the modality of implementation of health promotion, which we are cooperating with the HPSS, so a little bit different, because in the previously what actually we are doing was actually we are monitoring project based or we say intervention based health promotion intervention. We are doing supervision in those particular areas. But now in terms of when we discussed about how we can strengthen the systems. When I talk the systems, I mean for health in the region and the LGI, talking about RHMTs and the CHMTs, and actually how we are going to engage other departments within different sectors which are found within LGAs. So we developed the supervision checklist of monitoring the system for implementation of health promotion within the country. And actually this checklist is looking on mainly 4 areas. The area number 1 was looking on governance, to see the governance and the leadership of health promotion within LGAs and the RIs, and to identify these roles very clearly so as we can do some of the coordination of these activities. Is like, for example, when I say like coordination, the governance of health promotion within RHMT and the CHMT is, you know, when you want to address health promotion intervention, someone, so you will be touching one of the program or project of certain coordination. Like I want to design some intervention under HIV, but in the CHMT or RHMT, there's the HIV coordinator there. So we assisted now to see on how we can have like joint action plan within the region and the CHMTs that collect all health promotion intervention to be pulled together and implemented accordingly with the policies which are available. And another thing, it is capacity building. for successful implementation of health promotion intervention, you need also to build the capacity. As you know, it's one of the pillar for pillar or the building block of the 6 building blocks that human resource for health. So you have to build the capacity. So health space assisted us to build the capacity from understanding and how they can monitor those intervention. So in the nutshell, that is how we actually cooperated in the course of those years in terms of capacitating and strengthening the monitoring, supervision, and the coordination of health promotion intervention at PORAG. Thank you.
Thank you very much. And I think, we can see that both at the point that the implementation of health promotion is being integrated, and the tools for monitoring the coordination and supervision of health promotion activities has been mentioned, has been developed and in application at the PORAG level. I think this is a good development. And just one follow-up question: is this tool assessment or some follow-up based on?
Yeah, the tool actually, it is accessible, and we are using it. But among the way forward, actually, we wanted to digitize that tool. Which,
yes.
But it is available, and we are using it, and it is really informing. And it helps also to rank the regions and LGAs in terms of implementation. As I have said, that the areas actually we look, there are 4. I mentioned only one, but the one governance and the leadership. The second one is on issues around coordination of health promotion intervention, and there are issues around the planning and the budgeting. And actually, this tool was looking if there is a planning which is conducted for health promotion intervention within the council, because we're looking at the system, and we are looking also the expenditures. The planning, we are looking on the budgeting, we are looking if there are sources from the central, and as well as if there are LGA own sources which funds are allocated for health promotion intervention. And also we are looking on health promotion at healthcare facilities, at community, as well as at schools. And in the community, we are looking, the innovation which was established through HPSS is to have joint action plan between the healthcare facilities and the school which are surrounding that are being served by that health facility within the catchment area. So this was helping actually to ensure that periodically within the plan, the health facility staff go to the school, they provide health education regarding to different prevention of diseases, regarding to reproductive and the child health, also regarding to nutrition, and also doing some screening of diseases. And when they screen, there were also some students which were found with certain disease conditions, which were referred to the healthcare facilities for more treatments. And actually, this is where now I can see that like the program was linking within those 4 interventions which the program was dealing. So now those which were found with certain medical condition, they are supposed to go to healthcare facilities. But from that point, it's now where we are linking issues of access to healthcare facilities. Now, when ICHF was linked also to that part. So this is how actually, as innovation, which we work with the HPSS in this area. Thank you, Moderator.
Okay, thank you very much. Maybe another round of applause to the Manion. Now, I think he covered most of my follow-up question. Just see, maybe a follow-up question to HPSS. As you know, that health promotion is one of the pillars in health service delivery, and having 12 years of implementation, experience of 12 years implementation. What is your views on health promotion services or activities or implementation in general with regard to Tanzania? An opinion?
Mashukuru again. Well, I think at the policy level and the implementation level, there are still work to be done. I noticed there are a lot of fragmentations when it's come to development of policy and policy objectives, or when they do a strategy. As we are talking, the government is embarking in a very large scale community health workers. The program is very good, but I think it's lacking the basic principle of health promotion and disease prevention. It's focusing more on a service delivery, like a curative, the first line services and that. So that duplicate the work that we are going to do at the facilities, because that would have worked very fine in the past where we had very few health facilities. But now we have many dispensaries, many health centers. I think the focus should be on preventive and promotive services, of which the community health worker could be trained on and they can deliver that. That was the principal origin of having the community health worker, but it's now being deviated to another line. On the other end, in terms of investment, we are investing very heavily in the curative services and forgetting the promotive and preventive services. Of course, medical prevention is given very high priority. A lot of vaccination campaigns are done, prophylaxis are given, but the promotive area still need to give ample support and investment by the government, because without that, the burden of disease can get reduced, because at the moment, most of the diseases that are treated at the facility are avoidable and preventable, but are not addressed on the promotive way and prevention in a manner that people could develop skill and prevent from getting infection and the likes. So that's a call to the government and also development partners to look into that direction in order to enhance the preventive and promotive services. Asante.
Yeah, another follow-up question. Looking at the HPSS framework, what attributes does the HPSS project have in strengthening health promotion practices? Maybe we can speak a little bit.
I think at the very first, we were given a mandate to implement pilots. So we started with community engagement, empowerment processes, linking the community and facilities, so our schools and facilities. So over the period of time, we learned that the system, health promotion by itself is also a system. It's not just a subset of a system. So that need to be looked to a system perspective. So you can address all the challenges that I said with a tool that we to innovate. As human capacity for health promotion, availability of the human resource for health promotion, different other aspects, for example, budgeting, training, community engagement and empowerment, and several other ends. So we have to look at it as a system, not as an intervention or a plan. Asante.
Maybe to Mr. Kari Limo, if you look at all the spectrums of health promotion, do you consider the efforts of the project to strengthening health promotion have impacted the communities on how they respond to the health concerns?
Yes, thank you very much.
To be brief, because I've been.
Yes, first of all, let's just remind everybody to know what is health promotion. That health promotion is a comprehensive participatory concept that empower individual to control of their health, and it is cost-effective means for addressing community health problem. It is very unfortunate for a long time. Health promotion have never given adequate attention in terms of budgeting, in terms of skilling and capacity. I used to work in Morogoro for more than 15 years, loving health promotion, but I didn't have any contributing resources to make sure health promotion will take place. By the time I came to Dodoma, I was wondering to find the Dodoma with the HPSS supporting health promotion. Big hand for them, please. Clap the hand for HPSS. One of the important things which we learned, first of all, for HPSS, out of what we used to know the generic way of top-down approach, but here we started by very, very tangible issue of HPSS managing RHMT and CHMT to integrate effective health promotion to CCHPs. Big hand for that. This means that in the CCHP, before we integrate that one, we review what was there. We found a lot of calamities. Some people just write the health promotion activity is buying a printer. Another one write health promotion activity for the CCHP is purchasing drug for schizophreniasis. So that's end. But by integrating health promotion to the CCHP, it was a great achievement as entry point. Second one, HPSS managed to strengthen and advocate community participation at grassroots level. This includes the assessment of problem using community themselves, prioritizing the problem using community themselves, community developing their own plan of action. And here I just remember in Mpopa, when we have a cholera epidemic, we remember many years ago, we usually have, every year we usually have epidemic of cholera. But we used only 2 weeks to make sure we stop cholera epidemic in Mpopa by community participation. When they managed to develop their own plan and they monitor themselves and see the outcome. Also, what was the Mpopa? I think it was the issue of behavior. In Mpopa, they didn't like to utilize what is called the water guards. But within two weeks also, every household managed to put water guard to the house. And then that was a very good experience from there. Another thing is increase access to the health facilities and include access to the basic healthy infrastructures, like toilets, hand washing, and so forth. Up to now, in 2019, we had 30% of the household with the basic toilets. But to date, we have 95% with basic toilet. And we have also more than 57 improved toilets. Only, unfortunate, at hand washing, we have a bit negative because we have about only 37%. This is due to the fact that we had a tool which were not effective, that one known as a tip-tap, but now it's no longer working. From this juncture, we need to think about having alternative hand washing parameters. How about achievement? The achievement, in short, I think we need to say that the HPSS did a wonderful job. And today, since 2019, we don't have any cholera epidemic in Dodoma. Again, we have yes, you can clap head for that. We have the increased sense of ownership of the achieved intervention. If a household managed to construct, let's say, toilet themselves, they didn't have a toilet, they have the toilet now, they're practicing the hand washing, and then that is sustainable for today until, it's sustainable forever. We cannot change it, it is there to stay. And then we have the issue of way forward. It is still not adequate. The integration of the health promotion to our CCHP needed to be continued, and the best practice which was obtained from the community initiative maybe needed to be replicated countrywide to all regions of Tanzania. Thank you very much for that few remarks.
Yeah, thank you very much. And now I move to Ms. Beatrice Tito. HPSS supported the establishment of the National Call Center, which in Swahili we call Afya Call Center. Can you tell us a little bit about it and speak a little bit about the results of that initiative?
Well, thank you very much. First of all,
Let it be known that the operation of Afya Call Center has been a great achievement to the Ministry of Health, and these achievements have been a result of 20 efforts between the Ministry. Yes, these achievements have been the results of joint efforts between the Ministry of Health and the HPSS in establishment of the Afya Call Center. Afya Call Center was established in 2020, and its establishment was influenced by the outbreak of COVID-19 in 2019. The aim was to provide education to the community on COVID-19, but also to respond on community concerns, to reduce the community panicking, but also to receive the alerts on the people who showed some symptoms, whereby these people were being followed by healthcare workers, but also the aim was to respond or to give accurate information on the misinformations which raised at that time of the outbreak. So since that time to date, the Afya Call Center has been responding to various health issues, and these including pandemic diseases, communicable and non-communicable diseases, reproductive health services, but also nutrition issues, mental health, and the health insurance fund. Since its establishment, the Afya Call Center have been able to receive about 45,689,124 calls. Yes, whereby the vision is to expand the services by increasing other channels of communication, and these including the SMS and also using social networks so as to reach each group in the community, especially the people with disabilities who currently cannot reach us through phone calls services. Therefore, the Ministry of Health have been able to conduct various health promotion interventions through information acquired at Afya Call Center, especially in improvements of provision of health services in health facilities and other service delivery points. But also the community has benefited from the services provided by Afya Call Center in protection, taking precautions of various health diseases, outbreaks, but also testimonies on health behavior change have been provided by the community. And these including observing balanced diets on nutrition issues, but also identifying the importance of visiting health facilities whenever they face any health problems. Therefore, on behalf of the Ministry of Health, through health promotion section, we would like to appreciate the support which have been provided by the HPSS, the Swiss Embassy in establishment of the Afya Call Center. Since today we can stand and be proud of sensitization in the community on health issues, and we have seen the improvement of health issues through the call centers, whereby the community has been receiving education and they provide feedback on the change. Having said so, we really appreciate your support. Thank you very much.
Thank you very much, Beatrice. We go straight to Dr. Karume. I think you've been implementing under the HPSS, the school project, yeah? So can you tell us, please tell us the results of this intervention.
Okay, thank you. We have been implementing the school oral health program. First of all, we all know that most of the oral health conditions are preventable, but to our setting, the risk priority have been given, and this interfere a lot. But we also know that the poor oral health hygiene may link it to other diseases like heart diseases, cancer, and even diabetes. So before coming of this program of HPSS, the serious shortage of the staff, and also there is limited facility providing oral health. So with the coming of the health promotion program with the support from HPSS, we sat down, we arranged for the activities to support and to promote the oral health in the district. As the result, we planned for school health program where we are screening for the oral diseases and also giving the health education to the primary school children or pupils. And as the results, we improve the services and the utilization have been raised. I mean, for the case of the numbers, but also we train the lower facilities cadres to identify early identification of the oral diseases so that they can refer to the facilities. But we create supportive environment by teaching the school children how to properly to brush their teeth, but by using the brush sticks, miswaki ya miti, so that it can be affordable for them. So that's all.
Thank you very much. Yeah, maybe a last question, the more of a concluding question, back to Mr. Selemani Yondu. I mean, from here going forward, what are the government plan and the strategies to further strengthening health promotion and the financing part of it?
Okay, thank you very much. As far as health promotion now is concerned, and the evidences of its effectiveness in different intervention, including these global health emergencies which have been happened, and the role health promotion have played, particularly in prevention and in providing the response, and how the community are supposed to be engaged. Actually, this now have come as a priority. Number one is like now, for example, even in those committees for responding to the emergencies, now there is a specific independent committee which is on health promotion and risk communication. It is there within the Ministry of Health, and it is cascaded within the region and the LGAs. So now is to prioritize issues, prioritize the planning and budgeting. And another priority is to ensure now that we are collaborating more with partners and engaging also the private sector, particularly for assisting in health promotive commodities, which are supposed to be available within the communities. And another is to ensure now, like we are setting at the government, specifically proportion of budget health that will be allocated for health promotion because of its role now it is playing. So those are the way forward, and see on how also we can review our strategic, our government frameworks, and see how we can accommodate in a comprehensive way, and ensure also we are continuing with the capacity building of the healthy workforce, so that they can deliver in a professional way the health promotion interventions. So those are the way forward actually we are looking for now at the governments. Thank you.
Yeah. Thank you very much. Because of the shortage of time, I think yeah, we have covered most of the questions, and maybe if I can just see, give just a brief summary on some of the key issues that we managed to capture, just in summary. The first speaker emphasized on the issue that I noted, that there is a commitment at the ministry level, the policy level, to kind of integrate health promotion in the policy and the strategic plans, and at the POLH, as the implementing and coordinating and the supervision arm of the Ministry of Health. There is also integration of the monitoring tool in order to kind of follow up all the interventions that, or the implementation of the policies that have been outlined at the ministry level. And so they have a tool, and I think the presenter mentioned about the plan to put it even online, and so it will be easy to monitor and follow up such interventions. And lessons from HPSS, if you look at the health promotion in the country, I think there is notable fragmentation. If you look at the policy level and the supervisory level, so there is still some fragmentation that I think as a country we needed to improve. And we talked about the National Call Center from Beatrice to the ministry. I think this is one good example of a project that reaches directly to the people, and I think maybe it needs more marketing, and kind of we can diversify it to address more and more challenges. And I think this is it's one of the output that we get from HPSS. And Karume, speaking of oral health, I think there is good progress, and we have a framework now from HPSS on how to implement oral health in schools, and the outcome, I think, he already mentioned about the outcomes, and I think there is some progress, even though I think there is a lot to be desired in this area. And lastly, Mr. Seleman has mentioned a number of issues that will ensure continued implementation of health promotion activities, picking from where HPSS has left. So the ministry is prioritizing health promotion now in its budgeting and its plans, and inviting more partners for collaboration, involvement of the health sector. I think this will be a good initiative, because the health sector also goes to the local level, and seeing that the budget also addresses meaningfully health promotion activities. With this few summary or comments or lessons, let me thank the panelists, and I thank you all for your attention. And I think maybe we can have one round of applause to the panel members, and then I'll give to the MC.
Thank you.
Proceed.
Asanteni sana jamani, mtusamehe kwamba tumewarash kidogo, lakini it was for a good reason. Asanteni sana. I always say that health promotion should start, lakini katika mpangilio wetu, when we talk of different health services, health promotion comes the last in the list. But to be honest, is one of the most important thing. Nilikuwa nazungumza juzi Zanzibar. Zanzibar is also now introducing health financing, health insurance, since revolutionary of the mapinduzi ya Zanzibar wanaita. In 1964, Zanzibar has been providing 100% free health care for its population, but wameanza kuona kwamba it's impossible. The population increases, the epidemiological pattern of population health is changing, and things are getting tough. Sasa moja kati ya vitu ambavyo tuliwashauri ni kwamba when they are going into health insurance, I think the health insurance firm needed to invest heavily on prevention, and that needs to support health promotion, particularly the preventive component. hatujagundua tu, lakini tukiprevent tunaokoa hela nyingi kuliko curative. We are using quite a lot of money to treat people especially in chronic long term illnesses, kwa sababu hatufanyii kazi sana kwenye health promotion. Kwa hiyo nadhani umuhimu wa health promotion katika nchi yetu ni mkubwa, and we thank very much the project for investing heavily on that area, and we hope that the government is going to sustain, as we have heard from some of the panelists who are coming from the government, who are representing the government, to keep firm commitment that this is going to stay. Sasa ninaomba tumalizie kundi la mwisho katika panel discussion, and I'm going to give them a challenge. I'm going to offer 10,000 to everybody who is going to spend 2 minutes. Nataka hii group ya mwisho ifanye kwa 25 minutes. Marcos Mzero, you are going to be the moderator. If you can manage moderation in 25 minutes and make sure that we finish your panel discussion, you will be awarded 20,000. And every panelist is going to be awarded 10,000 if they can stay within the time. As a team, if you are 5 panelists and the moderator is the 6th person, then I'm offering, how much is that? 70,000, is it? Okay, this is your commitment. You fail, you miss it. This is a challenge. Karibu. You introduce yourself. I'm not going to read your bio. It's too long for the challenge.
I don't know, this afternoon. Good afternoon. Yes, we can manage, I think. Yeah, and I don't need to introduce myself more because we don't have enough time. But my bio is long because I have a good experience. So he's my classmate. So let me call upon I have 2 presenters and 3 panelists. Let me call upon Mr. Dr. Jiri Nemec, please. Mr. Jiri, by education, is a mathematician and information expert, more than 30 years of experience in health insurance and health informatics. He worked in many countries like China, Indonesia, Nepal, Malawi, and he has been working with HPSS since 2011 up to now. The next presenter, Mr. Nicholas Simon Kanisa. Mr. Kanisa, please. He's an IT system analyst from HPSS, holds a Master of Science in Information System from University of Greenwich, London. He's a certified network engineer. Before joining HPSS, he was working with Ministry of Health. He's one of the people who managed to design and implement the AFIA call center that was supported by the HPSS. Surely his contribution into IMIS domain will be remembered for many years to come. I would like to also call some 3 panelists. Mr. Jackson Stanley Shayo, Senior ICT Officer from Ministry of Health, with more than 10 years of experience in digital health, mostly working with Ministry of Health and the government system. He's an information technology expert, obtaining his education within the country. Also, I'd like to call Mr. Hamis Mahmoud from PORAG, experienced IT specialist from PORAG, with the same experience working in health and financial system, including system administration and management with IMIS and GOTHOMIS. Karibuni sana. It's an honor and a privilege to be part of this historic closer workshop, especially to moderate this digital health session. I would like to start with Mr. Jiri Nemec presentation. Oh, sorry, the third one, sorry. I forgot the third panelist as we are coming up from here. Ishengoma Paul, IT expert and database administrator from HPSS, please. Go ahead. Mr. Ishengoma, please, if you don't mind.
So, good afternoon, maybe good evening, ladies and gentlemen. I have the pleasure to tell you something about the development of IMIS system, Insurance Management Information System. What was the history? What were the principles? And what was its destiny? So I will have only 3 points, not too much. Genesis of NIS, of IMIs, special and hidden objectives of IMIS, and platform and connectivity of IMIS. Let's go to genesis of IMS. The history began in 2011 when Manfred hired me sometimes in March 2011 and said to me that he expects from me that he will have on the table working system for enrollment of injuries and underwriting of policies by the start of this year's summer's harvest. Yeah. Okay. 3 months for it, no problem. Funny thing is that he really got it. Yeah. And what was very important that the system that was started, with really the real IMIS, with all leading principles, and with a remarkable portion of functionalities that was available at this time, and still this code or this functionality is working here, yeah, from 2011. General objectives for IMIS are not surprising. It should be web-based software supporting standard operation, internal standard operation of a health insurance office or health insurance generally. It should support enrollment of injuries, underwriting of and renewal of insurance policy, tracking of payment of contributions for insurance policies, submitting an evaluation of claims for provided health care to injuries, of course, and remuneration of healthcare facility for provided health care. Okay, nothing surprising, but there are thousands of such systems throughout the world. But what's important? The systems, fixed systems inside health insurance agencies or companies that very closely keep to the current status of their scheme and are not marketable. They usually, in most cases, serve only to internal purposes of corresponding health insurance agency. But we wanted something more. We have some special objectives that were addressing needs of health insurance in CHF system in Tanzania. Firstly, several CHF funds should be supported from one installation, from one system infrastructure, for example, PORALC data center. So if you have 20 CHF funds, for example, we used to have 7 districts for the beginning, you have just one installation that runs on one server. All these CHF funds are served by this one installation. But the system should allow independent operations of CHFs that are associated in IMIs with territorial units, with regions, districts, or even with state. So you can define for each region, for each district, individual independent CHF fund, and within IMIS, you can support our operation separately, without interference or negative interference from others. Nobody, if he or she is not allowed, can poke nose to the business of one separate CHF. This feature is ensured by a bit sophisticated system of assignment access rules to users. So you can define either 7 district CHFs, you can define 3 regional CHFs as used to be in HPSS 2. You can define 26 regional CHS as is the case for HPSS 3. No problem. But the independence is not absolute one. Firstly, each CHF within the system can benefit from common data that are common for all. For example, list of services, list of medical services, list of medical items that are used for insurance, list of territorial units. This is very important, that work that has been done once cannot be repeated for all. And what's very important feature is this feature that allows portability of benefits. Although data of each CHF are protected against interference with others, there is one case when it's possible. If you are insured, for example, in Dodoma CHF fund, you should be allowed to take care, for example, in Morogoro, a hospital. But Morogoro Hospital is served by Morogoro CHF fund. In IMIS system, it's very easy. Simply, when such patients from Dodoma comes to the Morogoro Hospital can get from IMIS whether this patient is insured or not. It can also look at the extent of insurance, and if the treatment is ready, a claim is sent to Morogoro directly to its native Morogoro CHF fund. The CHF fund just enters the claim, and automatically the claim is proceeded or transferred to the Dodoma CHF fund, out of which money should be paid. This is done completely automatic, without any movement of any paper forms. It's very reliable mechanism. So it's an exception to to absolute independence of CHF fund in IMIS system. Also, IMIS system enables to some defined extent to control all CHF funds from a center, some center, for example in Porag, that can define its own roles that are only for this center, that for example monitor what happens in all CHF funds. But it's a defined process. Everybody knows that there is such role, such user that can look at, for example, balance sheet of individual CHF fund from some central level. So the IMIS generally is well prepared by this feature to some extent hierarchical system of CHF fund and controlling bodies. It was inspired by Tanzanian case. Yeah. Second special objective. Each CHF fund should be allowed, and it was a requirement, to offer several types of insurance. For example, some basic insurance and some supplementary insurance above it. And this requirement has led to the principal notion of insurance product in IMS, that it's key entity. Insurance product is a union of contribution rates and rules for payment of them, benefit package associated with insurance product, and cost containment measures, and the remuneration mechanism, for example, capitation, relative pricing, and so on. And what's very important, insurance product is holder of pooling. So money, so each claim, each contribution that belongs to the insurance product is gathered within this insurance product, and this money are used as a pool for paying healthcare within this insurance product. One CHF can have 1, 2, 3, 5 insurance product, and this is a very powerful tool in IMIS. The third one, say special objectives. Third set is that IMIS, although it's a web-based system that generally allows entering and manipulating of data from the websites, should also, beside it, allow more flexibility of enrollment and claim submission in the field. So besides the web-based application, there are two mobile phone applications based on Android that can run in online mode, directly connected to the system, on offline mode, when the data are transferred, when it's possible, for example, when internet is available in a given place. And these applications are used by enrollment officers in the field, in villages, for taking photo, for taking basic data on insurance, for certifying payment of contributions or for payment generally, and for renewals policies. So it's some toolbox for them that are rather complete and that allows rather independent operations of enrollment officers in the field. The same relates to the claim submission for health facilities, for example, the dispensaries, health centers. They have available application, mobile application on smartphone, by means of which they can easily submit claims to the IMIS system without any paper forms. So these are some three sets of objectives that are a bit distinguishing IMIS from other systems. There was one hidden objective of IMIS. When a new requirement came, it was done in such a way, implemented in such a way, not just as it was defined, but looking at the flexibility and future expectation, how this requirement may evolve. For example, when came from Cameroon requirement that they have some fixed enrollment, they don't enroll insurers in any case, but in specific dates during the year. The natural generalization was that IMS generally allowed the definition of several such dates during year. Even in Cameroon, we use only 2. So just generations of requirements, and their implementation was done on every step.
Jiri, you have 2 minutes. 2 minutes.
What was the result? That IMS appeared to be rather marketable. It quite easily was transferred to Nepal with just only adjustment of one feature, widely easily adjusted to Cameroon with again adjustment or adding several features, and all in other countries. This is very important. So openness of IMS and its flexibility and applicability in different environments. By the way, currently in Nepal, this image that is here has about 40 million of injuries in this database. So it's no toy. It's a real working system. Just the last slide that was developed using web-based technology ASP.NET, database technology Microsoft SQL. So this version of IMS is based on proprietary Microsoft platforms. Of course, there was mobile technology based on Android used to support enrollment and service provision. It can also be capable of to be interoperated with digital system, that's health management system, financial system, and education system, as it is already here with GPG for e-payment, with a payment portal here, with EGA for SMS sending to injuries, Cotomis, Afia Care, DIJust to end user for payment. So this is very important, this connectivity of the system, that is even realized that. I would acknowledge the role of the Dar es Salaam based company Exact that did for 80 years development of IMIS and de facto delivered the IMS in current status. And also I would acknowledge cooperation on thank for cooperation of Tanzanian IT experts engaged in the HPSS. Nicolas Ishengoma for HPSS 3, Gideon for HPSS 2, and 2 others that I don't remember names from HPSS 1. Without their help and without their ideas and proposals how to improve, how to enrich IMIS, the IMIS would be not in such a shape as it is now.
Thank you, Jiri. Jiri,
Thank you for your attention.
Thank you very much, Jiri. Thank you for your time. I would like to invite Mr. Simon Kanisa, please. Short and brief.
Thank you very much. I will be very brief because of the time, and I would love to get that 10,000 IMC talked about, and I would request him to give it to my project manager because this is the last presentation. Naogopa nikitoka kule tuanze kutafutana, kwa ampe kabisa project manager. Well, I'll be very brief because most of the things you know, we had an extensive discussion from yesterday and today, so most of the things you know is just a digital platform that support most of these intervention that most of the presenters talked about. So Mr. Jiri has presented about IMIS. I'm going to present other 2 major digital innovations that HPSS financially and technically supported. Well, we know that Tanzanian digital health strategy emphasizes the importance of applying digital technologies, and HPSS in line with that, also in most of its intervention, applied the digital innovations. And my presentation, I'm going to present on PIVMIS and MEMIS. We only know about Jazia, the prime vendor. Will not talk much about it, but simply it's just a system that complements the national supply chain in case of medical stockout at MSCD. So with that system, we've designed system that support Jazia business. How did it come about? Actually, rationale of developing this PIVMIS, because initially we had a manual operations, and this created difficult in terms of gathering, compiling, analyzing data. So we thought it's better to come up with a digital solution in order to support the Jazia system. Jazia technically has been designed, it's developed under GOTOMIS. For those who don't know what GOTOMIS is, it's a Government of Tanzania Hospital Management Information System. It's a system that supports all facility operations from the point where a patient enters the facility to the exit. And why did we choose to build this Jazia Prime Vendor on GOTOMIS? Because we believe it will be sustainable, because every time you go to, maybe you want to upgrade GOTOMIS, definitely you'll be able to upgrade the Jazia. So we thought it's better for it to be designed under GOTOMIS. Also, currently GOTOMIS is centralized the system, so it's easy to manage Jazia as well. The system has been integrated in with two other systems, and that is FAS. This is a Facility Financial Accounting and Reporting System. Also has been integrated with Logistic Management Information System, where we have different roles. We have different users, and they have different roles. One of the users is PEREG or TAMISEMI. For its roles is to host the PIVMIS and to ensure that the system is accessible and they do all the backup. Also, they are supposed to register all health commodities or the generic list. Also, they are responsible for upgrading and adding new features of the system. And they're also supposed to conduct all the training at all levels, and as well as monitoring the system. Also, we have users at the regional level. For them, what they're supposed to do is to upload all the supporting documents, including contract price, tender board approval, negotiation minutes, and also they're supposed to monitor the system. We also have a user at the council level. This is a council director. His role or her role is to approve and reject requisition, and also can view and monitor what is going on in the system. Also, we have head of department. Their role is to view the order and do the monitoring, just like others. We also have a council prime vendor coordinator. The role for him or for her is to approve or reject facility authorized order. Also, they can submit the order to prime vendor. They can inspect and receive delivered health commodities. They're able to see what is going on in the system, and they can do the monitoring as well, and as well view and export the reports for analysis and decision making. We also have health commodity stores in charge. The role for this person is to prepare and submit the order, inspect and receive delivered health commodities, and as well he can do the monitoring of what is going in the system. They can view status of the order, and also they can extract report and view. We have another system. They can view and process order, upload the receipts, issue out of stock notification for missed item, monitoring. Also, they can do the monitoring implementation. They can view reports and see what is going on also on the system. The functions of the system are as follows. You can do order creation in terms of stock out at MSD. So facility, they can create order. Also, the system can do order authorization. The system also has the function of order approval, as well as the orders can be inspected, and also when it's received, you can see the item has been received or not. So this is a function is also part of the system. Also, this system can allow to do attachment, because we need to see the proof of receipts and all that. It allows you as well to do attachment, proof of payment, copy of withholding tax, and other important document can be uploaded on the system. Also, it has a notification. When you register a user, you can get a notification that the certain user has been registered. If the order has been uploaded, you can see the order status and how it moves. It gives you delivery date. If the order has been created and the supplier has supplied it, you can see the order has been delivered as of when, and other information. And also you get notification when you request for the authorization and approval. Also, the system has reports for decision making and other use. We have various reports you can see there. We have a system report including order fill rate, item fill rate, value fill rate, delivery lead time, payment report, inspection report, vendor out of stock report, number of facility that ordered, and many other reports. So what have we achieved with this implementation of this system? Now we have timely availability of health commodities, and we have reduction of time for order creation and processing, reduction of audit queries. At least we have uniform and automated prices. Kwa hiyo hoja nyingi kidogo tunazipunguza with this system kwa sababu we have uniform and automated prices. And also it has improved the monitoring of prime vendor system. So that was PIVMIS. Also, we have another intervention that HPSS supported. This is medical equipment and infrastructure management information system. I think the key presenters yesterday and today, they talked more about this. So this is a system, at the name itself suggests it's a medical equipment and infrastructure management information system. So it manages the equipment and the infrastructure within the facilities. MEMIS is a web-based, so anywhere that you have internet and any browser, Mozilla or any other browser, you can easily get access to this system. This system is under Ministry of Health. So this system enable health facility to manage medical equipment, spare part, consumables, and ensure that the infrastructure are up to date. So it manages the infrastructure and all other medical equipment. How did it come about? HPSS project conducted a situation analysis, and that situation analysis informed a number of problems, including there was no systematic approach to equipment maintenance. Also, we had another problem with preventative maintenance does not routine occur. We saw that. We also saw that the administration does not have a proper plan and budget for equipment maintenance. Also, facility, they tried to deal with the failures of the equipment as they occur, but there was a scarcity, a non-existence of a competent technician. So all these problems also led us to develop this system. What feature does the system have? One of it has inventory management, so we can see all the list of equipment within the system and within regional and the countrywide. So it helps us to see the inventory of the equipment. So it has that feature of inventory management. It has another feature of stock management. We get a notification. The function allows biomedic engineer and biomedic technician to add and approve a stock in the system, and it has two sub-modules, stock and request. If they want something to be maybe repaired and things like that, they can easily request, or if something is out of stock, they can as well use that feature. Also, the system has an infrastructure management feature. This allows biomedical engineer and technician to register infrastructure in the system. This could be water infrastructure, electricity, electrical infrastructure, and other infrastructure. It also has a feature of maintenance. If an equipment has a problem, so it's easy to log it in the system and know this equipment needs maintenance, and you can assign which engineer can go and fix the equipment. It also, like another system, it also has a reporting feature. It has various reports: inventory report, infrastructure maintenance report, equipment maintenance report, and stock management report. So how this system has helped us. Now we have inventory of all medical equipment for every health facility in the country. So you can easily access that report and see how many equipment you have. Also, the system has enabled the easy management of medical equipment and building infrastructure and tracing where the equipment are and things like that. The reporting function of the system facilitates decision making and user accountability. So with this system, we can at least track user accountability and make a decision. With the implementation of the system, the management can do forecasting and budgeting of the medical equipment and building infrastructure. And one of also of the results, so far to me it's a result, so we've seen that system has helped, and we've managed to cover at least 50% of the facility countrywide. Thank you for listening, and that's the end of my presentation, and I would like to submit. Thank you.
Thank you. Thank you, presenters. Now we are having a bit of a discussion, few questions from our panelists. We are trying to see what has happened into the health sector. And I'd like to start with Mr. Jackson Shayo from Ministry of Health. We are trying to see compliance here. They talked about complying to digital health strategy. We have seen several digital solutions being developed as part of the implementation of National Digital Strategy. How is it being achieved, and how have you collaborated with HPSS within this undertaking?
Thank you. Good afternoon. There are several documents which are sector. There are several documents which are guiding the sector in the area of digital innovations or digital solutions. These documents are National Digital Health Strategy, and the Tanzania Healthy Enterprise Architecture. So National Digital Health Strategy, this mention all priorities of digital solution which are supposed to be implemented in a specific period. And Tanzania Healthy Enterprise Architecture, this is a document to guide the process of planning, developing, designing, rollout, and maintaining the digital solution. So our implementing partner used this document as the path or the roadmap to know where to support in that specific period, to know which system or digital system are supposed to be developed in that period. So it is through several digital systems developed by in health sector, including MEMIS system. So MEMIS system show results, fruitful results by Ministry of Health collaborate with HPSS from the first time from designing stage to development stage. So the development of the system was fruitful because we, the government and HPSS project, have share the common goals. So HPSS help us a lot in terms of technical and financial support. Thank you.
Thank you. Thank you very much. And coming back to Mr. Amis Mahmoud from PRAG, I think you are the key player here. For you being a key player in the digital health ecosystem within the project, what do you think that has been attribution of HPSS projects in supporting your work, especially the work of CHF and IMIS?
Thank you. Thank you, moderator. Good evening, all. Well, of course, it's true that PRAG is a key player in digital health implementation. Yeah, for the past 12 years, we as PRAG, we have worked closely and collaboratively with HPSS. HPSS have been provided supportive to PRAG in implementation of digital transformation, particularly in digital health, in a number of ways, including but not limited to development of CHF IMIS and integrating it with other key systems. Not only that, but also HPSS has improved the ICT infrastructure and the hosting facility of the CHF system, CHF IMIS system. But also HPSS has provided a number of training, not only to ICT personnel, but also to non-ICT personnel. Also, HPSS team has working closely with PRAG to provide continuous support to system users. On top of that, HPSS has always been there to provide both technical and financial support to PRAG. Thank you.
Well, this looks very good. And Mr. Ishengoma, first of all, very sorry that it took time for me to introduce you, but I'm glad that you you stand up and came over here. But I have one very small question, but I think you have to come up very clean to us and very clear. We are trying to see the rationale here of the project. What is the rationale for the project support the development of these digital products, such as CHF IMIS? We are talking about MEMIS, we're talking about Jazia PVMIs. I know we have seen this presentation from Kanisa and Jiri. What is the rationale? Why?
Yeah, thank you for the question. Yeah, good evening once all. I think the question is good. Most of the point has been highlighted through Kanisa's presentation, but briefly, the general rationale of supporting the government to develop the digital solution was to see how to integrate the intervention of HPSS within the government digital health system. So we have seen since yesterday, we have some of the intervention that the project has implemented in collaboration with the government. So the project came up with the concept of digitizing the process within all the intervention that has been implemented under the project. So I think we all have seen since yesterday the results that the key player of this achievement is the support from HPSS, that we have managed to support the government to come up with the systems that are within the government priorities, and also all the systems are now operated by the government, but also they are fully integrated within the government IT policies. So the rationale was to make sure that all the business process for the intervention that are implemented by the project with the collaboration with the government are fully digitized. Because, or simply just to ensure they have a bit of data and the accuracy of the data, because we have seen some of the challenges that were highlighted since yesterday through before the implementation of the HPSS intervention, that there was a lack of timely availability of data and the likes. So the HPSS under the digitization component, so we came up with that concept of to make sure that we digitize each process within the intervention to make sure that all the intervention are fully integrated within the government digital health system. Also to comply with the framework of the digital health strategy. Thank you.
Thank you. Thank you very much. So I'm trying to see from Mr. Shayo, from Minister of Health and PRI, Mr. Mahmoud. Yeah. We're trying to see the benefits. What are the outcomes? What have we realized so far that from the integration of solution of CHFS, IMIS, with GoToMIS, Afya Care, MUSE, and GEPG? What benefits have we realized so far? What are the outcomes? What can we go out and say we are proud that this has happened? Mr. Shayo, please, to start with. And
Thank you,
Mr. Mahmoud
moderator.
will follow.
First of all, IMS is integrated with Afya Care. Afya Care is the electronic medical records which is used in regional level. Is the electronic medical record which is used in regional hospital, regional referral hospital. So this integration with the IMIS helps a lot in e-claiming. So now the submission or claim submission are submitted electronically. Before this, this process was done manually, so it consumed a lot of time. So by saying that, this integration IMS with Afya Care make a lot make it job easy for the healthcare provider. Thank you.
Mr. Mahmoud.
Thank you. Yes, it's true. And it is, as you know, that the direction of the government is to have sustainable and integrated systems. As for CHF IMIS, now it is integrated with GOTOMIS, GPG, and MUSE. To start the integration between CHF IMIS and GPG is to ensure that membership fee are collected electronically. Before the IMIS, the collection was done manually. Nowadays, all collection of the membership fee are collected via government payment bus, which is the GPG. Second, there is the integration between CHF IMIS and GOTOMIS. The motive behind this integration is to allow automatic or electronic submission of the claim from the CHF IMIS to GOTOMIS. So if a person attends at the facility, there is no need for him or for her to fill a manual claim submission form. That was the motive behind the integration of GOTOMIS and CHF. And last, the integration between CHF and MUSE is to enable electronic reimbursement of the collection of the claim, so that they can be paid to the facility to proceed with other expenditure and commodity. On top of that, the benefit of the integration is one, to increase or to improve the accuracy of data, as data can be entered into one system and shared across the multiple systems. Thank you.
Oh, thank you. I have two last questions to probably both of you. Sorry, I'm trying to figure out what are the benefits between from the Ministry of Health and PRAG. It's my understanding when we started with the HPSS project, we were singing sustainability through capacity building, sustainability through capacity building. Let me ask you one thing. How have the government ministries, especially I'm talking about PRAG and Ministry of Health, has benefited from this approach? And do you see yourself that you have necessary knowledge and skill sets to support use of the system, maintain and developing new features? Start with Mr. Mahmoud yourself first.
No, thank you. Okay, with reference to the skill set and knowledge acquired through the training provided to us by the support of HPSS, we are now confident and capable of managing the CHF system efficiently and effective, to ensure smooth running of the system, as well as to ensure sustainability of the effort sustainability of the effort HPSS has put on it. Thank you.
Mr. Shai, do you think you have do you think the same? Or you want to add something?
Yeah, to add on top of that, through HPSS support, we undergo several training capacity building. Truly, this helps us a lot. We are capacitated well, and because we develop the system, MEMIS system by collaborative ways. So our technical expert developer are able to upgrade the system and to maintain the system and to add a new feature in the system. Thank you.
Oh, thank you. So everything looks very, very good. It looks like HPSS have done almost everything by the books. My last question to you, Mr. Mahmoud. How extensive this CHF IMIS? Now you have the skills, you have the knowledge. How extensive this CHF IMIS has been deployed and applied in the country? If you look in the future, maybe, where would you position CHF IMIS? It's two questions, but you can.
Okay. Currently, CHF IMIS is deployed all over the country in Tanzania mainland. Yeah, with reference to the knowledge and skills acquired, we see as PRAG that the CHF IMIS is a great step towards achieving the universal health coverage in the country. That's what we see CHF IMIS to us. Thank you.
Thank you. So, Mr. Shayo, I'm not trying to ask you the same question, but it looks like the same. But we understand that we have heard from the prior presenters about the HTM digital solution. So I'm trying to see about the MEMIS now. What is the future prospect of this platform? Because, you know, they're talking about CHF IMIS now is countrywide. What about MEMIS? What's the future?
Thank you, moderator, for the good question. The MEMIS system is there to serve the purpose for the health sector. So we as the government, Ministry of Health, we will be implementing or upgrading the system to serve the purpose. We are still developing the system because it is used in a lot of facility countrywide. So we are also receive the requirements which we are going to upgrade the system. So this is what we are going to do, and also we still need your support, HPSS support. Still, the government need your support. So we are welcome you to support in terms of technology, innovation, and any idea. Thank you.
Thank you very much. We have come to the end of our session. We would love to have questions and answers based on the time. Can I give you a very few brief about what happened today? We've had Mr. Jiri, as a founder for web-based software, which is IMIS. He was looking at opportunity of independence operation of the product. He was tasked to come up with a system that is centralized to save costs. The issue about multiple packages and monitoring, digitalize the process, minimize human errors, record keeping. We had Mr. Simon Kanisa, talking about Jazia, talk about MEMIS. And I think as we are coming to a closure, it looks like we didn't have enough, but it was enough at the moment. We are looking forward to have something that can come back and add up on our next journey. We heard Mr. Kanisa talking about managing equipment and assets, inventory, maintenance. When Mr. Shaw was commenting about compliance, he talked about the ministry preparing some documents and guiding documents for the implementation and development. When we talk about, we asked Mr. Mahmoud, he talked about their supports they are getting from HPSS on a technical, financial. HPSS worked on improving the infrastructure at PRAG. They did training. we saw that there's evidence from both ministries that the technology that was supported by HPSS helped them to improve the claiming by having e-claiming, which saves times, improve compliance. They integrated with the government payment system for members to submit their payment through electronically, e-claims, improvement of GoToMe. So we had enough, and we wish we could have more, but as the time expired for the project, we are more happy, glad, and we wish this technical expert can continue. Thank you very much. Back to you, Mr. Seller.
Thank you. We now allow you to go back to your chairs. Thank you. We are almost there. We're almost there. There'll be no other session. According to the program, the next session was supposed to be hearing from the research community based on their experience on empirical evidence that has been generated, linked to the recorded achievement and all the results that the project has shared with us for the last 2 days. But unfortunately, 2 of the presenters were not informed early enough to prepare anything. One is here, but with the time we have discussed with him, we shall skip that. And we have recommended that we are going to communicate the presentation via email or other channels so that nothing is lost. He has spent time to prepare some content for us to share. We can still benefit from looking at it on our own times after we have completely closed here. So thank you everybody for your time. I don't know what should I do to cheer you up. Can I see smiles? It has been a long day today, but believe me, although it looks like our program did not go according to time, we did not waste a lot of time. Yesterday, we had 4 hours lost. The program today was supposed to end at 16 hours, and it is ending at 17 hours. So it's just a loss of 1 hour. It means that we have been able to recover 3 hours of the 4 hours that we lost yesterday. Clap hands for yourself. Yeah. So it's not very bad. And to make sure that you are going home happy, please join us at a cocktail party downstairs where the car park is for this hotel. We are going to start the cocktail party at 6 p.m., just a few minutes from now. So hang around, join us. There's a lot to enjoy and catch up and networking and everything. And that will mark the real celebration here for the ceremonial closure of the project. Thank you very much for trusting me to be your msema chochote for the 2 days. I'm usually joking, but kama nimekutania sana ukakasirika, naomba unisamehe. It was with good intention, and I'm looking forward to many other invitations in your other occasions. I don't do weddings. I only do official things like this. So ukiwa na kazi kama hii na nini, I can come. Don't worry about the budget. I sometimes do it pro bono. Ili mradi jina langu litaendelea kutangazwa. I'm looking for a place in the paradise tomorrow. So I give charity. Asanteni sana. Naomba nirudishe kwa secretariat kama mna tangazo lolote lingine. Ali, otherwise naomba tuwakaribishe watu kwenye cocktail party pale chini baadaye. Ali, tafadhali. Asante sana jamani. Makofi machache kwa mimi.
Makofi mengi sana kwa Selemani. Paka akiwa anakaa. Sasa sijui anaenda kukaa wapi. Thank you very much, Suleiman, for the wonderful work that you have done for us to facilitate this meeting for 2 days. That has involved a lot of preparation. And I would like also to extend on behalf of the project management, I hope Manfred, you would agree, to appreciate the engagement and involvement of our project employees on preparing this event and for supporting it, facilitating the different undertakings that have been during these last 2 days. I would like also to appreciate and acknowledge your participation, your commitment, engagement, and willingness to share your own views and opinion on how this project has been successfully and what areas still need to be taken by government in terms of analyzing it further and to see how best it could be continuing on the implementation of the innovations. We also our thanks goes to the panelists who accepted to participate in the panel discussion. Without you, perhaps this session would have been very different and would have not been very engaging and live as it is now, similarly to the moderator of these sessions. We thank you very much. Asanteni sana, Mwenyezi Mungu awabariki. Lakini tunasema asanteni sana kwa ushirikiano wa miaka 12. We have 12 years of implementation. This project would have never gone beyond phase 1 if we would have been without your support. Dr. Chaula, we can't find another way to say thank you. We thank you very much for your commitment, guidance, and leadership that you have provided to this project. We thank you very much. So is to our mom, Dr. We are calling you Doctor today, Mama Lema Madenge, as well as the RAS here and the other region. She has been very instrumental in supporting this project. She's soft-spoken, but focused, and she got authority. We benefited from those qualities of hers in the first 4 years and of the phase 1 and the second 2 years of phase 2. It has been very, very good for us to have her as our chairperson for the advisory board, which she managed it very well. And here we are today. We are celebrating. We are looking forward to provide further exchange in the different capacities. Asanteni sana. Maybe Manfred, you want to say something or later at the party? Please, Khalid. Asanteni sana. Tukutane pale chini kwa ajili ya kusipu na kunyanyua grasi tuweze kushangilia kwa pamoja. Asanteni sana.